physiology, not just the vitals. So SVC flow anything less than 40 ml per kg per day, 40 ml per kg per minute indicates a low perfusion status. It helps in decision making. And PDA shunt physiology, either right to left shunt or left to right shunt, helps us to guide in choosing the inotropes. And LV function or RV function directs the fluid decisions, and IVC collapsibility guides us the true physiology in giving whether to give bolus or not. So to summarize, normal blood pressure, heart rate, CRT, saturation, as described, as we discussed in many of the scenarios, can hide shock. Heart rate respond immediately. It's a very sensitive vital sign, but very widely non-specific, affected by various other parameters, as I told. Temperature, CRT are very good, but they are environmentally sensitive, depending upon the ambient temperature and skin temperature. BP and urine output reacts very slowly. It takes at least 4 to 6 hours to predict shock. And saturation, interpret only after confirming the probe position and the pleth waveform. And the fluid bolus for tachycardia without ruling out PDA may prove harmful. And above all, always do not rely on one single parameter. Always integrate the clinical examination, echo, lactate trends, NIRS, urine output, everything to comprehensively put together to understand the physiology, not just one parameter and treating based on that parameter alone. Never rely on a single vital. Always understand the physiology. Thank you.
Thank you, Dr. Vaidishwaran, for your wonderful lucid talk. And through so many interesting clinical scenarios, you showed us how just a single vital sign can misguide us, and thus combining all the vital parameters and along with thorough clinical examination and going with functional echo and new technologies like NIRS, we can manage babies more comprehensively. Thank you.
Thank you.
Now I would like to request Dr. Sarvesh sir to give a moment to Dr. M. Vaidishwaran sir. Next talk is about resuscitation devices. Are we using them right? By Dr. Surinder Singh Bish sir. And to chair the session, we have Dr. Ashish Bhakta sir. So I would like to request Dr. Ashish Bhakta sir to come to the dais. ఇది ఒకసారి రారా Sir, now I would like to request Dr. Ashish Bhakta sir to introduce Dr. Surendra sir. Thank you.
Good morning. So today's next session is on resuscitation devices. Are you using them right? And it will be delivered by Dr. Surendra Singh. And please, Dr. Surendra Singh, please come to the dais and deliver your talk.
Good morning, everyone. Hi. Good. So this is a good attendance early in the day, and I'm happy that there are people to listen to it. And we are talking about resuscitation devices. Are we using them correctly? Yeah. So. Yeah, where do we use resuscitation devices? Certainly, it helps in fetal lung fluid clearance. It establishes the early functional residual capacity. It achieves some effective oxygenation. And our priority in cases is to establish positive pressure ventilation. And we must know the technique also. These are some of the points which are required. So as you know, this pyramid, most of the babies do just require base assessment and basic care. Some need stimulation and some need basic resuscitation and some need advanced resuscitation. So for this basic and advanced resuscitation, these are babies where we need these devices. And this is certainly very much required for the majority of babies who would be revived in the labor room. In this study by Wall, this was shown that if a facility-based newborn resuscitation has been done correctly, it can avert 30% of intrapartum related neonatal death. So this is important. And the same study showed that about half of the facilities with resuscitation equipment do not have did not have providers skilled in resuscitation. So that was the thing which was missing. It is not just the machine, the infrastructure was there, but the people did not know it. And again, this is something there is an inadequate supply of skilled birth attendants, and there's a low coverage of facility birth in certain areas. Certainly, in this was more for African countries as well. That impeded the use of resuscitation equipment. What makes resuscitation difficult is the most important thing is to have a good face mask seal. Sometimes the person is left alone and he has to do multitask. Whether he's able to control the pressure which is being to be delivered, there is some unreliable suction, PEEP, and oxygen regulation in this. So what is required to have good positive pressure ventilation is a skill. A skill is available, and our conventional approach is to train people to improve their skill. सिखाओ और सिखाओ, train करो और थोड़ा better करो, थोड़ा और chest rise करो. This is what we tell them. Or we can have devices which requires less of a skill, which have better seal, which can provide better delivery of tidal volumes. So both ways it can be done. And the studies showed that holding the mask by two hands actually reduced the face mask leakage by 50%. And the right, I think whether you are able to see the slides or not, most of the masks are rounded with a rim, some are triangular, and this is the soft flexible masks are better because the leakage can be lesser. The firmer elastic ones can lead to more leakage. The mask must be of the right size, covering from the chin, mouth, and the tip of the nose, and proper sizing actually prevents the leaks and the discomfort as well. And the shape, obviously the soft flexible is important, and the technique of use is more important than merely the shape of the mask. So in this study by Corley, And there was a leakage. In fact, you look at the leakage done by, or the study, they actually put a mask there and they had a flow sensor near, objectively they were trying to measure the objective leak, and there the leakage by the consultant, in fact, the we'll see that the consultants had a good leak around 65% or so, with and this was with one with a two different kind of mask, one with Fisher Paykel, one with Ledel mask 0 and 1. Fisher Paykel had a kind of a different mask. Uh, so the leakage was substantially, almost all, more than 50%, in whether it was by the consultant, fellows, registrars also had this. In fact, what I always feel in my personal training also, nurses and midwives, they do better than doctors in all the places. So when I train a consultant, with when I train a nurse, I always find nurses are gentler. Even sometimes even the OBG persons who have never done it before, they do better positive pressure ventilation with lesser of a leakage. And the way how you are holding it is also important. If I can show in there's a mouse, it will work. No, it will not work here. So can I have a pointer option here? No. Yeah. Can I? Yeah. So yeah. So these are the registrars, nurses, midwives. Obviously, leakage is there, but the confidence interval was lesser. And if when you are holding it, whether from the stem, just holding the stem, I should have a mask. Just holding from the stem, the leakage was so much because you are not making a good seal. You're just holding from the stem. And if you are holding it from the 2-point hold, which is my favorite, if you hold it like this, from the 2-point, and then make a seal, this actually led to lesser leak. And this was the rim hold. When people hold it like a C, it deforms the mask, it leads to good amount of leakage, though it is still covering from merely holding it from the stem, just very lightly keeping it on the face, like this, will lead to a lot of leakage. Holding it from a C also will lead to equal leakage. Holding it from a 2-point top down will be a better thing. And then there are with the different one with Fisher Paykel, and other was a ladle one also. So this is the stem hold. When there is only, it is being held like very loosely from the top. This is the 2-point hold when you're holding near the stem, the base of the stem, but putting some pressures. So this is the 2-point top, because your 2 points are there, and but from the top. And this is the okay rim hold. There is 2 rim hold. There's one rim hold, and there's one rim hold with a pressure, but holding it very tightly will also obstruct the place, and there would be no flow of air which will go there. So 2-hand techniques, really, if you are using 2 hands, it will really minimize the leak. Equal downward pressure on the top of the mask from both index finger and thumb, with good jaw lift, using 2 hands. Too much of jaw lift extension is also bad, but little jaw can be good, because it is traditionally thing. Though there are not much studies to tell which is the best angle when you can have it, the best. So resuscitators estimates the leak. So we see, as we are trained neonatologists, we are trained pediatrician, we have been doing resuscitation for so long, and they said, what we hear a hissing sound. I said, iska leak ho raha hai, iska leak nahi ho raha. There are some where they are leaking or not leaking. So perceived will come to that. How accurate is their assessment of leakage, and there can be a difference in this. And mannequin and infant study shows wide discrepancies. So sometimes they are able to do it in mannequins, but when they are really doing on the babies, there were studies which showed that the delivered tidal volumes were different. And training traditionally uses mannequins, but when they are doing it on babies, there can be different performance. So the newer courses, when you have a QCPR kind of a baby from Ledel, which tells you what is the tidal volume which is getting delivered. These are better mannequins than the mannequins which we are currently using, the low fidelity mannequins which we are using. And this is the graph which was shown on 20 babies. and it showed that the number one person who was doing the resuscitation felt he had only 20% leakage. But look at the leakage, which was around 60% with a wide interquartile range. And the other person, again, there was always a difference between these bars are what he said, how much leakage. This person said, I have zero leakage. But yes, this guy was doing it well. There was no sound, there was no leakage from the top also, because once the the popper wall opens, you cannot measure the tidal volume, because there is a leak which is going up, and what is getting delivered you don't know. So anybody who's having the top pop going all the time probably is not delivering the tidal volume which is required in that case. So this person said he has zero leakage, but yes, there was a leakage which was again around 15-16%. And others, imagine others were actually far away from what they perceived was the leakage. And if you're looking at the tidal volumes which are getting delivered with the pressure, because the popper wall opens by 30 to 40 centimeter of water, and somebody who's actually trying to give that of a PIP, and the tidal volumes can vary from 2010, though the tidal volume should be around 8 ml maximum. This bar is 8 ml per kg. It can go up to 30-40 ml per kg. So much of tidal volume can be delivered to a baby, which can be harmful. So this is irrespective of the resuscitator also. More with bag and mask, but it can be with TP's resuscitator as well. So, and there would be instances when there would be a airway blockage also. The tongue may fall back, and the neck position can be too much or too flexed or too extended. Then it can be there, and the mask size position and all these. This can be this, and people have used expired CO2 detector to measure the effectiveness. So LMA, laryngeal mask airways. Yeah, this is a small inflatable silicone device placed without laryngoscope, and there is a lobby, or you can say there is a voice coming up from all parts of the world, especially where either you teach the people how to do the skill correctly to save babies, or you provide something, a new machine, some new innovations to provide the tidal volume you really want to save babies. So LMA is a good option, and it has a seal around the laryngeal inlet, easier to place than the endotracheal tube. And there can be still leaks at the pressures which we are using, the neonatal pressures which we are using, and the smallest size is not good enough for a preterm baby. So that is there. And success in term and moderately preterm babies, the LMAs which are currently available can be used. So those with PEEP and CPAP, like the TP's resuscitator, or a flow inflating bag where you can have some PEEP at the end of the inspiration. So these are they facilitate functional residual capacity formation and improve oxygenation, which is logical to use devices. The bag and mask self-inflating bags can also have a PEEP valve over them. So there are companies which can provide a PEEP valve, which is available, which has a manometer which tell you how much is the pressure also which is being delivered with each PIP. So that those self-inflating bags are also available. And but the thing is, it depends on the flow which you are giving for a TP resuscitators. So if your flow changes, the PIP and the PEEP changes. So you have a TP resuscitator which is running at 8 liters with something which is running at 5 liters. The delivered PIP and the PEEP which you are just measuring, you are not just you're setting a PEEP, just imagining that you are actually giving a 5. It may not be giving 5. So that can be the case over there. So what we did how to make it easy. So this is a device some people must have seen. This is a foot operated resuscitator which was convenient, hassle-free, and easy to use and learn. Single, and there was a suction also attached to it, so multitasking could be done with this. And this was precisely controlled because studies were done. So we did a study on this in a randomized control trial in our place using this device, and with the self-inflating bag with a foot operated bag. which we did, and the objective was to compare the effectiveness. All babies more than 35 weeks were taken, and anybody with congenital malformation were not taken. We had a simple 220 ml bag versus a foot operated mask, and the primary outcome on basis was whether to see the increase in heart rate more than 100 after 30 seconds of positive pressure ventilation. It is so difficult to do a RCT for resuscitation. I imagine only when I did it, and the studies before me were done was quasi-randomized. Anup Thakur, which is so widely quoted, was a quasi-randomized. So I have done this randomization when the resuscitation was to be taken, and you are asking actually taking a consent before and opening the envelope only when a baby requires bag and mask ventilation. So it was very difficult to do this, and we were so many envelopes could not be used, and there was such a difficulty. We had to do it again and again sometimes. So the sample size was actually based on the previous studies, but just for convenience, we took a sample size of 60 because we were not able to, we were not very sure that we will be able to have 147 per group, which was a good number. And this is 30 in each group. And what we found, our primary outcome we were just looking at it, whether the foot operated was as good as self-inflating or not. So yes, the heart rate at 30 seconds and 60 seconds did not differ much in both the groups, but the time to spontaneous breathing was better. It was 61 mean vis-a-vis 114. This, though the median was same, but the interquartile range was quite different. 30 to 60 in foot operated versus 60 to 127. So the duration of PPV which was required was almost the same, though it was a lower in the foot operated this. So yeah, there was no significant difference, as I said, and obviously there was a time to establish spontaneous breathing, though this was not the primary outcome which was desired for the studies, and all of the parameters were just same. So it was not harmful, it was not doing something bad, it was really helping. So this something which can ensure a better leak, better mask seal, certainly with two fingers can be certainly be used. So obviously, currently we are using these two, and just to have I will use we know that self-inflating bags they do not require gas source. They can deliver positive pressure ventilation reliably, though there is no PEEP, even unless you use a PEEP valve, and there is a variable delivered tidal volume with each pressures. Somebody who's trying to empty the whole bag may deliver very high tidal volumes or may not deliver tidal volume at all also. Okay, because the popper valve will open and everything will go up on the sky.
Sir, your time is up.
Yeah, yes. So I'll just so there is a gap between which is very bag and mask, which is low efficacy. It is the skill needs to be taught. That is why we need to have more and more and more of training each time. You need to have people doing that every time they are entering the labor room. Some bag and mask practice should be done. This is what we are telling them, but it is low cost. Whereas a TPS resuscitator is effective, convenient, though it is expensive. And this is the Visakhapatnam Health Technology Assessment done by Konar Institute of Health Technology, and it is very good because I got hold of it, and they did the big review of all the studies which were there on this, and obviously there was no difference. The three studies which they chose was one by Dawson from Melbourne, Royal Women. The other is Dr. Thakur's from India, Delhi, Gangaram, and Queensberg from Brazil. So in the two studies, there was no significant difference, though Thakur et al. Found that the median duration of PPV significantly was less with TPS resuscitator, but there was no significant difference in the intubation rate when using TPS resuscitator versus SIB. This Dr. Jagdish Sharma from Visakhapatnam has done this systematic review, and so these forest plots are something which is Vizag, has been made in Vizag only. Okay. So this is from Vizag only, but the mortality reduces by 40% when using ARD, though. So this was important. If you are using TPS resuscitator, in all these studies, when they did a pool analysis, the mortality was lesser with T-piece resuscitator. So all in all, if we need to use it for our preterm babies, so certainly this is a machine we would certainly urge you to use. But the cost, they did the cost effective cost analysis also. This is somewhere at that time when they did it in 2020, it was 49,500. I think the cost is certainly now going in lakhs, a lakh or so, whereas the SIBs, even with everything, the cost, the training, this will be 3,400 so as per the calculation they did. The labor cost, बिकॉज they even calculated कि नर्स को जो आएगी वो कितने मिनट लगा रही है, उसकी पूरे दिन की सैलरी से कितने मिनट की सैलरी निकाली है, और डॉक्टर the doctor who is coming, उसकी सैलरी कितने निकाली है. So imagine the T-piece resuscitator was costlier than a self-inflating bag. So 593 for the cost per neonate was used, if that was used. Yeah. So I think that is all for the day thing. Thanks.
Thank you. Thank you, Dr. Surinder, for your nice presentation. And one thing I would like to know from you, this leakage in fitting, whatever be the machine, be it a ventilator or CPAP, it happens. But how much of leakage is acceptable? Because what I see myself sometimes in the process of making it very much perfect, we may cause trauma to the skin of the newborn baby.
Yeah. So a good seal is certainly required, because certainly you should not have any leak. That if you really want to, but while you're trying not to have a leak, you try to deliver too much of pressures, and the tidal volumes, you can generate a higher tidal volumes. That is why using a machine where you can see the pressures, like a T-piece resuscitator, or now with the self-inflating bag, which has a manometer over there where you can regulate, or a foot operating this, which can show you a manometer how much pressure you are going. You're regulating the pressure, you're looking at the chest rise, something with just a visible rise, chest rise would be good enough. So leave aside the leak. Despite the leak, if you are having just a visible chest rise, it is good for me, because the delivered tidal volume is okay. But if you are having a doom kind of a chest rise, certainly this is which I don't want.
Thank you very much. Any question from the audience? I think no, and time is also up. So thank you, Dr. Surinder, for your nice presentation. Thank you very much.
Thank you so much, sir. Now I would like to request Dr. Ashish Bhakta, sir, to give a moment of appreciation to Dr. Surinder, sir. Thank you. The next session is by Dr. Junti Jandas, sterile by strategy, ANTT in the neonatal zone. So I would like to request Dr. Junti Jandas to chair. And for this session, I would like to request Dr. Ashish Bhakta, sir, to chair the session and introduce Dr. Junti Jandas. Thank you.
Profile.
Excuse me, can I have this
Good morning. Our next session will be presented by Dr. Junti Jan Das. She is a clinical instructor, College of Nursing, Army Hospital, and she is attached to NNF Life membership. And she has got major achievements like she got second prize in a poster competition in annual conference of Indian Society of Trauma and Acute Care in 2023. And she has got 4 publications also. So welcome, ma'am. Please give your presentation.
Thank you, sir. Myself, Major Junti. I'm a faculty in College of Nursing, as sir has told. So today's my topic is sterile by strategy, ANTT in the neonatal zone. So I'll start this topic with a quote. Precision saves lives on every battlefield, including the silent one we fight each day against infection in the NICU. So coming to the introduction, so ANTT prevents contamination by avoiding touch of key parts and key site, standardized NHS techniques, reducing healthcare associated infection using during IV therapy, cannulation, and medication preparation. It ensures that only uncontaminated equipment or sterile fluid come into susceptible or sterile body sites during clinical procedures. Example, administration of IV medication via peripheral cannula, removing sutures, stitches, and dressing coverings in sterile sites. So the Health and Social Care Act 2010 stipulates that ANTT should be carried out in a manner that maintains and promotes the principle of asepsis. All clinical staff undertaking procedures involving asepsis should be provided with education, training, and assessment. And the staff should be annually assessed on ANTT, including the 7 steps technique for hand hygiene. Coming to the definition of ANTT, ANTT, as we know, aseptic non-touch technique is the method used to maintain asepsis, protecting the patient from healthcare-associated infections and staff from contamination from the patient's body fluids, and blood. The core principles of ANTT is always clean hands effectively, never contaminated key parts, touch non-key parts with confidence, take appropriate infection prevention precaution. So what is the key parts? Key parts are those parts of equipment that if contaminated by infectious material, it increases the risk of infection. And not touching these parts either directly or indirectly is perhaps the single most important component of achieving asepsis. For example, wound care dressing pack equipment, IV infusion needles, syringe tips, exposed lumens, and cannula hubs. So coming to the hand hygiene, there are 7 steps to hand hygiene. First is rub hand palm to palm. This helps in disseminating the soap or the hand rub which we take to properly properly in the palm. And then the second step, we have to rub the back of the both hands. Then third step is palm to palm with finger interlaced. Fourth is back of fingers to opposing palm with fingers interlocked. Fifth step is rational rubbing of right thumb clasped in left palm and vice versa. Coming to the sixth step, it is rotational rubbing backward and forward with clasped fingers of left hand in right palm and vice versa. And the last step is wrap left hand over right wrist using rotational movements up to mid forearm and vice versa. So in alcohol hand rub technique, we have to use 2 to 3 pumps, which is equivalent to 3 to 5 ml of hand rub, which to adequately wet all the surfaces. Then we have to rub palms, dorsum, interdigital areas, thumbs, and fingertips, and allow it to completely air dry before touching the patient. It is not effective on visibly soiled or contaminated hands, then hand washing is must. Do not apply ABHR immediately after soap wash repeatedly, and the nail must be short. Artificial nails and nail polish are prohibited, and we have to remove moisturizer build-up with soap after every 5 to 10 applications of hand rub. Coming to the moments of hand washing, there are 5 moments of hand washing which is given by the WHO. First is before touching a patient. So before touching a patient, clean your hands before touching a patient when approaching him or her. And why we have to do it? To protect the patient against harmful germs carried on your hands. Second step is before clean aseptic procedure. So it is done to protect the patient against harmful germs, including the patient's own, from entering his or her body. The third moment is after body fluid exposure risk. It is to protect yourself and the healthcare environment from harmful patient germs. The fourth step is after touching a patient to protect yourself and the healthcare environment from harmful patient germ. And the last is after touching patient surroundings. It is to protect yourself and the healthcare environment from harmful patient germs. Coming to the PPE. PPE is the personal protective equipment such as gloves, aprons, provided it's provide as a barrier between the microorganisms on hands, clothing, and susceptible site. The glove must be worn for invasive procedures and when there is a contact with sterile sites, when there is a non-intact skin, mucous membrane, activities where a risk of exposure to blood, body fluids, excretion, and contaminated instrument can occur. When should we use non-sterile gloves? Whenever we are administering intravenous medication or there is a wound care, venipuncture or cannulation. Whereas sterile gloves is used for invasive procedures like urinary catheterization or central venous catheterization. Now coming to the NICU entry protocol, the first and foremost thing we have to remove our shoes, jewelry and roll up ourselves and mandatory hand hygiene at the entry for 1 minute and 20 to 30 seconds in between. And we have to wear a sterile gown before patient contact and maintain control, contamination-free zone. Coming to the visitor and parent policy, which we follow in our hospital, only parents are allowed, in which mother is allowed any time of the day, whereas father is allowed during key periods. Parents supervise for correct hand hygiene. They have been trained for hand hygiene whenever they enter the NICU and whenever they are going to touch their babies, and there is no entry with active respiratory or infectious illness. So coming to the preparation of environment, the staff must undertake few things before preparation of environment. First is the environment should be tidy and ensure that it is clean, and there should be limited personal entering. We have to ensure that the fan are turned off and the baby should be prepared for access, and always use clean trays or trolleys and disinfect before and after use of the trays and trolleys. Then coming to the procedure preparation, we have to first wash our hands, then apply hand gel, gather the label all equipment, wipe the tray and trolley, allow it to dry, and wear apron and non-sterile gloves. The gloves is decided according to the procedure, whether it should be a non-sterile or a sterile gloves. Coming to the preparation of medication, prepare the syringe ensuring key parts remain uncontaminated and use 2% chlorhexidine wipe for medication without leads, and return the syringe to packets after the preparation. Administration of medication. So we have to replace the gloves if contaminated en route to the patient, and if the port lacks Kurus cap, disinfect the cap for 30 seconds and let it air dry, and administer without touching the cannula port or the syringe tip. And after end of the procedure, we have to dispose the equipment as per the hospital policy, and we have to wipe the tray or trolley whichever we have used and remove the gloves and wash your hands again. The basic asepsis routine, which is the sterile gloves, first IV line insertion, intubation procedures, and the skin preparation is first is alcohol, then iodine, then again alcohol. After this 3 steps, we have to allow it to dry at each step. And we have to use minimal preparation area and strict no touch insertion. Coming to the antibiotic stewardship, we have to encourage the using of antibiotics only when it is indicated and avoid unnecessary broad spectrum use. And we have to also de-escalate based on culture results. Coming to the bundle approach for prevention of VAP, that is ventilator-associated pneumonia, first is hand hygiene before air manipulation, aseptic technique for suction, no routine senile installation, used only for tenacious secretion, maintain head elevation at 30 degrees, ensure adequate humidification, and use minimal enteral feed early, preferably express breast milk. Then prevention of CLABSI, maximal barrier precaution during line insertion, chlorhexidine or appropriate antiseptic skin preparation should be done and allow it to dry. Then daily review of the line is very much necessary, whether we have to see for the redness, swelling. Then proper hub care with scrub the hub technique before every access to be done. Aseptic handling and dressing should be changed. And we have to also avoid contamination by keeping the line ports crabbed, clean and dry. Coming to the good housekeeping, just we have to change the IV set daily, which we use in the NICU, and there should be no stock of IV fluids and avoid heparin flushes. Use sterile gauze to cover IV bottle pods. Write date of opening on syrups. Use within 1 week. Do not top up humidifier chambers. Replace fully and sterilize bottle chambers daily in 2% Sidex, that is for 4 to 6 hours, and avoid overcrowding, maintain spatial separation. And also, each baby must have separate stethoscope, tape measure and probes. Maintain the temperature of NICU 25 to 28 degrees centigrade with adequate ventilation. No dry dusting should be done, only wet cleaning with approved disinfectant should be followed. No storing of files, pen, x-rays on the baby's cot, and ensure 24 hours water and power supply in the NICU. Coming to the surveillance, periodic environmental screening for the pathogens should be done. Weekly, the warmer incubators, surface equipment swab should be sent, and twice weekly, humidifier water culture should be sent. The culture baby's body or CSF only when clinically indicated. Nasal, throat, hand swabs of staff whenever it is required, and antibiotic usage audit and resistant trend monitoring should be done. Coming to the hub care, there's cleaning and maintenance of catheter hub is very much necessary to prevent catheter-related bloodstream infection. We have to clamp the catheter if it is required and scrub the hub antiseptic for at least 15 to 30 seconds. And after the scrubbing, we have to allow it to air dry and then attach a sterile cap or connecting tubing to it. Family-centered care. So in family-centered care is encouraged for care of the baby. So we have to allow the parents holding the baby's hand, talking or singing to soothe, helping restrain gently if trained, observing procedures, learn about care and infection warning signs. They are not allowed to touch the sterile field, handling equipment, touching hub, catheter, dressing during the procedures. How does it benefit? It reduces the anxiety of the parents, and there is a better cooperation during procedures, and there is an improved understanding of the infection prevention, and it enhances trust and therapeutic relationship, and there is a better outcome due to shared responsibility in care. When the procedure ends, our responsibility doesn't. Every aseptic act strengthens the shield around newborn. Careful touch, one safe moment, one life at a time. Evidence guides us, strategy protects us, and ANTT ensures that no preventable infection stands between a newborn and survival. Thank you.
My salute to Major Junti.
Sir.
Thank you very much for nicely presenting,
Sir.
particularly infection control
Sir.
and antibiotic stewardship in neonatal units. Thank you very much for your nice
so much,
presentation.
sir. Thank you, sir.
Now I would like to request Dr. Ashish Bhakta sir to give moment of appreciation to you. There is no break for tea actually, so you can have your tea in your chairs. Tea is served at the back end. Thank you. And next topic is Golden Hour Silent Hero, Thermal Care in Preterm Survival by Dr. Mamata Jaju ma'am. To chair the session, we have Dr. M. Indrashekar Rao sir. To introduce Indrashekar Rao sir. Indrashekar Rao sir is a former professor of HOD and pediatrics Osmania Medical College, and he was also medical superintendent, Nilofer Hospital. He had a higher training in neonatology, University of Illinois, USA, and he was national vice president and chairman of IAP. He was a chairman of neonatology chapter IAP 2002 to 2006, and he was also a member of IAP, COI, and EB Central IAP several terms from 96 to 2010. He is a convener of ACVIP 2022 to 24. He has received multiple uh, awards from. He was also president of NNF AP State 2003 to 2005 and recipient of Fellowship of National Neonatology Forum Award for outstanding work in newborn care. He delivered NNF oration at National Conference Chennai 2012. He conducted several NRP and CMEs for neonatology all over the country. He's a key person in IAP NNF collaboration for neonatal care, and he was the first to establish indigenous CPAP in Nilofer Gandhi Hospital. Thank you. Now I would like to request IS Rao sir to introduce Dr. Mamta Jaju ma'am. Thank you.
Dr. Mamata Jaju. Please come.
So good morning, everyone. I'm Dr.
Small
Mamta Jaju.
Introduction. Before we
Yes,
start
thank you.
this important session of
So
the
good
golden
morning.
hour and the silent hero, I want to pay my salutation to the person who gave first steps of neonatology in India, my mentor and guru, Dr. Dharmapuri Vidyasagar. Please give an applause. He is in USA. Secondly, neonatology has gone up in leaps and bounds in last 30 years, encouraging people to innovate and do many new molecules and also interventions. It has also given opportunity for many youngsters to take neonatology as their specialty and also have established their professional livelihood. Friends, only thing is practicing newborn care is not a business opportunity. It's a lifetime professional opportunity. Learn, escalate, and perform for survival of the newborn. Over to Mamtaji.
Thank you, sir. Thank you. So good morning, everyone. So just a very important topic and a very catchy. This title has been given to this topic: the Golden Hour, Silent Hero, Thermal Care. So we all know that in preterm babies, the temperature monitoring and temperature maintenance is very important. And if we see for the this data, abnormal temperature, either hypothermia or hyperthermia, more of hypothermia is very common in preterm neonates, and it's the very first of the important cause of mortality and morbidity. Though the data we don't have, because what we see in data is just the tip of the iceberg, because most of the time we are not even monitoring the temperature of the neonate at the time of admission or when they came to the delivery room. So if we see the data, even the whatever prevalence is available, it is from 32% to 85%, varying in different setups. And even in the home, the baby goes into hypothermia as high as 92%. Mortality in hypothermic preterms is around 30 times more than the normal term baby because of their vulnerable conditions. There is 28% increase in neonatal mortality with each 1 degree fall in temperature. So this is very eye-opening that even the 1 degree temperature fall from 36.5 to 35 point, mortality rate increased to 28% in these babies. And fatality rate is, if it is mild hypothermia, is around 40%. Moderate hypothermia is 51% and severely hypothermic is 80%. So the most of the severely hypothermic neonates, when they are coming to your NICU, you see that the outcome is very, very bad in this because of the multi-system involvement, DIC and other and there are a lot of morbidities also in hypothermic babies. They have acidosis, hypoglycemia, neurological disabilities, then BPD, necrotizing enterocolitis, so many conditions that. So it is very, very important to prevent them from the hypothermia, but hyperthermia is also very common. So the very important topic, and as per the definition, if we go, so WHO has defined that any temperature below 36.5 is hypothermia in neonates. So 36.5 to 37.5 is normal. And then they have categorized as a mild, moderate, and the severe hypothermia. And hyperthermia is more than 37.5. So when we come to the certain points that why it is important to from hypothermia or why they are prone for hypothermia. So we know that preterms have the specific vulnerable group uh, uh, because they have a large body surface area, their head is very large, they have very thin skin, the insensible water losses are very, very high from their skin. It is as high as around 80% or 90% that can lead to. They have decreased ability for the thermogenesis. They can't do shivering or the produce heat. They have less amount of brown fat and the glycogen storage, and low sugar, surge of thyrotropin levels, greater likelihood of hypoxemia, and which can impair brown fat metabolism, poor vasomotor control, and lack of shipping. So there are so many factors which make them prone for the hypothermia. And if we see that why the how they are losing heat, so we know there are four mechanisms: the conduction, the convection, evaporation, and the radiation. So we if you see that whenever a newborn is born, the baby is wet coming from the mother's womb, the mother's womb temperature is high and suddenly baby is coming to the low temperature. So one thing is baby is wet because covered with amniotic fluid, so evaporation led, and when coming from the high temperature to the low temperature, baby is suddenly in the low temperature and loses heat by conduction. If the temperature of the delivery room is also low, then again it led to the problems and leading to the heat losses by the convection, or the if wet air currents are there, then also it will lose heat, and the radiation is another matter. So there are so many mechanisms by which baby is losing, so already prone for having the hypothermia, and then there are so many other conditions. If we'll not prevent them, then certainly the baby will go into hypothermia. So there are things which we need to remember while we are taking the baby in the delivery. So this one first golden hour, so once the baby is born till the baby is there or reaching to the NICU, we need to maintain a warm temperature or warm route that way. So there are few new evidences have come, so I'll go through them one by one. So first prevention is the pre-warm the delivery room and resuscitation area. So we all know that we need to keep the temperature of the delivery room at around 25 to 26 degrees centigrade. And there are many studies, RCTs, even the Cochrane review has come. The basic idea rationally is it reduces conductive heat losses and gives warm environment before baby hour. So there are large prospective studies which showed that hypothermic infants were more likely to have been exposed to a DR temperature of less than 25 degrees centigrade than to a higher temperature. And it is significantly, the odds ratio is very high for this. So you need to be very careful to maintain at least 25 to 26 degree temperature of the labor room. And the recommendation by the newer NRP guidelines also is very highly recommended for this. So whenever we are attending a delivery, make sure that there should be a thermometer in the delivery room and that temperature of the delivery room should be maintained. So first is this. The second intervention, if we go, so there are 2-3 meta-analysis and the Cochrane review has also come regarding this. So preheat the radiant warmer before birth. And they have also studied that we need to do either manual or the servo control mode. So again, they have seen the evidences. So there are many studies, and the rationale is ensures radiant warmth immediately upon birth resuscitation. So if the servo controlled mode only it has been used, if it has not been started on the manual mode, then the chances of hypothermia is more, and the mean body temperature was also high. And if we see the RR, it was 1.20. So the recommendation is to keep it on the manual mode and to maintain the temperature and warm the even the mattresses and the underlying uh, sheets also for the baby. Another exothermic mattresses, few mattresses now they have started coming where you can keep the baby warm by applying the it over the warmer, or keep them separately to take the baby. So though not routinely used in Indian circumstances, many centers are using, but the studies have been done, few in India also and separately in outside, many have been done. So this has been seen that though exothermic mattresses, if they have been used, they are very useful. But if that has been combined with other things, like other bundles for the prevention of hypothermia, then the chances of hyperthermia is very high. So we have to be very cautious while using the combined modes of warming the neonates. So hyperthermia is also as detrimental as hypothermia. So we should be careful that we should keep the baby warm, but not use too many devices to make the baby warm. So routine temperature monitoring is again very, very important. So this has to be seen. Then again, the very important intervention came, and which has been seen in many studies and with many combinations. So the polythene wrap is used, the simple polythene food polythene has been used, then the polythene with the head cover is used. So there are so many studies come, but in total gist I'll say that though it minimizes the evaporative losses and the convective losses, but this is definitely is a very good evidence and has to be used, and it decreases, led to 38% lower risk of hypothermia when immediately when baby is born, the preterm baby is born, the baby should be taken either in a plastic cover or in a food grade plastic, or wrapped in a cling wrap, which is commonly available in Indian setting. And the baby, if you see that it prevents the hypothermia, and the RR is 0.67. So only less than 30% are getting hypothermia and no effect on mod. But it is immediate effect for immediate after delivery and within 2 hours to prevent neonates from the hypothermia, but no prolonged effect or the effect on the mortality prevention, or there is no difference in the mortality in the two groups, it has been seen. But it is also highly recommended to use these bags, especially in the preterm neonates. So use place without prior drying is strongly recommended in very preterm neonates. Again, come to the exothermic mattresses, which I have discussed with the this also. So combined intervention should be used with the cautious. The only word I'll say with the exothermic mattresses. And the another thing is heated humidified respiratory gases during resuscitation should be used, but the heated humidified normally is not available in our setups. Even in the labor room, we are using the dry gases, which is causing more dryness and the hypothermia in neonates. If prolonged respiratory the newer NRP 2025 guidelines says if you need to have a prolonged resuscitation in a preterm neonates, then try to use a heated humidified high flow nasal cannula or the heated humidified oxygen or air in the neonates, because it prevents them from the hypothermia and drying. Very important next intervention, which is very feasible in our setting, and most of the centers, I feel that they have started using it, skin to skin contact immediately after birth. So it is very feasible in more than 32 weeks of neonates, but 28 to 32 weeks you have to be guarded. If the baby is stable, you can use it. So immediately putting the baby over the mother's abdomen, or starting with the kangaroo skin to skin contact in the delivery room and continuing it for at least 1 hour is a strong recommendation to prevent them from the hypothermia. And I feel that it is the most feasible in our situation, most cost effective, and there are so many other advantages of kangaroo mother care which we all know that it is how it is very effective. So skin-to-skin care remains a valid and effective measure for maintaining warmth in stable term, late preterm, especially when resuscitators or intensive warming not required. So now with the new guidelines, now they say that the initial resuscitation, initial steps, even a preterm neonate can be done over the mother's abdomen if the baby is requiring only drying, or the suctioning or stimulation. So initial steps of neonatal resuscitation, we can do it over mother's abdomen also. Next comes, so if we see it, the total recommendation which is given by the ALCO in the delivery room. So for preterm infants, the use of radiant warmers, plastic bags or wraps, increased room temperature, warmed, humidified, inspired gases separately or in combination can be effective in preventing hypothermia. So basically these form a bundles to prevent hypothermia in the delivery room in preterm during initial resuscitation. Then placing the infant over the skin to skin contact to maintain normothermia. Then who requires resuscitation, temperature controlling interventions like putting the baby under the warmer or on the manual mode is very effective. Then the newer guidelines also says that the skin probe should be attached to the baby, and the frequent temperature monitoring of the baby is required during resuscitation. Then exothermic mattresses are also very effective. It is used. Then various combination warming strategies or bundles may be reasonable to prevent hypothermia, but we have to be very careful because whenever you are using bundles, the chances of hypothermia is very high. Okay, so this is bundle which I have already told you that we can use individually also or we can use in combined, because we know that all bundles individually also are the evidence-based practices, but they are not as effective as when we use them combinedly. So to summarize, in the delivery room, hyperthermia risk is high when we are using bundles, especially with the mattresses. Temperature monitoring is very, very important whenever we are using or the bundles or multiple. Then we should be prepared. Coordination and preparedness is required for the warm room, pre-warmed equipment, ready supplies. So whenever we are going delivery room, we should be ready with all these things. And method. And as I said that NICUs are available where mother and babies are together. So in the neonatal intensive care, if the baby is on CPAP or so they are together in the NICU, mother is also lying, the bed is also there, the bassinet and warmer of the baby is also there. So they are both together and it helps in lot of good things when the mother and baby are together since beginning. So the chances of infections are very less. The baby is getting exclusively breast milk since beginning. Mother is also very happy, less pain, less anxiety, and she is very happily taking care of the baby. So that mother and NICU baby, the ICMR also has given a lot of funding for these MNICUs to start. I don't know it has been started in Visakhapatnam or not, but all over India, many centers have started with MNICU. So the transport, the first most feasible method in our setting is by with the mother in the kangaroo mother position. If in case it's not feasible or you are not able to start that, then the transport can be done with the transport warmers, pre-warm transport incubators, and you have to maintain the temperature. The baby should be clothed in proper layers, then head should be covered while transport, and temperature of the transport should be adjusted according to the baby, so baby will not get overheated. So in an ICU, once you will receive the baby in an ICU, then again baby will go into the humidified double-walled incubator or double-walled under the warmer, bassinet warmer, and the field shield. So it is very, very important. The most important method, that hypothermia is the major killer in the preterm neonates, and we don't have that data that how much hypothermia is causing, though it's available from the Western world. But still, I feel that in India, we see in our unit only, it's outbound and ICU, that 80-90% of the neonates, when they are transported from outside, they are coming in moderate to severe hypothermia. And once they are severely hypothermic, the outcome is very, very poor. So it is a silent type of killer. So we should all take precautions to maintain the temperature of the neonate in every circumstances. So thank you so much. Thank you.
I have few remarks. Thank you, Mamataji, for giving an excellent summary of how to do. My concept of neonatal care is everywhere. It's not an ICU delivery or a hospital with the facilities. I'm thinking of the level 2 in the community. When the baby is born, we should be prepared to give the minimum care to maintain in that golden hour. That is, we thought and we did for years, is to dry the baby, warm the baby, overhead warmer, and keep the baby warm. And subsequently, low-cost intervention like the wrapper has come, it is good. Every district level we have done in Andhra Pradesh, this has to be encouraged. Subsequently, transport of the newborn to a higher level is necessary. Madam, you are told very well. And what are the goals of this golden hour? The goals of golden hour by any neonatologist or a pediatrician is thermal protection.
Right.
I still remember it is better to put the baby, even preterm, onto the mother's body soon after the delivery before delaying the clamp cord, cutting and clamp the cord. And again, the respiratory supervision, and also very, very important is the team spirit. Once your baby is going to be born, you must give a neonatal resuscitation alert to all your team. Mukyam, the core and the backbone of the team are the nurses of the NICU. Prepare them and keep the warmer and ready, and your co-gynecologist and the neonatologist to do. Then we'll be successful in the resuscitation and saving the heroes of this from the community, even at the district level, state level, and the intensive care level. Thank you.
Thank you so much. Thank you.
Thank you, Mamata ma'am, and thank you, ISLO sir. Now I would like to request ISLO sir to give a moment of appreciation to Dr. Mamata ma'am. Thank you. Sound out.
Check. Check.
Thank you, sir, and thank you, ma'am. Now I request Dr. Tushar, sir, to start the next session, early feeding strategies in at-risk newborns, SGA, and IDM. Dr. Suchitra, madam, is going to chair this session. Thank you, ma'am.
Good morning, one and all. First of all, let me thank the organizers, the Vizag team, and the National NNF to give this opportunity to be here with you. My slides. Yeah. So in the next 20 minutes, it's I think 11 o'clock. So next 20 minutes, let's go through early feeding strategies in at-risk newborns, and some focus on SGA, late preterm, and ITM. So if you look at these at-risk newborns, they are all low birth weight babies. And if you look at world, India is the world capital for low birth weight babies. If you see the recent NFHS data, we have about 18.2% deliveries in India, which are low birth weight babies. And out of them, so if you look at the neonatal mortality, 80% of neonatal mortality is seen in low birth weight babies. So this particular group is really at risk of mortality. And out of those low birth weight babies, if you see, 70% are premature and 70% are small for gestation age and 30% are premature. And gestational diabetic mothers are they're around 10 to 15%. So again, that forms an important at-risk category. So what is special about these babies? Because these babies will have poor feeding, they have specific neonatal morbidities, many have respiratory distress, and therefore monitoring is essential. So if you look at babies in general, and if you look at the hypoglycemia in these babies, so which are the babies which are at risk of hypoglycemia after birth in the first day? So preterm small for gestation is that the highest risk. Preterm large for gestation is at second highest risk, and term SGS are at the next highest risk. So if you include these three categories, majority of hypoglycemia you will be able to cover. So definition of hypoglycemia, is controversial, but for us to understand that any blood glucose level less than 45 is not accepted. It's above 45, and keep the blood glucose level above 50. And there is something called as operational thresholds, where depending upon the baby's symptoms, hours at the time of birth, we decide about treating or not treating. So at all times, baby's blood sugar should be above 45 to 50. And why this is important, that whether the baby is symptomatic or asymptomatic, because the studies have shown that baby who is symptomatically hypoglycemic has got almost 50% chance of having abnormal neurology on follow-up. And therefore, babies who have symptomatic hypoglycemia, they need to be closely monitored. They need to take attention and early treatment. So these at-risk babies, we must screen them, and their screening as per the American Academy of Pediatric recommendations. If they are symptomatic and their sugar is less than 40, they should receive IV glucose. If they're asymptomatic, within the first 4 hours, check their blood sugar after 1 hour after the feeding. And if that sugar is less than 25, give IV glucose. If the sugar is between 25 to 40, refeed and again recheck. But that sugar has to go above 40 after 4 hours. And after 4 hours, if the baby sugar is less than 35, baby should receive IV glucose. And if it is between 35 to 45, you need to monitor and make sure the sugar goes above 45. But if it is continuously staying less than 45 for the next assessment, then these babies should be shifted to the NICU and receive IV glucose. So this is very important, that target glucose must be above 45 in these babies on the first day, and later on should be above 50 for us to be comfortable. So if you look at if you look at meta-analysis about a role of early feeding in preventing hypoglycemia, so there are about 4 cohort studies, and these studies have shown that early feeding may reduce the incidence of neonatal hypoglycemia. The evidence is uncertain, but considering all the benefits, whatever is there in our hands currently is that we have to institute early feeding in these at-risk babies. So how do you decide method of feeding? So these babies you categorize as a sick baby or healthy baby. Sick baby should be started on IV fluids, should be shifted to the NICU, and well babies should be have their first feed within the golden hour. Appropriate feeding method shall be decided by gestation age and oral feeding skills. And again, poor feeding is a known problem in late preterm babies. Almost 32% of late preterm babies will have poor feeding, and therefore they require extra lactational assessment. So when you assess these babies in the delivery room after birth, when these babies are with mother, it is an extra precaution that we have to take. And there are some signs of good feeding and some signs of feeding immaturity. So if the baby is requiring to be awakened for feeding, falling asleep during feeding, feeding only small amounts, baby is coughing, spitting, or appearing to be choked during feeding, these are the signs that the baby is having feeding immaturity. And these baby will require extra attention and may require tube feeding. And reassuring signs are hearing the baby swallow the milk, seeing the milk in the baby's mouth. So these are the signs that the baby is probably getting good milk flow. And again, it is upon us that we must monitor their blood sugars. If you see baby having feeding immaturity, individualized assessment and lactation support is must. Skin to skin contact will help. Pumping soon after delivery to help the mother establish milk flow is very important. And nipple shield may help in this scenario. Tube feed for few days as NNS is attempted. So again, this is a very individualized care that we'll have to offer to a baby who is unable or who has a poor suck in this group. Now, more premature babies, how to decide about their feeding method? So, baby who is more than or equal to 34 weeks, most of them will have a good suck and they will be able to establish breastfeeding. But of course, these are the babies who are at risk. They need to be closely monitored and their sugar should be monitored. Babies who are between 30 to 34 weeks, these babies can be attempted spoon and palada feed. But again, we have to remember these are again at very high risk, may have poor feeding. Smaller babies, less than between 20 to 32 weeks, we should offer them NG feeds, and less than 27 weeks, definitely IV fluids. So, which milk we should feed in these babies? Exclusive human milk feeding we should attempt, we should target versus preterm formula. If you see, there are studies to show that human milk feeding will lower the risk of NEC, surgical NEC to a significant extent. The number needed to treat is about 8 for NEC, and for surgical NEC it is about 10. And again, there is a dose dependent benefit of human milk in these babies. So as much as possible, mother's own milk, and if it is falling short, PDHM, that is the pasteurized donor human milk, and if still that is not there, then the next best option is preterm formula. There are many benefits of human milk for these preterm babies. They reduce the risk of sepsis, reduce the risk of meningitis. Also, if you look at NEC, there is a significant reduction, but as compared to formula feeding, the reduction is much more. And if formula feeding, if human milk is not available, some effort should be done so that at least mixed feeding goes, where the risk of NEC is lesser than exclusive formula milk. Also, these babies will have better IQs as per these old studies by Lucas et al. Around 7 to 8 IQ points are the benefit these babies get. It's 8.22 minutes, is it? Okay. to the tune of about 20 to 30 ml per kg per day. Routine aspiration is discouraged. Withhold the fees only in case of suspected or confirmed NEC, or if there are any clinical morbidities that you suspect. Fortification at 100 ml per kg per day, and full feeds is between 150 to 180. Now this is something which is called a standardized feeding regimen. So all of your unit must have a standardized feeding protocol which has been shown to reduce incidence of necrotizing enterocolitis by 87%, and it also reduces late onset sepsis, improves feeding tolerance, and earlier achievement of full feeds and lower complications from TPN. So this is something which is currently in practice. This was further approved, shown in another meta-analysis by Boni Chassani et al. In 2017. How fast we can grade up the feeds? There are RCTs, and they've shown that if you grade up feeds at a speed of 30 to 35 ml per kg, you will achieve full feeds earlier, regain birth weight earlier, no increase in NEC, no increase in mortality, and therefore one can use speed of 30 to 35 ml per kg per day. Now, feeding interval 2 hours or 3 hours, there is no difference in feed intolerance. Too early schedule is faster full feeds, lesser withholdment of feeds. So, most of the units will have too early feeding. Now, in the recent times, there is a lot of talk about full total enteral feeds. Now, a lot of pioneering work has been done in India, initially by Dr. K.P. Sanghvi, and then later on Dr. Sushma Nange madam and their team. There are a lot of papers which have come out. Basically, in these babies who are more than 1 kilo, more than 28 weeks, start these babies on full quota of enteral feeds of 80 ml per kg on the first day, right itself. Don't put an IV cannula, don't start these babies on IV line. And full enteral feeds is graded up as per the day of life of the baby. You avoid IV fluids, you avoid dysbiosis, that is the potential benefit. However, the studies have shown benefit in terms of less hospital stay, and there is no increase in NEC. That is the common fear that we have, that if you give so much of feed volume on the first day, baby will end up with NEC. But the studies have shown that these are very encouraging results, and there is no increase in NEC. There is a meta-analysis which has shown that it did not show increase in NEC. There was no problem with feeding intolerance. There was decrease in late onset sepsis. Again, more studies are required. Cochrane meta-analysis shows that there are 6 studies, all of them from India, and they have shown there are few studies after 2020 also, but this trial provide, I'll just read the last sentence. Trials provide insufficient data to determine with any certainty whether early full enteral feeding affects the risk of necrotizing enterocolitis because of the risk of bias in the trials and inconsistency and imprecision. So they have advised doing more studies. So again, at this point in time, many of the units have adopted full enteral feeds on the first day, and many of units have a cautious approach, and they are sticking to the standardized feeding regimen. Few words about human milk fortifier. Why there is a need? Because if you give only breast milk, these are the nutrients, proteins, vitamin D, calcium, phosphorus, iron, these are the lagging, and therefore we should give HMF when the baby's feed volume reaches about 100 ml per kg per day. Single nutrient fortification is no role, because they only will provide carbohydrate and MCT, and these are not recommended. And these have shown to have better weight gain, length, head growth. However, long-term neurodevelopmental outcome has not changed. So, summarizing my talk, for at-risk low birth weight units, start direct breastfeeding during golden hour, monitor feeding, and more importantly, their blood sugar. Any baby with a low sugar must receive IV fluids. If the sugar is very low, or if the baby is symptomatic. For healthy preterm, ensure standardized feeding strategy where you start the feeding early. Colostrum mouth paint will help. Mother's own milk will be preferred, followed by PDHM if mother's milk is not available. Advanced feed rapidly. 45 mother's milk at 100 ml per kg per day. TPN has role for preterm infant who cannot be fed significantly. And early total enteral feeding is a new exciting strategy that needs more studies for a wider acceptance. Thank you very much for your patient listening.
Thank you very much, sir. I think you are well on time, actually a little bit
3 minutes
ahead.
earlier,
Yes. Thank you for that. And thank you for such a clear and crisp presentation with all the available evidence. Thank you.
Thank you, madam.
Now, thank you, sir. Now I request Suchitra madam to hand over momentum to Tushar, sir. I request next speaker, Dr. Deepan Patel, sir. Dr. Deepan Patel, sir. Next session will be on common fluid missteps in level 2 neonates, how to prevent them, by Dr. Deepan Patel, sir. Dr. Suchitra madam will be chairing this session. Madam, please introduce Dr. Deepan, sir.
So we are very glad to have Dr. Deevan Vasudev Patel, sir, with us. Sir is a professor, head of the Department of Neonatology, Sri Krishna Hospital in Gujarat. And sir has had several academic posts, past president of NNF Gujarat 2023, Secretary AOP Karamsad 2017 to 21, and he has taken the roles of organizing secretary and chairperson in Neocons in 2016 and 23. Again, he's faculty for NRP, pediatric ALS, BLS, and research methodology workshops. Sir, we are very glad to have you. Please go ahead. Thank you.
Thank you, ma'am, for introduction. Good morning, friends. I thank organizer for inviting for this presentation. We would start the presentation. The topic is common fluid missteps in level 2 and neonates. How can we prevent them? We know what is the indication of fluid management in newborns. Probably the single most answer is we need to maintain adequate homeostasis in newborn, and it is a bridge between the sick newborn to the healthy newborn. So it will give us a time for the newborn to get healed and get stabilized, and then will be on full fits. So we often use IV fluids in newborn. So we need to be very much cautious in treating newborn with fluids. So one of the most important thing is the need of fluid is very dynamic in newborn. We know that the fluid dose will change from daily and as per the gestational age, and in different disease conditions the need of fluid will be different. So we need to have a clear and very precise therapeutic precision, because there is a narrow margin of safety between the overhydration and underhydration. So what can happen if there is an error in managing newborn with the fluids? So one thing is important is electrolyte imbalance, that we all know hyponatremia may occur with this, or it may be hypernatremia also can occur. Predominant risk is cardiovascular instability. If you overhydrate the newborn, there will be overhydration leading to PDA opening, will lead to cardiorespiratory instability. Underhydration will lead to shock, hypotension, and may precipitate renal pre-renal AKI also. There is also evidence that if you overload the newborn with fluids, it will increase the risk of necrotizing enterocolitis. There might be neurological complications like seizures, interventricular hemorrhage, cerebral edema. Metabolic dysfunction is also common when we give less glucose to the newborn. So hypoglycemia may occur. Metabolic acidosis may happen because of the underhydration of the newborn. We need to understand, before going in detail about the fluid errors, physiology is very important to us. We know the diluting capacity of kidney and concentrating capacity of kidney of a newborn, especially those who are preterm, is less. If you compare it with the adults, adult has a maximum concentrating capacity of urine is around 1500 milliosmol per kg, while for extreme preterm babies is around only 600 milliosmol per kg. And what about diluting capacity? For adults, it's around 50 milliosmoles per kg, but for preterm newborn is 70 milliosmoles per kg. So we should understand the physiology of newborn, and based on these principles, we need to manage the newborn. We have seen this chart in many books, right? So this is from Fanaroff. How much amount of fluid to be started in a newborn? Remember, different books says different regimen. It is only our clinical decision which help us how to increase the number of IV fluid dose, right? So this is Fanaroff. You can see day 1 for micropremies less than 750 gram, the dose is 100 to 200 ml per kg. You can understand. So you will be in a dilemma what fluid dose we should start with. So you can have your own protocol for NICU, and based on your clinical judgment and what kind of equipment do you use, whether you use radiant warmer, whether you use incubator, you need to titrate the fluid as per the clinical status of the newborn. This is standard treatment workflow of ICMR. This was published in 2020. It is freely available on website. If you search for this, it may be available. So you need not to take pictures of this also, right? But it is important here. You can see they have divided in different days. Initial fluid therapy of choice is 10% dextrose for first 48 hours, and then you use N by 5 in 10% dextrose with KCl as a fluid of choice. Now, how much should we give? This all we know. This is how escalation happens with the day of life. But we should be aware of clinically how can we monitor. One of the most important parameter which we can use is urine output. And we all know that insensible water loss we cannot monitor. So that is just a clinical judgment. So that will combine will be a total maintenance fluid. But other factors that should be considered are like, this is how we can calculate how much daily weight can happen. So a newborn who is a term baby will get around 20 to 30 gram per day as a weight gain. But what about preterm? They will get around 10 to 20 gram per kg per day. So 70% of the body weight is water, right? So of this 10 to 20 gram per kg per day is water. So how much water increases daily in a newborn's life is around 10 to 15 ml per kg per day. So this is a gain that you should add in the daily calculation. Stool output also has water, right? Around 10 to 15 ml per kg per day water is there in stool. So this all makes to total fluid loss in the body, and then we have to monitor. So sometimes it is very difficult to monitor these all. So what we should do this with this, right, is you have to have the risk factors which increases or decreases the fluid loss in newborn. So level of maturity, you all know that premature newborn, because of the skin is very fragile, it is very thin epidermal layer, there will be increased fluid loss through the skin. Even environmental temperature above the thermal zone will increase the risk of fluid loss. Elevated baby's temperature, sometimes dehydration, because of our environment is much more humid and hot. The hot environment may increase the risk of fluid loss. So this all we should consider. Radiant warmer is commonly being used, not the incubators. So radiant warmer will also increase the risk of fluid loss. So we should be also aware of which sites which increase the risk of fluid loss. So each site will have different amount of electrolytes that can be considered in our mind, and based on that we need to add fluids to this loss. So what we can have is a clinical monitoring. If you have precise clinical monitoring, this will definitely add to your management. So first most important thing is history. Antenatal history is very important because polyhydramnios, oligohydramnios, and other maternal conditions may increase the risk of some kind of fluid mismanagement in newborn. So you should have keen history available with you about the antenatal and interpartum history. Especially birth asphyxia also has a chance of acute kidney injury and may also precipitate fluid mismanagement. What is most important for us is because sick newborn who are often on CPAP in level 2 nurseries, they are not often monitored for weight because it is difficult to get them off of CPAP and monitor the weight. So daily weight monitoring is very important for a sick newborn, because even with the weight scales we should have a precision of around 1 gram plus minus. So this is also very important. Urine output monitoring every 6 to 8 hours will help us. You check for the mucosa edema in the newborn, check for the eyes, skin turgor. That will help assess the fluid level of the newborn. Vital parameter monitoring is optimum, and we all know that how much valuable they are. You can look for the hepatomegaly. You can do POCUS. So that is now a promising field in measuring the fluid assessment in a newborn. Serum electrolytes, these are the all laboratory parameters which we can use to help us in managing the newborns. Some more idea about glucose and sodium balance, because we all know that newborns are very prone for hypoglycemia, and many risk factors are there for any newborn who is there in nursery. So we should be very cautious about this when they are on TPN. There are multiple drugs newborn are receiving, right? So diluents are commonly used in newborn, like dextrose 5%, 10%. We use normal saline. So what kind of fluid we are using, we should be also be cautious while giving the drugs as a dilution with some other therapeutic agents. So sodium should be around 2 to 4 millicoulomb per kg per day, and potassium should be around 1 to 2 millicoulomb per kg per day. That should be started after 48 hours of age of a newborn. We all know about this glucose infusion rate calculator, but we often forget to measure how much newborn is receiving glucose. So this is all available in our Cloharty manual also, but very easy to calculate how much amount. You can see ml per kg per day in this table, and how much milligram per kg per minute newborn will be having in the chart. So very easy to calculate, but Sometimes we can also use some mobile applications. We have prepared Excel application to calculate glucose infusion rate and other calculator also. So it is very easy to calculate glucose infusion rate, and be sure that you are giving at least 4 milligram per kg per day of glucose in your therapy of a newborn. This is another chart which I have taken from Cloharty that easily helps us to identify where we can go wrong and where we can manage the newborn if there are such situations. Common situation is like very hot, humid environment, babies has lost weight, and maybe if you do urine output, it is less, sodium is high. So what is possibility? It is a free water loss, right? So we can increase free water supplementation by increasing feeds to a newborn who is very stable. So what are the key pulse to remember in a newborn when we manage fluid therapy? They are the normal unit output around 1 to 3 ml per kg per day. We should have measure the weight of the newborn is around 10% weight loss is maximum in a term newborn, and 15% weight loss is in preterm newborns. So beyond the first week of life, term neonates should gain approximately 20 to 30 gram per day. Urine specific gravity is around 1.008 to 1.012. We should use 10% dextrose in first 48 hours, and daily weight loss of more than 5%. Then you should add more 10 ml per kg per day. If there is a weight gain of more than 5%, then you should reduce the fluid intake by 20 ml per kg per day. This is a kind of standard norms which we have. And standard glucose infusion rate is around 46 milligram per kg per minute if child or newborn does not have hypoglycemia. So second misstep is poor monitoring and charting. So level 2 SNCUs are often flooded with newborns with less nursing staff, and we do not have that much opportunity to monitor the newborns, and they increase the risk of adverse events. So what happens is we don't track their weight daily, we do not have adequate input output monitoring, and then when we miss important electrolyte investigations when baby is sick. We do not often use blood gas in managing those newborns. Sometimes lab services are available, but the turnaround time is very high. So this also reduces the core component of care of a newborn. Incomplete documentation and handover of newborn is also very important, because sometimes nurse has managed a newborn with some antibiotic and she forgets to tell next sister who is coming for the round. She may give otherwise the second dose also. So we should be very cautious in handover also. So what is the preventive strategy for this? Is standard monitoring chart and daily rounds checklist or handover strategy is very important for such kind of managing the newborns. So we often start with the feeds also simultaneously with fluids. So we should consider feeds in our calculating the total fluid volume whichever newborn is receiving. Other major important part is compatibility, which we often forget while we are managing the newborn. So drug incompatibility, the major incompatibility which of a drug, we commonly use ampicillin and gentamicin. So sometimes many nurses, they combine ampicillin and gentamicin together and they give simultaneously. So this is very unsafe practice, because ampicillin inactivates aminoglycoside. So we should not combine ampicillin and gentamicin. So that we should be very cautious. Dopamine and sodium bicarbonate. So this is not a topic of level 2, but dopamine and sodium bicarbonate may be used in level 3 nurses, but you should be aware that dopamine is inactivated in alkaline environment. So it won't be of use when you use combined dopamine and bicarbonate. Dopamine and PEG cells. So when a newborn is sick, dopamine is ongoing and they need often PEG cell transfusion, and the same line will transfuse PEG cells. Then there is high risk of hemolysis, right? And pseudoagglutination, which may be risky to a newborn. Some drugs are not compatible with TPN, this you are aware. And you can find this kind of compatibility in Neofax, it is available. Even you can search in up-to-date lexicon. Many drug websites are available in which you can find out which drugs are not compatible with other drugs. So what is the risk of incompatibility is? One is precipitate formation. The precipitate may go in brain, may go in lung, may go in kidney, and will lead to failure and may lead to death of a newborn. There will be a loss of efficacy, and sometimes it may have potential harm also. Another major terminal site incompatibility is for vancomycin. Vancomycin is very toxic drug, and it has also major incompatibility issues with many drugs like other antibiotics like cefazolin, cefepime, cefotaxime, cephalosporin group of drugs need to be very cautiously used with vancomycin. Chloramphenicol, dexamethasone, these are the drugs which are commonly used in our NICU. Heparin, naphthalene is not used, but phenobarbital, piperacillin, tazobactam, these are the commonly used drug in NICU. So we should be cautious using with vancomycin. So how can we mitigate this incompatibility? Is by following standard guidelines. We should check the complete leaflet of that drug. We can do different time administration of these incompatible drugs, separate administration by different IV lines, flushing with a compatible solution between the drugs, using multi-lumen catheters. The dictum is when drug compatibility is uncertain, never mix and avoid possible terminal injection site mixing. So that is what we should be aware of. Avoid mixing any drug which we are not aware about the any terminal site incompatibility. Another major area which we need to improve is labeling the syringes. So you can see here the monitors are there, infusion pumps are there with the labeled syringes. Which drug is given at what date and what time. Even the labeling is also done like with high risk drugs. So appropriate labeling of syringing is very essential, because sometimes if a newborn risks some drug, need some drug in emergency, and we need to disconnect these syringes from the infusion, and we may forget what drug is there in these syringes. So to avoid such kind of errors, we have to label the syringes with appropriate guidelines as recommended by NABH. You are all aware of those guidelines. Another thing is not changing IV tubings. So we often see that newborn is not changed IV tubings until they are discharged. So this happens especially in very crowded level 2 nurseries. So what is the guidelines? So some says we have to change every 42 hours, some say 24 hours. I also check CDC guidelines. They say maximum 7 days we can keep, minimum 3 days. So 3 days to 7 days we can check IV tubings which are on continuous maintenance infusion. But if newborn is on TPN, we need to change IV tubings every 24 hours. Or when we give intermittent drugs like baby is stable and we are giving only antibiotics, then that IV tubings can be changed every 24 hours. Blood and blood components, we have to immediately discard those IV tubing after use. This is also a major area of concern that we need to improve, because many drugs needs to be given with appropriate dilution and at appropriate rate. One of the drug example I have given is vancomycin over here. You can see this need to be given very slowly with appropriate dilution. If you give it very fast, it may have a toxicity inside, and we don't know what would have happened. And we will label this pneumonia is worsening because of sepsis. But now the time has come that we should think of this kind of problems, and we can mitigate this by appropriate dosing and dilution. Paracetamol, you might be aware that we use often in PDA management, which are very symptomatic. Dose is 15 mg per kg, 6 hourly. But remember, paracetamol ampoule, when you break, it is of single use. You cannot use after 6 hours again that ampoule. So discard that ampoule of paracetamol. So saving cost by using those ampoules repeatedly will be more costly than the discarding them. Too fast delivery, we often use gravity assisted drip sets. So now it is only used in some of the nurseries, especially when we transport the newborn. So that is also should be avoided, because it has an increased risk of either overhydration or underhydration. And sometimes some important drugs which is very toxic like KCl is ongoing. This gravity assisted drugs equipments may worsen the fluid overload. Breaking the asepsis barrier, you all know hand hygiene, wearing the gloves, gowns as appropriate are very important part of our management. Breaking the asepsis may be more poisonous than not giving the fluids. Wrong calculation and wrong patient. See, you all know NABH criteria. Newborn needs precise calculation based on weight, based on gestation, based on day of life. So this need to be very much precise. Small error may change amount of drug to multiple times, and which might be more risky. Air bubbles and tubings. So if there are air bubbles in tubing, that means we are not that much careful in managing the newborns. Small amount of air might be more damaging to the newborn. At a dose of 3 to 5 ml per kg might be a lethal dose to a newborn. So be cautious about air embolism in newborn. Some of the drugs needs to be protected from light that you are aware of. So be cautious when you use some drugs. Sometimes when you ask patients to buy the drugs, they bring it from the pharmacy. They need to be kept in that packets only. We should not uncover them, because some of the drugs are very much sensitive to lights also. Even they are not used, like cefotaxime, metronidazole, vancomycin, linezolid. So that's why they are brought in covered packets. Not checking the IV site. So we need to periodically check every 6 to 8 hours when newborn is on IV therapy, especially on peripheral IV lines, and sometimes on PICC also. So we should check for visual phlebotomy score for these conditions. Otherwise, if we miss this, then we will end up in many much more complications, and it will be difficult to manage such kind of newborns also. Expiry date of drugs. So you check expiry date of drugs of all the, not only drugs but also equipment, devices also. This is very important for us. Some drugs need optimum temperature management, like betamethasone. So that needs optimum temperature, need to be refrigerated. Albumin needs to be refrigerated. So optimum temperature management will help maintain the potency of the drug. Open fluid bottles should not be preserved for a long time, especially not more than 24 hours. Another area which we need to improve is we have to respect the kidneys. So we often measure creatinine clearance. So you know the formula. So K into L divided by serum creatinine. So this is very important for a newborn especially. So what is normal creatinine clearance depends on the gestational age, depends on the age of life also. But you can use Hereditary, which gives detailed information about how much drug we should be reduced, how much the duration of between doses can be increased. So Hereditary is one of the good book for this. Soil tubing. So whenever there are connection in the tubes, we should always cover them with autoclaved linen. So that is very important. Here you can see prescription errors are very common in newborn. In any ICU cares, you can see the prescription when their handwriting are not, still they are readable here, but still they are not, I do not feel that this is optimum. So it may increase the chances of handwriting, can lead to prescription errors. So legible handwriting is very important. Another area which is very hidden, or we can see it is a tip of iceberg, is inadequate reporting of errors. So we need to improve our system, to improve ourselves, to our to even our nurseries also need to be sensitized about reporting the errors so that we can improve. So to summarize, we should have a knowledge of physiology for newborns, start when needed. Proper dilution and proper rate is very important. Check for incompatibility. Optimum clinical monitoring and laboratory investigations as per need. Avoid errors. Adhere to asepsis protocol. Check IV sites periodically and respect kidneys for optimum fluid management of the newborns. So this is the last slide. Thank you so much.
Thank you very much, sir. You have taken us through the physiology and given us very practical tips to be careful about. So thank you once again.
Thank you so much.
Now I would like to request Dr. Suchitra ma'am to hand over memento to Dr. Deepen sir. For the next topic, we have Dr. Venkat Reddy sir. When lines go wrong, tackling extravasation injuries in units. For this session, Dr. Suchitra will be chairing the session. Thank you. I would like to request Dr. Suchitra ma'am to introduce Venkat Reddy sir.
So, Dr. Venkat Reddy sir is a neonatologist from Fernandez Hospital, currently consultant neonatologist and head of neonatology, Paramita Children's Hospital, Hyderabad. So he is also a medical illustrator and created Neonat AI smartphone application and has had several publications to his credit. Over to you, sir.
So thank you for the kind introduction, ma'am. So first of all, I would like to thank NNF and organizing committee for giving me this opportunity for speaking over here. So my talk is on when lines go wrong, tackling extravasation injuries in units. So the next 15-20 minutes, we'd like to go about with this agenda for the next 15-20 minutes. So, so is this topic matters? So first question we'll try to answer. So if you see in the previous talk we saw, So the importance of lines and everything, importance of fluid. So if we see in the NICU, the most important and most common procedure what we do in newborn is securing a intravenous line. So as it is most common, it can have complications as well. So the incidence of, if we see the incidence of these complications, so majority of the studies, if we when we done the literature review, it has shown that the incidence is around 18 to 46%. That means if we equate that, out of every 2 newborns, one baby will be having some amount of injury, or one baby out of 5 babies will be having some amount of injury. So in these babies who have injury, it will be something like around 2.4 to 4% of them have severe form of injury leading to necrosis or requiring active intervention, and of this around 4% might end up having a cosmetically or functionally significant scars or problems. So as it is causing problems, what happens is, nowadays we see there is a significant medical legal dimension to this aspect, because IV lines are meant to be protective, and we should be it should be prevented from our end. So that's why if there is any complication, that has a medical legal implication and it can cause litigation. So coming to the definitions, we need to understand 4 important terminology here for understanding the overall topic. The first and foremost thing is irritant or a non-vesicant. Second is vesicant. Third one is infiltration. Fourth is extravasation. Usually we use these terms interchangeably, but there is a difference. What is a vesicant or what is a irritant? So irritant is any agent which can cause pain, swelling and venous irritation and can lead to chemical phlebitis at the injected site. So what is a vesicant? Vesicant is an agent which can cause not only the pain, but along with this there is something called blistering, and can also lead to ulceration and tissue necrosis. So what is infiltration? So any inadvertent injection of a non-vesicant, that means an irritant, is called as infiltration, and inadvertent administration of vesicant which can lead to necrosis and ulceration is extravasation. So infiltration is the infusion of a non-vesicant, extravasation is infusion of a vesicant. Coming to the vulnerability, as we know, neonates come up with certain their own physiological and anatomical challenges, so that can lead to increased risk of injury, and if there is injury, the severe form of injury is more common in the newborn. So the reasons are, first and foremost is their tissues are very fragile, so the skin is very thin, and there is minimal subcutaneous fat which leads to easily spreading of the infusate, and the venous wall is very fragile which can lead to increased risk of rupture and leakage. The highest risk when we see is seen in babies less than 32 weeks and less than 1500-gram babies, and they have their own limit expressing the pain, so thereby whenever there is an injury it can lead to severe form of injury, and because of their immaturity of the immune responses they can't curtail the injury at that point. So coming to the pathophysiology, so there are 5 components actually. The first is the because of the drug or the medication itself can lead to direct cellular toxicity. And the second thing is, if the drug is hyperosmolar, what happens is it will cause a lot of sucking of the fluid from the cell, leading to cell rupture. That is osmotic injury. Next thing is medication which can cause vasoconstriction, like vasopressors, can lead to ischemic necrosis. And the fourth, there is a lot of compression happens which leads to compartment syndrome and ischemic necrosis again. So finally, infection, as there is a significant port and the tissue is fragile, an entry of bacteria can cause and can worsen the problem. So there are 5 components which can lead to injury whenever there is extravasation. And with respect to newborn, we have the problems like the endothelium is very immature, and there is freely release of free radicals, and the free radicals can't be contained at that point. So these are the factors which are specific to the newborn actually, which can worsen the situation. So coming to the risk factors, so there are drug related factors, like there are 3 things we need to remember. First is the pH of the drug. Any extremes of pH, like pH less than 5 which is very acidic, pH more than 9 can cause problems. And if the osmolarity of the drug, if any hyperosmolar drugs can cause problems. And as such, I told you about the vesicant and the irritant. Coming to the patient related, again the prematurity, babies who are less than 32 weeks have highest risk of having problems, and low birth weight babies, and babies who are having edema. So here what happens is, because of the edema we can't secure the line properly, multiple poking can happen that can lead to problems. Coming to the device related factors, so we see commonly what we see is the lines we are were secured at the joints actually can cause problems, and lines secured in the lower limb can cause problems. and whenever there is a opaque dressing, so it will obscure the underlying swelling. So next thing is infusion related factors like high infusion pressures and rapid infusion rates can cause problems. These are the risk factors which we need to consider. Coming to the medications actually. So here what happens is every unit have their own set of medications which they commonly use. So we need to prepare a list of medications and categorize them into whether the medication is an irritant or a vesicant. Thereby nursing staff will be very cautious with respect to this. Whenever they are giving this sort of medication, they will be very cautious. So coming to the classification of injury. So whenever we classify the injury, the management will change as per the grading actually. So if you see, if we grade the injury, there are 4 grades. The grade 1 is there is minimal pain and minimal swelling at the injection site, and there is a lot of irritability, and cannula can't be flushed, and but the perfusion is normal. When we say grade 2, along with pain, there is mild to moderate swelling, redness is present, cannula can't be flushed, but perfusion is normal. So in grade 1 and grade 2, perfusion is not compromised. There is swelling and pain and minimal amount of redness. When we come to grade 3, there is obvious swelling and redness. Along with this, there is blanching is there, and capillary refill will be a bit prolonged. Coming to grade 4, here the main problem. So the perfusion is decreased and skin can have blisters and epidermolysis can be there and arterial occlusion can be there. So this is graded. Grade 4 is the grade. So grade 3 and grade 4 we need to have active intervention from our side, not just the normal management. Grade 1, grade 2, normal management. We'll discuss then in the next slides. Coming to the early warning signs. In early warning signs, the most common thing we need to consider is 2 things. The first thing is the baby is crying. Baby is having some amount of irritability that should be addressed at any cost. So any excessive cry baby, if the IV line is there, we need to check the line whether it is patent or not. So next thing is device related. Whenever we see there is a lot of alarms going on, okay, whenever alarm is there, we silent and we continue. So whenever occlusion alarm is going on, we need to address that occlusion alarm because that is the most common early warning sign. Coming to the immediate management, we call it a stop protocol. The first thing what we do is stop the infusion immediately. So don't prolong. So next thing is do not flush the cannula. So normal tendency is once there is a block, we'll check the line, flush it with the 2 ml flush. Thereby we see that if there is any occlusion, it will go off. But what that causes is when we flush it, if there is already a block, already extravasation is happening, the drug will go deeper and it causes more problems. More concentration of drug will be lodged there. Next thing is leave the cannula in place for review. This is again the most commonly done mistake. Once we see, we'll try to remove the cannula, but that should be kept in place for the review because we may sometimes that the baby might require some more interventions. The cannula in place will help us. So next thing is if there is an option, try to attempt to aspirate the drug or whatever which is there from the cannula. Next thing is remove the splints, tapes or tight bandages which is causing obstruction. Next thing is elevate the limb, which will help us in gravity dependent drainage with respect to venous and the lymphatic drainage. Next thing is provide pain relief, so soothe the baby. Next thing is document. This is very, very important. So at that point of time, what is the drug which is going on in the line, time and volume of the drug. This should be documented and inform the senior staff. Here again, the most common problem is they try to cover it up because the consultant will come and shout what is the reason why this happened, all these things. That will cause more problems actually, because if we are not shouting, if we are telling them properly in a normal tone, more and more these things can come up. Otherwise night, by the time morning we go, night swelling also will be reduced. So along with the stop protocol, the critical questions we need to answer in the first hour are: what is the drug type? Is it a irritant? Is it a vesicant? Is it a vasopressor? And what is the grade of the injury? Is it grade 1 to grade 4? What is the grade? So based on that, we can take a call for whether this baby requires a hyaluronidase injection or not, and if the baby requires any surgical intervention or not. So coming to the medical management of the extravasation, the first and foremost one and the most commonly done thing is hyaluronidase injection with saline flush out techniques. So out of all the medical management thing, this is the most evidence-based intervention. So what is hyaluronidase? So this is an enzyme which will break the hyaluron, which is a connective tissue element in the subcutaneous tissue. What happens is whenever we give this injection, it will break the tissue. Thereby, it will allow the spread of medication into the tissue. Thereby, it will decrease the risk of concentration of drug at one point. Thereby, the decrease the risk of injury will be there. Ideally, it should be done within 30 minutes. And indications are any grade 3, grade 4 injury, we can attempt hyaluronidase injection. And if there is any hyperosmolar or a vesicant extravasation, we can attempt this one. The contraindications are whenever there is a vasopressor, it should not be used. For the reason we'll discuss in the next slides. If it is beyond 1.5 hours, there's no point in giving this, and known allergy we can avoid. This is a technique. The first thing is the extravasation site should be properly cleansed with chlorhexidine, and we need to give some amount of local anesthesia, followed by this injection. So can be given at 4 to 5 different sites in and around the injection site with a 23 gauge needle, and followed by a 20 gauge cannula should be inserted through the subcutaneous tissue from one end to the other end, which is as shown in the figure. So there will be one entry wound, one exit wound. So after this, what we'll do is we'll try to remove the needle, and we'll try to keep the cannula in place, connect a 20 cc syringe by flushing through the syringe, 20 cc syringe, slowly try to remove the cannula. So we'll repeat this third and fourth step around 4 to 5 times. Thereby we'll have around something like around 5 to 6 entry and exit wounds actually. And via this entry and exit wounds, we'll try to keep the just cannula hub, and we'll try to flush the NS around 20 ml or so. Thereby we'll try to, first we have given the injection, hyaluronidase injection, thereby the drug has dispersed. In essence, it has not concentrated in one place. Followed by flushing will be done. By flushing, what happens is this drug, whatever is there, can come out. Say, thereby we are decreasing the contact of this drug at that point of place, thereby decreasing the injury. So post procedure, the care is try to avoid occlusive dressing, keep it open, with small covered with normal sterile gauze, elevate the limb for at least 24 hours, monitor for the perfusion. Though even though we have done the procedure, it may not guarantee the perfusion is improved. So analgesia should be given, document it, and take a serial photographs, which will help us in saving your skin later on. Family counseling, we need to explain the parents clearly that what we have done and how it is going to help. So next thing is management of vasopressor extravasation. So unlike the previous medication, vasopressor medication is something different. It will cause the problem is not because of concentration of the drug. The problem is because any minimal quantity also it can cause vasoocclusion. So there will be significant vasoconstriction will be there, leading to ischemia and necrosis of the in and around tissue. So thereby, as it is because as the drug is causing problem because of vasoconstriction, your hyaluronidase might not be helpful in this case. So that's why it is contraindicated. So there are certain agents which can be tried if there is a vasopressor extravasation. One is phentolamine, so which is a alpha adrenergic antagonist which reverses the alpha mediated vasoconstriction. It can be given in subcutaneous route in and around the site of extravasation. Studies have quoted that if it is being given to 2 to 12 hours timeline, it can improve the outcomes. One more thing is nitroglycerin. So nitroglycerin patches are available. Sometimes nitroglycerin patches applied in the compromised area, not at the point of injection, or it should be in the distal actually. So studies again have shown that this will help. Coming to the surgical indications, so any grade 4 extravasation with poor perfusion, full thickness skin injury, deep tissue involvement, compartment syndromes, suspicion of tendon or nerve involvement, and failure of early hyaluronidase or flush out technique. These are the indications for surgical management. Always involve surgeon early if you feel that it is grade 3, grade 4 injury. So the intervention, what surgery point of view they does is, one is debridement. So indicated when there is a necrotic demarcation is there, and it might require multiple sessions actually. So it will remove the necrotic tissue, thereby it will prevent further infection, and it can help in promoting healing. So again, with respect to dressings, what we generally try is hydrocolloid dressings and silicone mesh dressings. This will help in protect the fragile wound bed, and it promotes granulation tissue formation. Usually this is done after debridement. Next thing is split thickness skin grafting. It is required when there is a loss of full thickness skin or surgical debridement exposing dermis or fascia. These are the indications. Coming to the fasciotomy, done very rarely, mainly with respect to compartment syndrome. It will help in releasing the pressure, thereby restoring the perfusion. So coming to the management, as I told you, grade 1, grade 2, predominantly conservative management. The stop protocol is more than enough. And grade 3, grade 4, you can consider hyaluronidase injection with saline flush out technique along with surgical referral. Coming to the prevention strategies. So always use a central access for medications like irritants, vesicants and hyperosmolar fluids. Avoid cannulas near joints and avoid cannulas in the lower limbs. And secure the cannula well. Use minimal but firm dressing. And hourly extravasation assessment should be done. And always respect the alarms which is given by the syringe pumps. Use transparent dressings and document side checks should be done every shift. To conclude, early detection definitely saves the tissue. Stop protocol is non-negotiable. Hyaluronidase injection plus flush out technique is the best evidence as of now. Vasopressors, special protocol should be followed. Prevention is always better than cure. So use standardized grading and documentation. System level changes, especially with respect to nursing and with respect to documentation should be there. So thank you.
Now I would like to request Dr. Suchitra ma'am to give a moment of appreciation to Dr. Venkat Reddy sir. Yes, sir. Yes, sir. Yes. Now I would like to request Dr. I.S. Rao sir to give a memento to Dr. Ashish Bhakta sir. Thank you. For the next session, we have Dr. Nishant Ahmad Liaquat. The topic is born early, balance carefully, the art of IV electrolytes. To chair the session, we have Suchitra ma'am. Ma'am, kindly introduce Dr. Nishant. Thank you.
So Dr. Nishant Ahmed is a neonatologist and currently associated with Latifa Hospital, Dubai. He is a faculty for the Neonatology Fellowship Program, faculty for Clinical Assistant Professor in Mohammed bin Rashid University, Dubai, and a clinical lead, Clinical Practice Guidelines Committee, Latifa Hospital. He has several achievements to his credit. Sir, please start. Thank you.
Good afternoon. Thank you for the introduction. It's my pleasure to be here in Vizag, and thanks the organizing committee for the opportunity, and great hi from Dubai. So I work in a level 3 unit. We have 75 bedded NICU where we cater from 22 weeks onwards. And my talk is on the art of IV electrolytes, born early and balanced carefully. Right. So the focus will be on extreme preterms. How do we treat them differently? Extreme preterms means we'll be focusing on less than 1 kg or less than 26 to 27 weeker babies. Their unique physiology, what are the requirements, the different electrolytes and how are they have to be adjusted, the morbidities associated with the dyselectrolytemias, and lastly, sodium acetate bicarbonate and some take-home message. So why this matters? High stakes in L-GANs, because if you see there's altered physiology. They have very thin epidermis, they have insensible water loss is high, the respiratory rate is high, so respiratory loss is also high. They have diuresis because of immature kidneys and tubular dysfunction. They cannot be fed by mouth, and there is iatrogenic fluid management by our enthusiastic neonatologist, and they need humidification. So there is a setting for impaired homeostasis in general for all these babies. So the fluid and electrolyte shift are rapid, unpredictable, and high risk. We also know from literature that hypernatremia, sodium of more than 145, there is some risk of IVH. High sodium with fluid imbalance, there is always a risk of PDA, IVH, BPD, and mortality. So it's a modifiable practice. Major impact can happen when it is done within 72 hours. There is lack of evidence, and there is a need for individualized prescriptions rather than guideline or protocol based. So what are the burning questions we have in this? What is the expected weight loss? What is the optimum weight loss? Is sodium a good proxy for fluid status? What is the timeline for weight gain in Elgans? What is the fluid goal? Fluid and electrolytes, whether to give TPN or how to adjust in fluids, how much sodium, potassium, calcium phosphate to be given, how to treat the dyslipidemias and how fast and slow to treat, what is the role of alkalization. So we'll see these questions whether we can answer them or not. So to understand this, we need to know we have to dig into the basic physiology of extreme preterm. So extreme preterms, 26 weeks, the total body water is 80% of the body weight. Compared to an adult, it is only 60%. But if you see the proportion, the ECF is higher. Majority of fluid is from ECF, 2/3, and ICF. So this extravascular component is high. So there is a normal postnatal adaptation. So the diuresis and natriuresis should happen. Expected weight loss is around 10 to 15%. Any interruption in this can cause fluid overload and increase the IVH. So this is a busy slide, but if you see the changes which happen before birth and after birth, and this is the compartment list. So before birth, because of various labor and hormones, there is a fluid shift from intravascular to interstitial compartment, so the volume is less. After birth, the capillary membrane integrity is restored, and there's a fluid shift back from interstitial to intravascular compartment. Some situations like maternal endomethacillin or excessive fluids to the mother can expand the ECF and cause neonatal hyponatremia. And placental insufficiency and diuretics can cause neonatal hypernatremia because of fluid deficit. So electrolyte management is very, very crucial because it has narrow margin, rapid shift, and dynamic needs. So that is why individualist management protocol is always better than having a standard set protocol. So what are our goals for fluid and electrolyte management? To maintain the intravascular volume, allow for ECF contraction, which is physiological, avoid overload, avoid dyselectrolemias, and support growth. So this is a simple fluid strategy what can be followed in babies who are less than 26 weeks based on the weight. Less than 750, if you see at day 1, the fluid started is higher, like 100 to 140. This is because they lose more fluid, diuresis, right? So day 2, 120 to 160, but the maximum fluid if you see on day 7, 140 to 160. Some babies, extreme cases, you can give up to 200 ml also for 22-weeker babies who are nursed and then they have high insensible water loss. As the weight goes down, the fluid on day 1 is less, and day 5 to day 7 maximum 150, not more than that, right? So we'll go to each ion and see how to manage them, and out of which sodium is a very, very important central player. So in the fetus, sodium is essential for fetal growth and ECF expansion. Sodium is actively transported by the fetus by the sodium potassium ATPase. So if you see, the majority of the accretion happens in the late trimester, third trimester. So if a preterm baby is born below 28 weeks, they are born with less sodium reserve, less dose. So that is very, very important. So, but what happens after 7 days, after birth? So initially there is hypernatremia, then hyponatremia. This is very important to remember. Why there is hypernatremia? Because of loss of water, their insensible water loss is high. Excessive sodium administration, which is hidden sodium, what we call as like sodium flush, medications, blood transfusion, all these things can cause higher sodium. Possible there is some AKI. So in many studies where they have found in a retrospective audits, average sodium intake was very high, and higher sodium intake levels were associated with IVH and or death. There's a recent paper also published by Ambulavanan in 2025 correlating high sodium fluid imbalance to IVH. So restrict sodium whenever possible. Right. So after 1 week, there is hyponatremia. Why it happens? Because of diuresis and major other physiology. So ESPGHAN recommends to give sodium after day 3, 2 to 5. In Elgans, sometimes you have to give 6 to 10 because their loss is very, very high. So when and how much to give? So important point to remember as far as sodium is initial hypernatremia, then there is hyponatremia. This is physiological, right? So early phase, no sodium. because there is already hypernatremia, dehydration. Transitional phase, which is after day 2, you can start 2 to 4 depending on the blood levels. Late phase, sometimes you can go 4 to 5 or even 6 to 7 to maintain a target of 135 to 145. This is the ideal range. Is sodium a good proxy of fluid status? No, there are many flaws. Sodium and weight loss have been monitored traditionally for a few days. Sodium poorly represents the total body sodium. So it is not a good proxy at all. There is hypernatremia because of dehydration, and immature kidneys, insensible water loss confuse a lot about sodium. So sodium is not a very good proxy to assess the fluid balance, especially in elegans. How to treat? 2 slides on treatment. How to treat hyponatremia. The important point what we have to see, most common cause for hyponatremia in a sick neonate is excessive fluid administration. So in those sick neonates, treatment is restriction of free water rather than giving sodium, which sometimes tend to do the opposite way. And sodium deficit is calculated from the standard formula. But if severe hyponatremia is there, this is an exception. When the sodium is below 120, you have to correct it by giving sodium. 3% saline over 4 to 6 hours. Some cases where in children, when there is seizures or coma, you give rapid IV correction over 10 minutes or over 1 hour, 5 ml per kg. But beware that chronic hyponatremia can cause spontaneous myelonosis. After 120, give slow correction. So if the baby has sodium around 120 or low, but asymptomatic, avoid 3% saline. So 3% saline has to be used very, very carefully because it has a lot of side effects. Hypernatremia. In hypernatremia, the issue is because of water deficit, right? So there's a movement of water from intracellular to extracellular. So when there is sodium level is high in the extravascular compartment, the blood compartment, the tonicity goes up. The water is pulled from intracellular compartment. So there is actually a dehydration. Acute condition, the CNS is protected. You can correct at 1 milli up to 24 millicurrent per day. But in chronic hypernatremia, there is formation of idiogenic osmoles. So we have to be very, very careful to do a rapid correction in this. So expected is slow correction, 0.5 milliequivalent per liter per hour. So we can use the formula to correct. In emergent phase, you can give saline if there is hypernatremia, like plain saline or a higher concentrated saline, especially if the sodium is 160 or 170. In the rehydration phase, it has to be collected slowly over 48 hours. So you can see the free water required formula for 48 hours and 36 hours, depending on the severity of sodium. So hypernatremia is all acute, maybe sometimes relatively slow, but chronic gives slow correction. Second thing is about potassium. Why potassium matters? Because potassium is a major intracellular cation. 95% is intracellular. It is essential for cell growth, membrane potential. Elgans usually have immature potassium regulation. Similar to sodium, there is a transition from excess to deficit. So hyperkalemia to hypokalemia. Similarly, hypernatremia to hyponatremia. Okay. Born early, they are born with less potassium. That is very, very important, which you have to understand. So there are various reasons where there is hyperkalemia of prematurity. Some are physiological, some are pathological. If you see the sodium potassium ATPase activity is less, the distal tubule has poor secretion, there is metabolic acidosis and relative insulin resistance and hypoaldosteronism. Pathological causes like tissue breakdown, lysed RBCs because of blood transfusion, severe RDS, acidosis, hypoxia, hemolysis. These are some clinical conditions where there is transient hyperkalemia. Sometimes we iatrogenically add potassium also. Antenatal steroids and protein in TPN decrease this hyperkalemia. But after 3 to 5 days, there is hypokalemia. It's a contrast because there is a diuresis. Sodium administration also increases potassium excretion. Aldosterone surge amplifies this. Sodium potassium ATPase upregulates. And in TPN, there's low formation. So this is important to remember. So the key implication is early hyperkalemia is a predictable physiological issue, not always a sign of renal failure, right? Right. So if you see the potassium table, how much to give? Day 1, day 2, avoid potassium at all. Monitor 6 to 12 hourly. Day 2 to 3, if the urine output is more than 1, potassium is less than 4.5, you can start at 2 to 3. If the stable on TPN, can give higher dose. On high dose potassium, when there's diuretics or loss in the growth phase, you can give higher potassium level also. Target is to maintain 3.5 to 5.5. Avoid potassium if more than 6.5 because the risk of arrhythmias and hyperkalemia. Important thing about potassium is the route of treatment. Okay, parenteral nutrition is always preferred. Giving high concentration potassium through a peripheral line like more than 40 millicount is known to cause extravasation injury. So that is very, very important. Third thing is about the calcium. Calcium is also actively transported. Accretion happens in the late trimester. So those who are born premature, they have less calcium. So in contrast to sodium and potassium, calcium has to be started on day one because there is hypocalcemia early in Elgins because the PTH response is abnormal, lower calcium stores, placental supply stops. So there is early hypocalcemia and also late hypocalcemia, which we see in metabolic bone disease. So calcium has to be started on day one at a lower quantity. You can the use of giving the risk of giving calcium through peripheral line is always very, very has to be balanced because of extravasation risk. Monitor ionized calcium in the range of 1.1 to 1.4, but ionized calcium is not always equivalent to serum calcium because the albumin is low in these babies. Acute symptomatic condition like seizures and high inotropes or PPHN, when they're not responding, calcium can be given IV as a correction. Otherwise, it should be given slowly. There's always a risk for extravasation. Phosphate, similarly, accretion happens in third trimester. So when the babies are born premature, they have less phosphate. So phosphate has to be started on day one. Even in our unit, we start TPN on day one. Most of the time, the phosphate levels are not measured at all. After 1 week or 2 weeks. But if you see the SPECN guidelines, you have to measure the phosphate level on day one and then have a baseline value and then measure weekly. So phosphate and calcium has to be started on day one if you are catering for babies less than 1 kg. And the molar ratio has to be maintained 1.3 to 1.7:1 in the parenteral nutrition, because altering the ratio will again cause abnormal reports and then it can lead to metabolic bone disease. Magnesium, although least considered, we try to start 0.2 to 0.4. It is useful in case of refractory hypercalcemia. So next important thing is about the acid-base balance. Two good studies which I read during this preparation is ABCs of therapy in neonatology, role of acetate, bicarb, citrate and lactate by Satyan, and uses and misuse of soda bicarb in NICU by Rakesh Ani. Very good article to read. Yeah. So there is another important reason for metabolic acidosis elegans is hyperchloremic metabolic acidosis. Why it happens? Because the renal immaturity, poor acid excretion, high chloride load from saline, flushes and sodium chloride. It is not only sodium chloride which gives chloride, potassium chloride also gives chloride. So hyperkalemic metabolic acidosis is very, very common. What are the side effects? They can cause hypertension, pulmonary vascularization can go high, increase ventilator requirements and the risk of IVH. How to treat this, we will see. Before that, I would like to introduce you about the paradox of soda bicarb. So even though soda bicarb IV will cause alkalosis intravascular, if you see in the diagram, it can cause intravascular alkalosis, but immediately it splits into sodium and bicarb. This bicarb combines with H plus ion to form H2CO3, and with the help of carbonic anhydrase, it splits again to H2O-CO2. This CO2 goes inside the cell, again combines with water to form H2CO3 and releases H plus ion. So there is a paradoxical intracellular acidosis. Even though if we give IV bicarb to satisfy our ego to improve the acidosis, the intracellular acidosis which is causing more harm to them because it can affect the lungs, it can affect the cardiomyocytes. So ultimately the cardiac function can depress. Another important thing is when we give soda bicarb, there is extra CO2 which is released. It has to be removed. So if there is inadequate ventilation, CO2 is already high, avoid soda bicarb. So rather than acetate is more promising because acetate enters into the Krebs cycle in the mitochondria of liver, skeletal muscles and kidneys. In the Krebs cycle, it is converted into bicarb, and 1 millimole of acetate will release 1 millimole of bicarb. So acetate has been used in TPN in many places, in many units, and also as an arterial line infusion. Suppose if you have UVC or an arterial line and you're using saline with heparin, this extra saline can also cause hyperchloric metabolic for which sodium acetate 0.5% mixed with heparin is another alternative and very, very promising. There are a few studies also on this. So most in the future, what we are expected to see is the base trial, bicarbonate for acidosis in very preterm babies in RCT, which is conducted in UK. Around 3,700 babies are enrolled from 23 to 30 weeks. They are going to monitor whether soda bicarb IV in very preterm babies are going to improve the outcome short term and long term. So this is one of our picture of a TPN calculator which is used in EPIC software, where we put all the electrolytes and gives us the amount of calcium, potassium which has to be given as a ready summary. Right? Monitoring labs, ionized calcium has to be monitored, sodium, potassium, ionized calcium 12 to 24 hours, serum calcium and phosphate and magnesium baseline and twice weekly. That is very, very important. So already we have seen about extravasation injury. So peripheral IV avoid calcium and potassium. If you are giving higher potassium, higher calcium, always use a central line. So common pitfalls and how to avoid them. Mistaking physiological weight loss for dehydration. It is expected in elegance, treat accordingly. Giving sodium too early is also not useful. Relying on fixed fluid electrolyte templates, overusing chloride containing fluids, and missing AKI in elegance. So these are common pitfalls, we have to look for them. So this is a sample sheet, like for a day one, a preterm neonate, fluid is 100 to 110, no sodium, no potassium, but calcium and phosphate 1.2 is to 1.1. After a few days, you increase the fluid intake, you add sodium, you change the calcium phosphate to 1.5 to 1.2 and add sodium acetate. In our unit, we use more often sodium acetate compared to sodium chloride. So it's a multidisciplinary approach requiring multiple departments. In our unit, we have the luxury of having the pharmacist preparing the IV fluid and the TPN, but it is not always so. So the take-home message is electrolyte management is dynamic. It is not a set dose. Extreme prematures are vulnerable to electrolyte shift. Fluid requirements are high. Allow for postnatal diuresis. Balance the fluid to promote normal physiology. Avoid overload. Early calcium changes in TFI can impact BPD, PDA, IVH and survival rate. Sodium, no for 48 hours. After day 3, you can start 2 to 3. Later on, you can increase the dose as needed. Potassium, no for first 2 days. Calcium and phosphate on day 1. Avoid soda bicarb. Sodium acetate is promising. The art lies in daily interpretation and not daily prescription. Thank you.
Thank you so much, sir. Such a crisp presentation and covering all the very important topics. Thank you.
Thank you.
Now I would like to request Dr. Suchitra ma'am to hand over memento to Dr. Nishant sir. Thank you. Sir, I have a question. Sir, nothing, sir. You told that to avoid sodium in first 48 hours, but we used to give something like half saline for Elgan babies with the arterial line. Should we avoid it or should we give something else?
That's right. So this is like avoiding sodium in the maintenance fluid.
Okay,
so,
sir.
So we can't avoid
Yes,
half
sir.
saline and arterial line. That's why instead of half saline, you can use sodium acetate also.
Acetate. Okay.
Acetate if it is available. That is very important. So what I spoke was about the maintenance fluid.
Okay.
Arterial line is hidden sodium. We can't avoid.
Okay. Thank you, sir.
Thank you.
What calcium salt you are giving in the day 1? Calcium as a salt, which one is giving?
Yeah, calcium chloride we don't use. Calcium gluconate in the maintenance.
Calcium gluconate.
Gluconate only.
And also about phosphate, you told that means usually organic phosphate we use it. So is it available in Dubai?
So we are using sodium glycerophosphate.
Oh, nice.
Which is available and we start from day 1.
Oh. So, thank you so much, sir. For the next session, we have a panel discussion that is continuity of care. What happens after NSU discharge? Perspective from neonatologist, developmental pediatrician, and nurse. We have a panel discussion. So we have a panelist by Dr. Ramesh Chaudhary, sir, Dr. S. Srinivasan, sir, Dr. Deepika Rastogi and Miss Palani Ammal and Dr. Shishir Agarwal. To moderate the session, we have Dr. Ruchi Rai.
Good afternoon, everyone. So after hearing to those excellent talks, which were very high on technical aspects, finer nuances, technological aspects, we'll be talking about another thing which needs to be equally intensive, because all of us are always talking about intensive care in the NICU. But once we have adopted those intensive steps carefully, like the esteemed speakers have spoken, and we are finally able to discharge the baby. So how do we make sure that the baby whom we have cured or made it possible that we are now able to discharge, how do we make sure that the baby goes home safely and remains safe and healthy even after discharge? So we'll be having a panel discussion for the next 40 minutes in which we'll be discussing different aspects of Okay, so we'll be discussing about continuity of care, what happens after discharge. So once the baby is saying, okay, I'm going home, and we were with the baby, maybe over with the baby, we are spending too much time with the baby, everybody is hovering over the baby, constantly monitoring, but now the baby will go home with the parents, with the family, into the society, and will no longer be surrounded by monitors, nurses, and doctors. So so we need to provide a continuity of care irrespective whether the baby is discharged after the illness is over. Sometimes babies go home before we are ready to discharge. They may go discharge on request, and unfortunately some babies may leave your hospital against medical advice. So we need to provide continuity in all the cases. So the ambit of continuity of care would include nutrition, growth monitoring, danger signs, vaccinations, neurodevelopmental assessment, and regarding medication, when to stop, how to taper, whatever. Then screening needs to continue even after discharge, And we also need to understand that some of the babies, like babies who are on severe encephalopathy, some severe metabolic syndromes, some genetic syndromes, may have to be provided palliative care also at home. So ultimately what happens is there is sometimes discontinuity of care. The follow-up care becomes so crucial for their survival, and this is the most neglected aspect. So the family is left without any support. The health literacy of the family is poor. There is lack of expertise in the peripheries. And the traveling may be a challenge for the parents to come back to the parent hospital again and again, and they do not know whom to contact in case of an emergency. So some of these aspects we look after. India is a vast country with very diversified health setups. So different needs are there for different hospitals. So coming to the first question to Dr. Shishir Agarwal, sir, what are the what babies do you think discharged from NICU will you like to give special attention to?
Baby discharged with second or third grade HIE or with gestational age less than 34 weeks, or babies suffering with inborn error of metabolism, twins, triplets, ELBW, VLBW, we need to keep a close monitor on such babies.
Okay, so all the units should have a definite guideline what babies we are going to follow up in the high risk clinic, and plus the clinician's decision would always be the last. Some categories which are not included in your list, you may still like to call the baby for follow up. Okay, now we next come to the next question when we are about to discharge, and this is a big lacunae. What we are trying to make the parents understand and what they are actually understanding of what we are trying to tell them. So, Ms. Palani Amal, how will you like to counsel the parents of the baby who are being discharged from NICU?
Yes, ma'am. Counseling we have to start on day one. It's not at the time of discharge. If you counsel on the day one, it will be easy for counsel at the time of discharge. We have to educate all the skills on day one. So first of all, we have to explain the baby's condition. So far the baby is stable, so we can be discharged, and still baby needs monitoring when they go at home also. That we have to educate them, and we have to teach essential home care skills, like if baby is taking palliative feed, we have to teach about how to give palliative feed, after feed how to burp. If they are giving direct breastfeed, we have to teach how to latch and proper positioning, and also we have to highlight the warning signs. So when they go home, if baby is not active, if baby is not sucking properly, and if baby has no urine output, or baby is having low temperature or high temperature, seizure, abdomen distension. So this, everything we have to teach them. We should not ask them to get fear, but they should have the awareness about the danger signs, so that they will identify the danger signs and they will bring the baby to the hospital on time. And also we have to demonstrate hands-on skill. It's very, very important. Many of the babies are preterm and low birth weight babies. We will be discharging at 1.8 kg. So apnea is one of the common problem in preterm babies. If baby is going to apnea, we have to teach how to stimulate. If baby is not responding to stimulation, we have to educate how to do Bahan mask ventilation. So we have to demonstrate how to give, and also the re-demonstration. So they will be having competent in doing those things. And also follow-up care, we have to educate them and review the discharge checklist. So in the discharge checklist, everything we have to mention what are the treatment we have given and what are the medications baby had taken, and also what has to be continued at home. And support emotional readiness. So that's why I told from the day one itself, we have to educate them so they will be ready at the time of discharge. And teach infection prevention at home. It's very, very important. Hand hygiene, we have to tell them before handling the baby, they have to wash their hands, or they can use the hand rub. So, and also we have to tell when to use hand rub and when to use hand wash. So if their hands are really soiled with urine, stool and vomiters, anything, blood, so definitely they have to wash their hands. And also we have to tell about the visitors, strict visitors, nobody should allow, and only the close relatives. And also the relatives should be free from any infection. If they are very illness, avoid to contact with the baby. And provide the written instruction, that is again the same, that is discharge summary, and ensure the parent competency before the discharge. That's all.
Okay, thank you, ma'am. So we need to be careful that there are no language barriers. Whatever we have taught them, they have actually understood. We may try and ask them, what have you understood? Can you demonstrate how the medication has to be given? So ma'am, can you again highlight what all extra points will you like to tell the parents when the baby is going home about the care at home?
Yes, ma'am. Previously, I told about the feeding, palliative feeding or direct breastfeeding. We have to teach them how frequently they can feed the baby and how much duration. So frequently means at least 8 to 10 times in a day they have to feed. At least if direct feed means they have to baby has to suck until the baby is satisfied. We cannot fix the timing, but everybody will say 10 to 20 minutes they have to suck. But until the baby satisfies, the baby can take feed. And also temperature is a very important one. We have to advise the mother how to keep the baby warm and teach how to swaddle the baby, and they have to use the mittens, and also how to check the temperature with our dorsum of hand. They have to see whether the extremities are cold or not. They should identify whether baby is having temperature high or low. And also sleep pattern. Baby has to sleep at the back, not at the prone position. And again, infection prevention, then medication and supplements. So we'll be advising the drops and vitamin supplements, and they should know the dosage or how many drops they have to give, whether to mix with the feed or directly they have to give. Then everything we have to teach. And monitor for early warning signs, that is already I have mentioned. And Gangar mother care also is very important. And we have to teach how they have to keep the baby on position. Usually we will be continuing the Gangar mother care at the NICU, so they will be understanding how to give at the home also. So who all can give, how long to give, and when to discontinue. Then everything we have to teach, and what are the benefits also. And weight gain monitoring is very important. That is the one sign whether the feeding is adequate or inadequate. And immunization at the time of discharge, all the baby will receive the BCG, polio, and hepatitis vaccine. So the next follow-up we have to advise, we have to return in the discharge summary. And definitely we have to give the emergency contact number. If they find anything emergency, they have to contact the emergency number, or they can go to the nearest hospital.
Okay, so two things are very important: what we tell the parents and how we tell it to them. It will make a long impact on how safe the baby, how healthy the baby remains, and how frequently the parents bring the baby for follow-up. So my next question is to Dr. Ramesh Chaudhary. So what supplements do you give to your babies at discharge, until when should we continue these supplements?
So, ma'am, supplements needs to be individualized and tailored. And one of the most important supplements what we are giving, that's vitamin D, iron. And besides that, we may choose to give calcium, phosphorus. In some specific situations like cholestatic baby, we can supplement additionally with vitamin K or E, and sometimes zinc as well. Regarding the doses and duration, so duration is always a bit issue. Even in the guidelines, there is a research gap. But for the iron and calcium and vitamin D, it should be between 6 to 12, and to be tailored as per the baby's next supplementation level. What about the complementary feeds? Are they adequate to match the growth and to maintain the levels of the hemoglobin and the ferritin? So we must not stick to the dead guidelines, but in fact we have to monitor each and every baby individually till they are within the prescribed range of normalcy. So we have to go for the vitamin D and iron, and most of the time the babies who are on breastfeed, they actually needs. Sometimes if baby is being discharged on a special formula or with HMF, because in the government setup, sometimes we discharge at 1.5, 1.4 if the baby is on self-sufficient feeds. In that case, if we are providing with HMF, then there is no need of special supplements in the form of medication till the baby is shifted to the breastfeeding.
Okay, So thank you, Dr. Ramesh. One thing important is that when we prescribe the supplements, we must make sure that the parents understand how to give it and what pharmacological preparation we have prescribed, because iron preparations are available in different concentrations. So some must be 25 milligrams per ml, some is 10 milligrams per ml, some is 20 milligrams per ml, and sometimes the drops are replaced by syrups which have an entirely different concentration. So you prescribe them 1 ml of iron drop and they will be giving 1 ml of the syrup. So that every time we must insist that they should bring, because whatever preparation is available near your hospital may not be available at their hometown. So we must always ask them to bring all the medications that they are giving to the baby on each visit. We must always cross check with the mother how she is measuring, what preparation she is measuring. So that is extremely important that we emphasize upon. Then the next question goes to Dr. Shishir. How do you organize a high-risk follow-up clinic for discharged neonates? And there are a lot of things which we talk about idealistic, but and what practically is it possible? So we like, sir, you to highlight on this aspect of
Follow-up clinic is really important part, especially in the newborns and especially in the preterm clinics. And for follow-up clinic, a day once a week should be decided, at minimum once a week, maybe twice a week. And whenever the baby is coming for that particular day, maybe Saturday or Sunday, then pediatrician, neonatologist, social worker, then physiotherapist, then developmental therapist, different kind of therapist, even if possible in a bigger setup like genetic counseling, that can also be done. Sepsis screening, if required, can be done. So these are the things which can be set up, if possible, in a tertiary care center for follow-up clinic, which will prevent these newborns. Thank you.
So at least dedicating one clinic for a follow-up purpose is mandatory. If we just club all the babies together in routine OPD, you can never actually follow them up properly. So you must have a follow-up booklet, a fixed protocol, at least 2 people to look after the babies, and sometimes you can coordinate it with your ROP clinic. When is the ophthalmologist doing the ROP screening? So we must try and minimize the visits. It is not that one day you're calling them for follow-up in neonatology, other day the baby is coming for ROP, the third day the baby is coming for an ultrasound skull. We try and club it so that the baby's visits to the hospital is minimized. Ms. Pilani Amal, can you elaborate on how will you assess? The first thing we need to assess when the baby comes for follow-up is what feeding are you giving and how are you feeding the baby? So how do you assess the feeding of the baby in follow-up?
Yeah, when they come for the follow-up, we have to assess the feeding frequency. I already told they have to feed at least 8 to 10 times. If mother says, I am feeding only for 5 to 6 minutes, it is inadequate. Usually, all the mother will have the doubt whether my milk is enough for my baby or not. So we have to educate them. They have to, if the baby is, if your milk is adequate, the baby will go for sleep at least for 2 to 3 hours. And also they have 6 to 8 wet diapers, and automatically, obviously, they will be having the weight gain at least 10 to 15 gram. So we have to ask them about the feeding frequency and the duration. Duration means already I mentioned, until the baby is satisfied, they have to feed the child. And check for feeding cues. The mother should know about the feeding cues like rooting and hand to mouth movements. So she should not wait until the baby cries. Whenever she seeing the cues, immediately the mother has to feed the child. That we have to educate them and ask them whether they knows or not. And if possible, you can evaluate the latching and the positioning of the baby, whether the full areal of the baby's areal is within the baby's mouth, and also the position. Different types of position we are using football. If baby is preterm, they can use football method. So this and all the education we can give at the follow-up time. We can assess, and according to that we can educate them. And also milk transfer and output indicators. If they are giving in the palatal feed, how they are expressing, how they are storing, and after storage, how they are thawing everything. We can ask. And also weight gain is very, very important. If weight is not improving or gaining, it is the indication is they are not feed the baby properly. And also observe the baby behavior after feeding. So after feeding, how the baby, that is baby goes to sleep or not, or whether baby is having irritable cry. And also not only that sleeping, if baby is crying, what is the reason for crying? Baby has to see. So the one thing is, if baby has hunger, baby will be crying, or baby is having pain, they will be crying, or they are having wet diaper, they will be crying. These are all the things the mother should know. Or if any insect bites also, baby will be crying. They should not ignore. And also, whatever the mother says, we have to accept and we have to give immediate attention, because she's the one with the baby for 24 hours. And ask about the problems during feeding, whether both side, mother side and the baby side. In coming to the mother side, whether her nipple is flat or inverted, or the nipple is correct in position, or sore nipple is there, breast engorgement, anything. And coming to the baby side, when during the feeding, how the attachment, or baby is having choking or coughing, anything. So, and review the supplemental use, whether they are taking the medications regularly. So by asking those questions, if there is any lacunae, we have to correct them in the correct way.
So if we have counseled the mother well during the NICU stay, that is half the task done. So if we have counseled her well, we have addressed to the issues she was having at that time when the baby was inside the NICU, I think we have done half the job. So if we have counseled them well, the mother is likely to continue good feeding practices even after discharge. And one important thing is that feeding is such a thing that everybody in the family should be counseled about. So many times we have seen that the mother is convinced about something, but the father may not be, or the grandmother, or the bua. Also, every member of the family who is a stakeholder in the family must be counseled together, and just counseling the mother alone may not solve the purpose. So Dr. Deepika, once we have assessed the feeding, now the next step goes, the first most important thing we do in the OPD is to monitor how well the baby is growing. So how do you monitor baby's growth and follow-up, and when do you consider that this is a red flag?
Hi, good afternoon. Thank you, ma'am, and thank you for all the organizers for including us. So I think once they're discharged from the NICU, the growth monitoring is a very, very critical and crucial part of their monitoring. We all, in the previous sessions, we've talked about daily weight monitoring. So on follow-ups, we usually say that whenever the child is coming up, the growth or the anthropometric parameters should be closely monitored, including weight, length, head circumference. Initially after discharge, it might be a little earlier, like every 1 to 2 weeks. And then most of the time they are on routine vaccination visits when the intent is not to just give the vaccine, but to assess the infant in a wholesome way, starting from anthropometry and going on to the development. Plotting these anthropometric parameters on specific preterm growth charts is very, very critical, I feel, because most of the time the faltering that is happening could be actually iatrogenic depending on which growth charts you're using. So I feel it is very important for each unit to identify the growth chart that has been used for the baby at the time of birth. A preterm growth chart, we have many. Fenton's, I think, is the most commonly used, but recently we have had Intergrowth 21st Century. That was the international growth standard for fetus and newborn for the 21st century, which is more realistic, more global. But I would say identify a unit-specific growth chart and continue to monitor that, because extrauterine growth restriction is something that we really fear for these preterm infants or who were born growth restricted. So plotting and seeing a growth faltering would be the biggest red flag for me on an OPD basis. But apart from that, we've already discussed that, how the feeding is going, how many times is the baby feeding, are there any signs of feeding intolerance noticed by the mother? There are again red flags when it comes to growth for a preterm infant on follow-up. Apart from that, compliance to medications, which has been reinforced with the previous questions, is again a very important part. And looking actually at the composition and looking actually at the medication which is being given, syrup versus drops, the concentration, brand differences should always be looked into on follow-up. Early identification of growth faltering and the underlying cause that could be feeding, issues, which could be because the mother has limited understanding or the family has their own social taboos, or could be because of something which is pathological related to the infant, should be identified at the earliest.
So completely agree, Dr. Deepika, that however dreaded illnesses we have dealt with, and the baby is now out of his acute illness, then we start struggling with the extrauterine growth retardation, which is so common. So the baby just fails to, run parallel to the line which we want the baby to run. So that is extremely important. And coming to the growth charts, There has been a lot of debate what growth charts should be used, which is better. But I think just sticking to one growth chart, like Dr. Deepika emphasized, would just be sufficient. The main thing is that you should monitor. You should have those growth charts in your follow-up OPDs. You must have the small equipment, maybe a measuring tape for the measurement of the head circumference, an infantometer to take the length, and a digital weighing machine to weigh the baby. If you do that, then irrespective of whatever charts you are using, you will be able to identify the growth faltering earlier, and then you will start addressing it. So my next question goes to
I just wanted to add that the best way that we use in our unit is that the growth chart that was used in the NICU at the time of birth, we just hand it over and we continue it on follow-up, and we ask the parents to carry it. That is the easiest and the best way.
Yeah, right. So that's what I think most of the units are doing. We just hand it over to the attendants so that they bring it at every visit and we correct. So, sir, Dr. Srinivasan, sir, how will you, once you have identified that this baby is not following the chart which you want him to follow, how do you address growth faltering in these babies?
See, growth faltering, let us take our country, where 25% of the babies are going to be SGA babies, 11 to 12% is going to be the preterm, and 2% is going to be the below 1.5 kg baby. The salvageability of below 1.5 kg is come around 50 to 60, 70% in the country now. So these are the vulnerable babies, they are going to have a growth faltering. When I talk about growth faltering, I want to classify into two. One is called severe growth faltering, another one is called complex growth faltering. So what is the difference between severe growth faltering and complex growth faltering? In severe growth faltering, this is the study done in Poland and Canada. What they have found, the severe growth faltering, mostly the SGA babies and those babies with NNEC sepsis are going for it. While the complex growth faltering is nothing but where there is a loss of weight, height, and head circumference. In severe, where the weight alone is less than 2 Z score, when you take complex, it is less than 1 Z score of weight and height and head circumference. So when you want to go and assess this growth faltering, I think the pediatrician should have a knowledge what has happened in antepartum, what has happened in intrapartum, what is happening in the postpartum also. You should take all the comorbid conditions of the mother like diabetes complicating pregnancy, hypertension, PAH, antepartum hemorrhage, any chronic debilitating illness in the mothers which is causing the fetal growth pattern is lacking. That is point number one. Whether the baby needed any resuscitations during the birth, that is point number two. And the study has found that there are babies who stayed more in NICU and those babies who needed more ventilation, where they found the growth faltering is there. Similarly, babies with BPD and retinopathy of prematurity also, they found a lot of growth faltering. So, if you want to analyze a growth faltering of a baby, there should be an anticipation of high index of suspicion when you are discharging the baby. This is the baby who is going to have a growth faltering, which I am going to monitor. As Deepika told that there are two charts previously, any chart which is convenient to the people, they can use it, maybe a FEN10 or maybe a IG21st. But one of the advantage of IG21st is even the field level, so you put the head circumference, put the length and put this one, automatically it shows where the baby lies, what you have to do, what class has been done, that you can see. So this is what you can assess the growth faltering regarding this. The next slide, please. So what is how I'm going to address? See, now we may say that breast milk is the best milk. Yes, most of the babies you have to go for breast milk, that is antepartum counseling. I always prefer a antepartum counselor rather than a lactation counselor, because lactation counselor takes part only after the mother is in agony, when she has delivered the baby is sick and she is in distress state, and that is the time I'm going and counseling the mother. I don't think so. It happens, it really corrects many things. I always prefer an antepartum counselor where the mother will be taught how to feed the baby. Once the baby is sick, what sort of feeding you should do. So I always give preference to the breastfeeding. That's why in Tamil Nadu, I have started 50 human milk bank in Tamil Nadu, 20 CLMC and 25 LMEU. Another 5 I'm going to put in the next week PIP program to the government of India. And all these LMUs and CLMUs are really running well, where I'm getting almost 1.5 to 3 liters per milk every day. 15 to 20 mothers are giving and 15 to 20 babies are getting benefited because of the human milk. The next one I will go for is finally only the formula milk, which generally in Tamil Nadu, I have 1,20,000 babies getting admitted in 1 year. 52,000 babies are going home. They are the low birth weight babies. We never give any formula milk to all those babies. all these babies are managed only by the human milk and milk bank. Of course, there are studies where MOM is better than the donor milk, but still we go by the donor milk which is available. That is what we are doing. So growth faltering, that is, and they are going to be their future SAM children also. That's what WHO says, that you can diagnose SAM even on second month by just see if the baby has got a 48 to 49 centimeter length and he comes under less than 3 standard deviation of weight for height, you put them under SAM. So now we have come to, in fact, I have done a study, 100 children I have studied, why SAM is coming within 6 months. My study showed that most of them are 4 reasons. Number 1 reason is the child has got congenital malformations. Number 2, the child has got recurrent infection due to some immunodeficiency. Number 3 is the faulty feeding techniques. So what we have found, what generally say faulty feeding, now no, the other comorbid condition in the child is causing a growth faltering. So I think the best is go for a more of human milk banks, or at least LMU, where the milk storage can be done. That will solve this problem of growth faltering. Of course, advising the mother in the postnatal period. I will be telling the next slide what we are doing in the follow-up also.
So commendable work, sir, you are doing, and we will look into the possibilities if the UP government can hire you from the Tamil Nadu government to improve some statistics.
I visited Varanasi for 3 days for Sankalp program and gave all these.
No, sir, we love to have you for a longer time, for months, probably for a couple of years, to bring up or to bring down the mortality. And so after feeding, the next question that we always ask about is how is the baby doing neurologically? So Dr. Ramesh, how do you perform the evaluation of the baby, neurological evaluation, and the baby comes to you in follow-up?
So, ma'am, before going to the follow-up, our first neurological examination that's detailed must be just before discharge. On the day of discharge, it should begin. Then, it should be ideally done when the baby is in optimal state, because we cannot examine when a baby is sleeping or agitated. So, he should be 2/3 way in between the feeds. He should be in the wakeful state and calm. We need series of examinations, not limiting, starting on the day of discharge. Then otherwise we are going from home visits, but for the neurologically 3, 6, 9, 12, 18, 24 months. And why we wanted to detect an early intervention. Is there any point where if baby is lacking in the development, lacking in the growth, we can intervene. And next thing is that how to go for it. We look for baby's state, position, posture, and moreover, don't forget to look for the tones, baby's tone, symmetry of the movement, easy cranial nerve functions, and easiest for everybody who is even sitting, who is not even trained neonatologist, just assessing the adequacy and completeness of the breastfeeding will serve most of the cranial nerve tested at a single go. We keep on teaching Moro's primitive reflexes, but once baby's breastfeeding reflex, it tests so many cranial nerves. So that should be emphasized. And above all, don't forget to look for the head and not to miss the spine, because they are very important containers. Head is growing more slow, sutural override, fontanelle level. So they must be looked for. And important is to tool. You may use Hein or Dasi, because NNF recommends Dasi and Hein. So we may go for any one of them.
So very important when we do a neurological examination is like winters which are on in the northern part of the country. So in the northern part of the country, we are having winters and the babies come covered in clothes. And many times we are examining without, and the cap is always universal. The baby will always have a cap on. So sometimes it happens that you never remove the cap of the baby and hydrocephalus was missed, or a rapidly rising head was missed, or a overriding of the sutures is missed. So we must completely undress the baby, not completely, but undress the baby is sufficient to neurologically examine. And for that, you must have your room temperature warm enough so that you can remove the extra clothes, the blankets, and then you can examine the baby. You want to say something else, Dr. Ramesh?
So that can be only done in an organized follow-up clinic.
Yeah.
That should not be mixed in a general OPD,
because in the essential discharges, because lot of the babies, now lakhs of babies are being treated in the SNCUs across the length and breadth of this country, and there we need a dedicated follow-up clinic which ensures all the domains, not a single domain.
Definitely. So a structured follow-up will help us in detecting every problem that the baby may be having, or will also assure us that the baby is doing well. So Dr. Shishir, how do we assess the development of a baby? So one aspect is a neurological aspect. This is also another aspect of the nervous system. How will you assess the development when the baby comes for follow-up?
Madam, as far as assessing the development of the baby is concerned, this question has already been answered by 3 panelists in a very detailed way. Nothing much less to be added to it, but I would like to add that on every follow-up, vision examination in the form of ROP and ear examination in the form of BERA should be done, which was probably not covered. And age for gestational age, weight according to the growth chart, lactation should not be overlooked. We need to have a lactation counselor, and we should try that the mothers are being checked whether she is feeding well or not. If the baby is not gaining weight according to the age, if there is not weight gain, then we need to do counseling. Lactation counseling is something which is very important, which I have felt in my private practice, in my practice in the rural areas, that improper lactation leads to formula feeds. But if we do a proper counseling of lactation to first mothers who are becoming mother for the first time, if proper lactation is there, then the baby doesn't fall ill much, and the weight gain is also better. That's rest. Everything has already been covered. Thank you.
So we were talking about developmental milestones. So this development, when we assess the milestones of the baby, we must understand that if it's a preterm child, we need to know what is the actual corrected age of the baby. We cannot assess the baby as per the chronological age. That is very important. And we must also keep it in mind that when we ask the mother, कि क्या बच्चा पहचानता है, does the baby recognize you? Sometimes the parents are more optimistic and they falsely tell you, even when you can see that this child is not that it's not possible that a child recognizes, but they will still tell you, no, whenever I come near the baby, the child recognizes me, the child smiles, or they will say that this child tries to make some sounds. So you must take history from the mother, but then you should also try to assess yourself. And again, as I said, that all domains of development must be assessed, and we must also understand that the development of the baby may be affected by the hearing and the vision of the baby. So if the vision or the hearing is affected because of some other reason, maybe the development of the baby is okay, but these may impact the ultimate development and the baby may get developmentally delayed. So Dr. Ramesh, coming to another very, very important aspect, what will you like to tell the audience about the vaccination of babies, especially preterm and low birth weight babies when we are discharged?
As the time is running, to cut short, vaccination as per the NNF, IAP and NIP, it should be as per the chronological age.
No, we have 7 more minutes. Yeah, I don't know. This is showing wrong. Okay, please continue.
So, vaccination should be as per the chronological age of the baby, not as per the preterm or low birth weight. Second one, we must address to the still prevailing confusions. Baby is very tiny, fever is running, we should delay. Baby's muscle mass is very low, how to administer. So we just look that they should be administered as per the chronological age. With special emphasis, they should be stable. And they must be monitored, especially those babies, those who were on ventilatory care or they were having some neurological disorders. So no baby should be going home without vaccination. They should be vaccinated on the day of discharge. And regarding hepatitis B, if the mother is hepatitis B positive, irrespective of the baby's weight and age, they must be given both on the different limbs, hepatitis B immune globulin, as well as the hepatitis B immune. And they must not be counted for the routine doses. And important about the pentavalent or hexavalent, whatever the parents choose, they should be as per the chronological age.
Okay, thank you, Dr. Ramesh. So, as per the Government of India guidelines, hepatitis B birth dose can be given irrespective of the birth weight of the baby. and the rotavirus vaccine can be given till 1 year of age, the first dose. So, Dr. Deepika, how do you continue to screen babies from discharge from NICU?
So I think again this question has been answered in its pieces in the various questions. I think it's important to have a framework of follow-up for these babies, either in the form of a preterm checklist. Like in my unit, I've made a preterm checklist, which again I start during the NICU course and hand it over to the parents so that they know what all head to toe has to be followed up on OPD basis with their proper dates. Now, coming back to the question again, if we want to answer it specifically from head, maybe if there were findings of IBH or there was post-hemorrhagic ventricular dilatation or there were findings of early PVL changes, then we can just follow them up with the routine, apart from the routine examination and the head circumference, we can give them follow-up dates for a review head ultrasound, maybe plan a MRI. If MRI, I usually consider doing a MRI if I see developmental faltering, and preferably around 1 to 3 months of corrected age when all those changes have already happened, the neuroplasticity has set in, and some form of myelination has also started. ROP, depending on the stage of ROP at the time of discharge, it might be 1 to 2 weekly follow-up. When it comes to hearing, we do the hearing screening in the form of OE or ABR at the time of discharge, and we prefer doing a BERA on follow-up at 1 to 3 months of corrected age. Pulse oximetry screening must have already been done for the heart. If there were some findings on the echo, maybe a review scan can be done around 6 weeks. Metabolic and growth monitoring is again a very, very important follow-up that I usually consider for these extreme preterm babies, depending on what was the last level of alkaline phosphatase, just to optimize their growth supplements. Anemia of prematurity, again, just to optimize the supplements, see the trend. And it is very, very important also to monitor the blood pressures. Preterm babies are at very, very high risk for hypertension, and because of all the medications that they have received during the NICU course, that also puts them at risk for nephrocalcinosis. BPD is another risk factor that puts them at risk for nephrocalcinosis. So if our baby is going home before 36 or near-term corrected age, like Sir mentioned, that many times because of the financial issues, our babies are going much earlier than what the Western, preterm babies are going home. So then ultrasound of the kidneys and blood pressure is another thing that I keep on my checklist to be followed up.
Okay.
There are different frameworks that are available. If someone doesn't have a unit-specific checklist, you can use all those frameworks. Even IEP and NF has some. AP has recently given a very good framework that to be used for follow-up of these NICU graduates.
Thank you, Dr. Deepika. So, sir, once we know what to see on follow-up, but the parents are still not able to come. One thing is, how do you ensure that the parents come for follow-up?
I think this is the problem country is suffering, madam. So many newborn babies after getting discharged going home. We see many post-neonatal deaths also. So how to improve this follow-up? I am in the field for the past 15 years, since 2010 and 25. I have developed 3 follow-up. Each one I am not able to successfully doing. The first one is what I did is phone tracking. I made the necessary necessities to talk to the mothers. I purchased a phone and gave them numbers for each and every SNCU. Talk to the mothers every day. Some nurses are talking, some mothers are responding. It's not doing well. Then what I did is through the ICDS, which is called Chalatule scheme, that is otherwise called Pet Child scheme, where the CDPO, Child Development Project Officer, will visit the postnatal ward. In a district, 12 blocks will be there. 12 CDPO will come to the SNCU every one day, and they see the postnatal ward and see what babies are getting discharged. They will give the WhatsApp message to the concerned Anganwadi. The Anganwadi will take care. That is what we say we do as called Pet Child scheme. This is what Government of India is recommending as HBNC, Home-Based Newborn Care. But still I am not fully satisfied. Now I have come out with a new scheme where you can see what is called the baby kit, which our Honorable CM is going to inaugurate in another 2 weeks. I'm not supposed to publish here, but still for the part of conference I put this picture. This is what the baby kit designed by me. In this baby kit, I have 2 vitamin D and 2 iron and multivitamin drops will be given for the 52,000 low birth weight babies who are getting discharged from the SNCU. And these low birth weight babies, I am spending an amount of 8 crores for this. And in this, I have the card, which is what Madam Deepika was telling, the height, weight, saturation, everything will be there in the card. And I am making the baby to come to the facility follow-up. Rather than the community follow-up is there, I want the baby to come back to the facility follow-up. Can you put the next slide, please? No, I put one picture also that maybe the picture is not there. I have given a specific cartoon book in that. In the cartoon book, on one side you will have your green papers, on the other side are the red papers. The red papers I have put 12 red flag signs, and the green paper I have put 12 developmental signs. Now I am depending on the mother to educate, rather than depending on Anganwadi, Asha, staff nurses, CHC. I am going to educate my own mother, where I put the picture in cartoons. What is lethargy? What is convulsion? What is cyanosis? What is jaundice? What is hypothermia? Everything in cartoon picture. That book we have designed now. Now we are going to publish it through our Honorable Chief Minister. That will be put into the bush. So these babies will come every month with this kit to the facility and get all the things filled up, then go back and come back, go back and come back, so that my well baby clinic, which has been established in SNCU on the block level, will see to that they are seeing these babies at least for 6 months. This is the one mechanism I'm going to implement in the next week in the state of Tamil Nadu.
Thank you, sir. I think this was you were the most appropriate person to answer that question. So since we are running short of time, we had a question on RSV, but I think Dr. Deepika has a dedicated lecture on that. So we can skip the next two questions. And so the need of the hour would be sensitization of the healthcare workers regarding need of baby after discharge, a home-based follow-up, and probably, as sir said, we can encourage them to come to the center for follow-up. Better communication, maternal training, parental education, emotional support will go a long way in bridging the gap of follow-up that we normally observe. Thank you so much.
Thank you, ma'am.
I thank the esteemed panelists for enlightening us about different aspects of follow-up.
Thank you, ma'am. Now I would like to request Dr. Ruchira, ma'am, to present momentous to the panelists. Thank you. Now I would like to request Srinivasan sir to hand over memento to Ruchira, ma'am. Next talk is on palliative care in the NICU, focus on practical applications. Talk by Debashish Nanda sir. To chair the session, we have KTV Lakshman sir. I would like to welcome Dr. KTV Lakshman sir. And sir, can you introduce Dr. Debashish sir? Thank you.
Yeah. A warm welcome to all the delegates from Visakhapatnam. I'd like to introduce our next speaker, Dr. Debashish Nanda sir, who is working in the Department of Neonatology at SUM Hospital and IMS at Bhubaneswar, and he is a PC Srivastava Memorial Best Outgoing Student for the DM resident, and contributed majority to FBNC and NBSU NSK modules, and a national trainer for FBNC and NBSU and SSK. He's a national instructor for IAP and NF Basic and Advanced NRP. He has got 35 publications to his name, and I would like to, no more waiting, we'll start the next session. Thank you.
Thank you so much. I would like to thank the organizers for the opportunity. Thanks to Dr. Vinay and also to the previous speaker, Dr. Ruchi, who was presented, and there was an extensive discussion on the post-discharge care of the baby. So my topic will be, you can say it is just the opposite of what Dr. Ruchi has described. So what if we have a situation where the current existing care, whatever we have, is not going to improve the baby's outcome, or the chances of survival of the baby is very minimal with the currently available treatment options? And what if the baby is going to suffer severe low quality of life after being taken care by the currently available treatments? So what is the option we have? So the answer here is palliative care. So unlike Western countries where we have a very team, there is a team, dedicated team for this palliative care of newborn babies. So the care is not that much very well developed in our lower and middle income countries, in India and also in other LMICs. So to begin with, so these are the learning objectives. So to define what is palliative care in neonates and to differentiate it from giving up, identify who are the actual candidates for which this palliative care is needed, and understand the spikes protocol, which is mainly needed for counseling, and understand the principle and management of various symptoms like pain, breathing difficulty, agitation, what we call it as symptomatic management or management of symptoms. Then briefly we'll discuss something about the ethical concepts regarding the neonatal palliative care. So as the care in NICU has advanced in last decades, so the survival of extremely preterm babies and many babies who are having life-threatening conditions has improved. But at the same time, the babies where the treatment options are limited or the therapeutic options are limited, the process of death or the dying process is being delayed with the currently available treatment. So this is a paradox because advance in the technologies can save the smaller babies, and at the same time it can extend the dying process for some of the babies. And if you see the statistics, there is a substantial number of babies who die in NICU mainly after withdrawal of support. And so we are shifting and we are moving from survival at all cost for all neonates to survival with a acceptable quality of care, quality of life. So to define, so WHO has defined a holistic definition for this palliative care, and this is mainly applicable for pediatric patients and it can be extended to the neonates. So palliative care for children is an active total care of the child's body, mind and spirit, and also it involves giving support to the family. So here the important concept to understand is that it begins at the diagnosis of a disease. So severe life limiting conditions, so it begins at the diagnosis and it continues regardless of the treatment options what we have, and it persists throughout the bereavement process. So what is our goal? Our goal is to prevent and relieve suffering, not necessarily to cure the baby. So when I was doing my DM courses, so there was a long question used to come regarding end of life care, and if the textbook, if you see the standard textbook, so only one page is available in the standard textbook. So the end of life care is something which is different from palliative care. So palliative care is a broader concept and end of life care is only part of the palliative care. So that is a very important concept to understand. So palliative care, it begins at the diagnosis of a life limiting conditions, and end of life care, it is basically the care around the time of death of the baby. And the goal of palliative care is to improve the quality of life and symptomatic control, which I already have discussed. And the goal of end of life care is comfort during the dying process. So the curative intent, it can be concurrent, means at the same time we can give the concurrent treatment for curative treatment and we can continue the life prolonging treatment. But in end of life care, usually we withdraw the life supporting treatments. And focus is basically living with the illness, and in end of life care, dying with dignity. So if you see the conceptual framework of this palliative care in neonates, so it is extensive. It is not limited to the end of life care. So you can see there are many subsections in this. So it is not only related to the symptomatic management, but also at the same time, we have to take care of the maternal bond, emotional aspects, family-centered care, and comprehensive treatments like we have to take care of the psychosocial aspects, spiritual aspects, and we need to integrate the care which is started early during the course of the disease, and it would persist during the bereavement process as well. And in some of the cases, it can be also extended to the antenatal period. If the baby's condition is diagnosed in the antenatal period, for example, the baby is having anencephaly, so in those cases, it can be also extended to the. So, just briefly discussing the changing paradigm. So, the old concept is that, so once the baby, we are not able to cure the baby, or we are not able to achieve the curative options, then the palliative options come. So, both are in the different direction. So, curative treatment is in one direction, and palliative care is in the other direction. But with the changing paradigm, now you can see both palliative options and curative options are concurrent. That means both the treatment options can be started and continued at the same time. And if the curative options are decreasing gradually, then the palliative option is gradually increasing. So this is a new concept, and that need to discuss certain myths versus facts. The myth is that palliative care means what we are doing is we are doing nothing. But it is fact. The fact is that it is active medical management of symptoms, and the myth is the pain medications kill the baby, and fact is that appropriate dosing and management of symptoms, it actually without hastens the death. So there is a double effect, and parents lose hope, but actually the fact is that the hope shifts from cure to peace and comfort. So what are the categories of baby for which this neonatal palliative care is indicated? So basically we have three categories of babies for which it is indicated. So category 1, it says that if the baby has a inevitably lethal conditions where cure is physiologically not possible. For example, if the baby is having bilateral renal agenesis, Porter syndrome, anencephaly. So in these cases, so our goal is to provide comfort care from the birth. Then the second category, when the baby is having some life-threatening conditions and intensive treatment is very likely to fail. For example, extreme prematurity less than 23 weeks, but this gestational age may be extended in our setup, maybe 24-25 weeks, or it can be based on the statistics of your NICU, and severe CDH. So here the goal is parallel planning. So try for the best, hope for the best, but be prepared for the worst at the same time. Then the third category, here the severe, if the baby is having a severe morbidity and the disease is such that the quality of life is going to be limited severely. So here the survival is slight, but the chances of having a profound disability is quite significant. For example, if the baby is having grade 4 IVH, severe HI, progressive metabolic diseases. So in these cases, our goal is to discuss with the parents and what makes the life worth living. So there are certain barriers to implement the neonatal palliative care in our low and middle income countries. So basically that can be divided into two factors. So first is the factor which is related to providers, and second is related to systems. So provider, because most of the time the clinicians think that, so we are doing because we can do it. We have a ventilator, we have lines, we have inotropes, so we will try it. And there is some fear of legal repercussions, legal issues, and most of the time the clinicians they view death as a medical failure. And the second barrier, which is again very common in our low and middle income country, is that lack of private space. There is some issues related to the administration and restrictive visiting policy. So not too much of parents are allowed to visit the baby while the baby is in NICU. Then there are certain cultural and religious consideration as well. So many times the parents, even the clinicians, they think that suffering is redemptive and it is determined by the God. And decision makers, mostly in some cases they are parents, and sometimes the extended family and the elders also, they take part in the decision making of the baby. So our strategy should be ask how does the family and faith view the serious illness in that particular context. So for palliative care, again, you need an interdisciplinary team. So multiple persons has to be involved. So as usual, the physician, nurses has to be involved. Chaplains, if available, again, limited in our countries and other LMICs. Social works, logistic, finances, and bereavement resources. And child life, mostly it is applicable in pediatric patients, but to some extent it can be applied to the neonates as well. Then it is very important to communicate with the parents. So art of communication is very important. So the basic principle of communication here is that you need to listen more than you talk. Then silence is also a tool, and you should allow the parents some time to process the facts. Then you need to you need to understand the ask, tell and ask loop. So you need to ask what the parents actually know, tell the parents the medical facts and updates, and ask what they have understood. So these things have to be done for a effective communication. And this is very important. We need to follow a protocol while we are breaking a bad news. So you use this protocol. Spikes protocol is being used. So S stands for the setting. So allow some privacy, allow the parents to sit, relax. Then perception, try to understand what is their perception, what do they know, and invite how much they want to know. And knowledge, try to explain the medical facts, updates of the baby, and respect the emotion of the parents, need to validate the feeling, and summary means what you are going to do in the next step. So this protocol again you have to follow while breaking a bad news in NICU. Then setting the goals. So there are two goals. So we need to shift from the technical goals to a goal which is respecting the family values. For example, technical means we can ask what do you want us to do. But values, if you respect the values, so you can ask the parents what are your hopes on the baby. So what are your hopes? The common hopes of the parents are to be pain free, to be held, and to go home. So handling, I want everything done. So some of the parents will tell, I want everything done. So why it happens? Most of the time it happens because of guilt or lack of understanding of the underlying conditions. So what we need to do as a clinician, so try to do everything that helps the baby. That means focus on the aggressive comfort of the baby. Pain relief, symptomatic management, those things are very important here. And try to avoid things that only hurt the baby without giving any check. For example, prolonging the ventilation, giving some inotropes for a prolonged period, inserting a lines. So all these are painful procedures. So a shared decision making is very important. We need to balance the medical facts with the family values. So a optimal collaboration has to be established to means balance these two facts, that medical facts and family values. So the medical facts basically it provides the prognosis, treatment options, and the realistic outcome which is based on the statistics. And family values actually they contribute their goals, cultural belief, hope, and fear for their child. So a optimal collaboration or shared decision making would be the best option for the baby in this situation. And the sibling support, again, it is very important for pediatric patients populations, but in neonates also it can be extended to a certain extent. So the siblings again has to be prepared, describe what they will see, like multiple tubes, wires, syringes, alarms, like that. And they may be involved, and choose a book to read or drawing to live. So child life specialist essential for translating complex medical situations into child friendly concepts, maybe various diagrams, cartoons, like that. So so in this situation we are likely to face many conflicts. So how to go for this conflict resolutions? So many times the parents will disagree with each other, and the second is the team disagrees with the parents. So we have two options here. We need to consult the ethical team, ethics consult, and in some cases we can try a time limited trial of therapy. For example, let's try these treatment options for another 48 hours or 72 hours and see what is the response of the baby. So that is time limited therapy of trial, and based on that different care planning can be planned. For example, DNR, A&D, allow natural death, post, like that. So what are the principles of symptomatic management? This is very important in palliative care, very important pillar of palliative care, you can say. So you need to anticipate and assess, treat with pharmacologic and non-pharmacologic options, and reassess whether the treatment actually worked or not. So these are the three important pillars. So one is symptomatic management, already I have discussed, family support, and third one is ethical integrity. So multimodal comfort strategies means we have to take care of the environment and non-pharmacological treatment, pharmacological options, and carefully you have to manage the activities like breathing, taking care of the secretions, convulsions, all these things. So pain assessment and managing pain is very important. You need various, we have various tools you can use, NPAS, CRIS or PIPP, which are commonly used in neonate, in NICU. And also you can rely on facial expression, physiology and behavior of the baby. So pain assessment is very important, and always assume that if a procedure is painful for the adult, it is definitely painful for the baby. So these are the various non-pharmacological comfort measures you can practice. So containment, you can use swaddling, 24% sucrose. Environment, you have to dim the light, minimize the noise, and touch. Allow skin to skin contact. So you can see there is minimizing the light and noise level, swaddling and skin to skin contact if a baby who is on respiratory support. Then various pharmacological options we have. So for pain management, aggressive pain management has to be, it has to be a cornerstone of management of palliative care. So opioids, we have morphine or fentanyl. So you can choose either based on the dose, and adverse effects like morphine can cause hypotension and fentanyl can cause chest wall rigidity. You have to take care of all those things. Then sedatives like midazolam, lorazepam, basically used to relieve agitations. Anticonvulsants. So here, when you are using anticonvulsant, our goal is for clinical suppression, not electrographic suppression. And secretion management. So you can use glycopyrrolate or other anticholinergic drugs. So managing the basic needs like respiratory support. So here our goal actually shifts from correction of blood gases to symptomatic relief. So allow permissive hypercapnia if the baby is comfortable. Reduce invasive suctioning. Use low flow oxygen for air hunger rather than targeting the saturations. And opioids. Using opioids is very important here. It will relax the pulmonary vasculature and respiratory drive. And you can use anticholinergics for secretions. Nutrition and hydration, again there are two school of thoughts. So you can continue breast milk or formula for comfort. So here here our goal is not to look for the calories, only for comfort. And there is another school of thought is that if the gut fails, there is withholding the artificial nutrition, it will prevent your edema formation. So edema is again very something which is the parents do not want to see. And dehydration, sometimes it releases the natural endorphins which have anesthetic effect. So you can decide accordingly. And managing the basic needs like gastrointestinal issue, opioid induced constipation which has to be treated, vomiting, comfort measures has to be taken, skin care optimized, then withdrawal of life supporting treatment. So you have to plan, and who means you need to discuss with the parents and the key family members, primary nurses and the physicians, and where it has to be done. So there should be some privacy. Okay, privacy, private room, garden, like that. So these are the sequence of withdrawal. First, you have to discontinue the monitors. Second, the anticipatory drugs you have to give like opioids and benzodiazepines. Remove pressure and IV fluids. At the last state, you can go for extubation. So again a concept of compassionate extubation. So environment has to be optimized as I have discussed before. And before the procedure, some pre-medications like opioids and benzodiazepines can be given. And gently you have to remove the tape and place, if possible, if facilities are there, you can place the baby in parent's arm before extubation and remove the tube gently. And at the same time, you need to counsel the parents what to expect. Like there is some alteration in breathing, baby will have some agonal gasps, like that. So all these things have to be discussed. Some skin changes will be there, and some changes in the consciousness will be anticipated. Some memories again have to be created, like some photographies, footprints, a chunk of hair, or some memory box type of things. So this again can be given to the parents. Again, you have to discuss with the cultural and spiritual humility, like various rituals which are which the parents actually follow, that can be done. Decision maker have to be involved, the other family members, elders, and the primary decision makers. And the grief expression, again, it varies from different communities. So again, you have to respect that. Ethical framework I am not discussing because time is short. So I'll just skipping the ethical aspects. So how to define futility of medical treatment, physiologic, qualitative and quantitative futility. Legal consideration again very important here. We need to document. It is very important to document the change in plan from curative to palliative. That has to be documented. And one another aspect is moral distress. So moral distress, it is also called as compassion fatigue. So the physical and emotional exhaustion from the caring of a dying patients. So the physicians actually they suffer from this moral distress and compassion fatigue. So how to differentiate? The common signs are emotional exhaustion, intrusive thoughts, and avoiding patient room. And we need to do some supporting strategies to the staff to prevent this compassion fatigue. So the key message is that palliative care integrates with the curative care. Symptomatic management is very important and is an ethical duty. Family support is a standard of care, and we need to acknowledge the moral distress and need to support the team which is doing the palliative care. Thank you so much.
Thank you, sir. Very difficult topic to present, I know, but very well presented. And I think we all got the key points that we need to continue the care with the same intensity, even though we know the outcome, but we should not concentrate on the outcome and we should continue the same level of care. Thank you, sir. Thank you.
Thank you, sir. I request Dr. Lakshman sir to present a moment to sir. Now I request Dr. Usha Devi Rajendran ma'am to start the next session regarding screen to strategy, making the most of your NICU monitor. Dr. Lakshman sir will be chairing this session.
Good afternoon. Good afternoon, ma'am. I'd like to take the opportunity to introduce Dr. Usha Devi ma'am, who is an assistant professor in Department of Neonatology at JIPMER, Pondicherry. Her achievements goes to a gold medal in neonatology at NB, and gold medal for award paper presentation at Neocon, and research awards, and around 80 articles, and contribute to major books, and a trainer for an NRP and BNCRP, quality improvement coach, and pregnantology module, and sonography and NSU. Now I give the
Thanks for the introduction, sir. I would like to thank the organizers for the opportunity. So moving on to the topic, from screen to strategy, making the most of your NICU monitor. So we'll be seeing about why this matters at all. That is moving from the screen values to clinical strategy, and what are the cautions we have to take before interpreting the values in the monitor. And mostly we'll be concentrating on tools which would be dealing with this big force. Big force means heart rate, respiratory rate, oxygenation, parameters related to oxygenation, ventilation, and parameters related to perfusion. These values are shown in the monitor. On how do we interpret and what do we do seeing those values, and few take home messages. So why this matters at all? There are a lot of monitors in NICU which generate lot of numbers, numerical data. So we should not take it just as a numbers. These are actually physiological data which should be used for clinical management of the baby. And these numbers may be an early warning so that we can go for early intervention and prevent the clinical deterioration in the baby. And also it is high time that we move on from just seeing these numbers, passive monitoring, and go to an active clinical strategy. And many a times we need to find strategies which would reduce the alarm fatigue. Alarm fatigue means there would be lot of alarms, too much of noises in the NICU. Then what will happen is healthcare workers would become non-responders. They would not respond to the alarm at all if there are too much of false alarms. So we need to find the strategies. We need to keep a proper alarm limit, and we need to find strategies to reduce the artifact and how to identify artifact rather than a true value. So all these things need to be standardized. So we need to move from passive monitoring to intentional monitoring to pick up anything abnormal and to treat the child based on the values. So what are the essential cautions if you see? So there might be some 50 monitors around the baby. The most important thing is who is watching the patient. So the clinical monitoring or clinical assessment is the most important thing. It is a foremost thing. Then only comes the values in the monitor and interpretation based on the values. So the clinical assessment still is the gold standard, and all these are supportive decision tools. So, and just buying the monitors and attaching the baby to monitor is not enough. Someone has to monitor the monitors also. So, we need to see the values and we need to interpret. So, we'll be in this 15 minutes, we'll be seeing about tools which will give parameters regarding oxygenation like pulse oximetry, CO2 monitoring, tissue oxygen saturation, ventilator screen, ventilator monitor which will be giving certain parameters, and ventilator monitor which will be giving graphics, and tools which would tell about heart rate, perfusion and hemodynamics. So in the multipara monitor, the primary things which we are interested in are heart rate. So setting alarm limit is also very important. Usually we set a lower alarm limit of 110 and upper alarm limit for heart rate as 160. And for saturations, similarly 91 to 95 is our target. So we set a lower limit of 90 and upper limit of 96. And for BP, we have many charts for systolic BP, 5th centile, 50th centile, 95th centile. So like Zubro's chart. And normally what do we teach for a beginner is the mean BP should be almost same as a gestation age. If it is a 38 weeker, mean BP should be around 38. Before seeing any chart, at least that much we can interpret. And temperature. Usually temperature is shown by the probe, warmer probe. So it will be displaying the baby's temperature. In some cases like therapeutic hypothermia, where we have to maintain 33.5 degrees Celsius core temperature, we will be putting a rectal thermometer. The probe will be attached and rectal temperature probe will be attached to the multipara, which will display the temperature. And we will be setting a lower and upper limit for that also. So, starting with the pulse oximeter, which is a basic monitoring device which we use most commonly in NICU. We all know that it shows the percentage of hemoglobin which is attached with the oxygen. And so what are the clinical applications? It uses Beer-Lambert law. So I'm not going into this theory. So clinical application is normally we attach it for a growing preterm or a baby who has got admitted with some clinical indication inside NICU, for seeing the saturation, for seeing the heart rate. And also we will be using it for every baby, because before discharge they have to undergo critical congenital heart disease screening, pulse oximeter screening according to the AAP protocol. So we wanted a right upper limb and lower limb saturation more than or equal to 95%, and the difference between preductal and postductal less than or equal to 3%. And also we use it during resuscitation, during transport of the baby. We use a pulse oximeter for monitoring. So most of us prefer some technology called as Mesimo technology, which uses this set, that is signal extraction technology. Without the technology, what will happen is whenever baby moves, there will be falsely low saturation, or there might be bradycardia, which most of the times we everything will be varying during inspiration and expiration. So this respiratory variation of the perfusion is taken as plethora variability index. And so this respiratory variation will be more when the baby is hypovolemic. When the volume is less, when the baby is in shock, this PVI will be more. So normally, the perfusion index normal cutoffs are 0.4 to 1.5 percentage in a preterm baby. In the initial 2-3 days, it might be on lower side, 0.4, 0.5. But in a term baby, it is usually more than 0.7 percentage. It can extend somewhere till 3 percentage. So whenever the peripheral perfusion is affected, baby is in shock, you get a low PI. So that is also one of the indicator that baby is having poor outflow, cardiac output. So again, we need to remember that if the baby is hypothermic, this PI might be falsely low. If the baby is on vasoconstrictor, this PI might be falsely low. Next is pleth variability index, which we saw whenever pleth variability index variability is more during respiration, it means that baby is hypovolemic. So normal cutoff is 5 to 15 percentage. What book says whenever it is more than 18 percentage and the baby is having clinical features of shock, we need to consider hypovolemia, taking other parameters like pulse pressure, all those things, and we need to try a bolus and see whether perfusion of the baby clinically improves and whether PVA improves. So there is another machine called as pulse co-oximeter, which also gives methemoglobin and carboxyhemoglobin level. This might be relevant when the baby is on nitric oxide, when methemoglobin is getting generated. So this might be relevant for monitoring a baby who is on nitric oxide. Coming to heart rate monitoring, usually a pulse oximeter only gives a heart rate. No, it is based on the pleth signal, which is detected by the pulse oximeter probe. Again, this can be affected by the motion and all. But in a sick baby, very preterm baby, we usually in level 3 NICU, we usually attach ECG electrodes also. So this ECG based heart rate will not be affected by the motion artifact much, and it will be useful to detect any arrhythmia as well. Only disadvantage is electrodes. Yes, you have to attach ECG electrodes. You need to attach. Skin might be fragile, so you should be taking care such that you are not creating any skin injury. So ECG derived heart rate is less prone to artifact. Whenever you attach a ECG, your heart rate alarm limits automatically gets linked to the ECG based heart rate, so that you don't get false alarms because of the motion artifact. So another thing, heart rate variability monitoring. If you see, it is a variability in the time interval between the two beats. Okay, so this is one of the parameters which was much talked a few years before. They told ERO monitor, heart rate variability, which is the earliest marker that the baby is going to sepsis and septic shock. So there was a ERO monitor which predicted HRV and which told that this baby has high chance of going to sepsis and septic shock. So this is the role of this heart rate variability. Usually increases when the baby matures and when the baby is having autonomic stability. When the baby is very preterm, autonomic nervous system is not stable enough, what will happen is it will be very low. We will use different numerics which will be less than 30 millisecond when the baby is having some instability. So that is another marker that this baby is going to become sick. And coming to the blood pressure, most commonly we use non-invasive BP, but invasive blood pressure we will use when the baby is critically ill, when the baby is in hypotension, when the baby is on multiple inotropes, when the baby is on ECMO. So during that time we go for invasive blood pressure monitoring. NIBP routinely we see for babies who are in level 2, level 3 NICU. This NIBP, when we are checking, we should be which we should be very much particular is we must be particular that cuff size is in accordance with the arm circumference of that baby. So we need to select appropriate 1 size, 2 size, whichever cuff size we are selecting. So the width should be, as we all know, should be covering 50% of the circumference, and the bladder length should be more than 75, more than 2/3 of the circumference. So the cuff selection is very important when we go for NIBP. When the baby is sick, when you have an arterial line in place, we will be going for IBP. In IBP, what we should be careful is we need to level. So the transducer should be at the level of heart. So that leveling we need to see. Whenever there is a clot or some obstruction, there will be dampening effect and the waveform will not be correct. So we need to see that also, and we need to do proper calibration and zeroing when the baby is on invasive BP monitoring. So respiratory rate and effort, this is also from the pulse oximeter probe. It gives a respiratory rate also, no? So this is also based on pleth wave, based on the arterial signal. So it gives some respiratory rate. However, it will not, it will just show whether the respiratory rate is below the cutoff or above the upper limit. Whether tachypnea or bradypnea is there according to your limits, the alarm will be activated. But it accurately doesn't pick up apnea. There is something called as apnea monitor, which takes both heart rate and saturation into account and will pick up whenever baby is not breathing for more than 20 seconds. So another thing is endotracheal CO2. Some units have transcutaneous CO2 also. Endotracheal CO2, how it is helpful means, so it will be just lesser than that of the arterial CO2. We cannot be taking arterial CO2 frequently when the baby is on ventilator or high frequency ventilation. So in that case, the EtCO2 will give a trend of CO2 values. You will know if CO2 is getting washed out, what will happen. Cerebral vasoconstriction, baby will go for infarction and periventricular leukomalacia. So CO2 you have to maintain in a desirable range. Usually we maintain around 45. 40 to 45. If it drops till 35 itself, we need to panic because this will cause infarction in the brain. So this for continuous CO2 monitoring and titration of settings in a sick baby, a EtCO2 will be helpful. Another uses, as we all know, to check the position of ET tube, capnography, EtCO2, all these things can be used. And many units have transcutaneous CO2, same thing. Instead of attaching to the endotracheal tube, which will add to the dead space, we are attaching to the skin electrodes we are attaching, and it will show the CO2 level. This might take some time for calibration, everything when compared to EtCO2. So even in a non-ventilated baby, we can go for this transcutaneous CO2. However, only in ventilated baby, we will be going for EtCO2. So again, ventilator screen will be showing set parameters, delivered parameters. So if the tidal volume delivery is more, you know that you will see the chest raise. Chest raise is also more. You know that you need to come down on the settings or you will be damaging the lung and creating CO2 washout. There are some ventilators like SLE 6000 which has a automated FiO2 control. So there will be a saturation module in that only. You will attach that probe like a pulse oximeter probe. Whenever baby saturation comes down below 91, it will automatically increase the FiO2. And so graphics. So this is a flow time graphic which is showing air trapping. And this is a volume pressure compliance loop which shows that the loop is almost sleeping on the x-axis. The compliance is very poor. It is a severe RDS lungs. And after giving surfactant, this loop is just becoming straight. So here we can see there is lot of air leak. Either it might be around the ET tube or it might be due to some disconnections in the circuit. And another thing is NIRS. In pulse oximeter, we are just seeing the arterial oxygen saturation. In NIRS, we will be seeing what is the oxygen saturation at the tissue level. So this monitor will be showing what is the oxygen saturation in the brain, in the mesentery, in the gut, in the kidney. So it will be showing how much oxygen the organs are actually getting or using. So this also uses some modified Beer-Lambert law, and so there all we will see the regional oxygen saturation, cerebral, splanchnic, and renal. So we will be seeing in the brain cerebral regional saturation, splanchnic regional oxygen saturation, and renal oxygen saturation. So the terminology which we will be using is directly the monitor will be displaying the tissue oxygen saturation, which is present at the level of tissue. And another thing is fractional tissue oxygen extraction. Okay, so this will be using a formula where we will be seeing the saturation from the pulse oximeter. We will be seeing the regional saturation from the NIRS. Both we will be subtracting and dividing by the saturation. This much oxygen the tissue is consuming from whatever is available there. Okay, so we are more interested about fractional tissue, how much is present and how much the tissue is extracting. So normally cerebral saturation will be, tissue saturation will be around 60 to 80. Mesenteric saturation should be slightly higher than the cerebral saturation, and renal saturation should be higher than the cerebral saturation. If the regional saturation is, I think I have 3 more minutes, 17 minutes only. So regional saturation, if it is less than 55%, it is abnormal. If it is more than 90%, 90 percentage means what? So the tissue is having so much oxygen. It is more than 90 percentage. Nothing is extracted by the tissue. So that is also abnormal. So anywhere between till 50 to 70 is okay. Less than that, more than that is not okay. And when baseline you started with a good regional saturation around 60, suddenly it is becoming 30, then also something is abnormal. So you need to see why the oxygen is coming down. Whether hemoglobin is low, you need to transfuse to improve the oxygenation. Whether you need to improve the shock to improve the oxygenation. Whether you need to improve the ventilation to improve the oxygenation. So another thing is we do echo to see cardiac output, contractility, IVC collapsibility, all these things. Without doing a echo, without having that expertise, can I connect a monitor which will non-invasively give all these values? It is called as TEBT, icon monitor. Many of the centers in south side of India also use this icon monitor. In western setup, it is too common to use a icon monitor. This is like a pulse oximeter, but there will be 4 skin electrodes which has to be connected. This will be showing all these parameters. We will see an example. So this is icon monitor which is kept in a stand and which is connected to the baby. So this is showing all these components: stroke volume, cardiac output, systemic vascular resistance. We cannot measure systemic vascular resistance or afterload using a echo, but this will be showing all these parameters. Index of contractility, that is icon. Total fluid content. So in this baby, if you see, those are the ranges. Left side it is showing the ranges. Icon, that is contractility, is in the normal range. Stroke volume and cardiac output is low. So I will not concentrate on inotrope, I will concentrate on giving fluid. Afterload is very much high. So I might be giving extra noradrenaline, so I need to come down on my vasoconstrictor. Total fluid content is more, but stroke volume is less. It means that it is not inside the vascular compartment. It is in the tissue, capillary leak. It is in the tissue compartment. So anyways, I need to go upon fluids to maintain the normal fluid volume. Another neurocritical monitoring parameter is EEG. We use for babies with encephalopathy, with seizures, who are undergoing therapeutic hypothermia. A continuous video EEG is not possible in our NICU, so we go for amplitude integrated EEG. So we see whether it is normal, moderately abnormal, or severely abnormal, and all these things: burst suppression, flat waves, longer time to recovery, sleep-wake cycle if it is absent. All these are poor prognostic factors. So this help in monitoring as well as prognostication also. So future of monitoring, I haven't seen all these tools. Future of monitoring will be using all this monitor. There will be some analytics, and AI itself will give what is the decision to be taken, what is a clinical condition, what would be the clinical condition based on those parameters. And we need to go for skin friendly sensors. Since many of them have sensors and probes, more skin friendly sensors should start coming, and all these parameters should get integrated by itself to give a final conclusion. So this will be the future. So take home messages are: monitors are decision support tools, not just numbers. We should take that numbers, physiological data to support our decision. And we need to remember that they are just support tools. They are not replacement for a clinical assessment. And more than the snapshot or a single value, trends matter. Trends of the value matters. We need to transform this numerical value into insight, and insight we need to use it as clinical strategy. Thank you.
Thank you, Usha ma'am, for a elaborate and good presentation. I think with increasing AI in medical field, I think this presentation will be more dynamically changing year by year.
Yes, sir. Thank you, sir.
Thank you, ma'am. Now I request Dr. Lakshman sir to present the moment
Yes, sir.
to Rajendran ma'am.
AC and DC.
AC and DC in perfusion index.
Yeah.
So
that is calculated value. We are not going to calculate AC and DC. Normally, the pulse oximeter will pick up signals from the pulsatile component of the blood vessel. So that is what arterial. Pulsatile arterial component. There will be a non-pulsatile portion also, which is DC. Non-pulsatile means those that are coming from the venous side. They will not be pulsatile. Even part of the arterial side, during some time, they will not be pulsatile. So that is DC. So pulsatile component divided by non-pulsatile component. We need not calculate. It will give by itself, sir.
Thank you. Thank you.
I request Dr. Usha ma'am to present a memento to Lakshman sir. Dr. Usha ma'am, please introduce Dr. Grace, chairperson of next session. No, ma'am. She will introduce you, ma'am. Just your introduction. They'll display and madam will introduce. Chairperson. Okay.
Which one, sir?
She is a chairperson. Just
For
introduce
next
her,
session,
madam.
sir?
For next session, prevention of drug abuse.
It's my pleasure to introduce Dr. Grace Lalana Christopher, who is a consultant pediatrician and founder CEO of NewGen Parenting. And ma'am has many publications, index publications to her credit. And she's affiliated to Grace Specialist Clinic as well. It's a pleasure to have you, ma'am. So, ma'am will be chairperson for the session on prevention of drug errors in NICU practical aspects.
And nursing representative for Delhi branch, affiliated to government and scientific NNF. So has major achievements in various chapters of NeoClips, facilitated in research project, and is a soft skill trainer at AIMS and a NeoQuip trainer, and won awards, gold medalist. So we welcome you for the session. Please present.
Thank you so much, ma'am, for the beautiful introduction. A warm good afternoon to one and all present over here. First of all, I would take this opportunity to give heartfelt thanks to the NNF office bearers and all the chairpersons and the organizing committee to give me this opportunity to speak upon this topic. So I'll be dealing with prevention of drug errors in NICU, its practical aspects. So these will be my contents. So before beginning, let's see why it is important to reduce the drug errors in NICU. Is it important? Yes, it is. So why? Neonatal survival rates can be increased by 55% if appropriate IPC measures are carried out, that is infection prevention control measures. Then, as per the recent NFHS study and SRS data, we have seen that NMR, that is the neonatal mortality rate, accounts for more than 42% out of all the deaths in under 5 mortality rates. So, NFHS 5 2021 states that NMR is 25 per 1,000 live births. And why we are speaking about this NMR is that in order to achieve the SDG and MDG goals set by the international committees, so we have to achieve the SDG third goal, which is good health and well-being, and MDG fourth goal, that is reducing the child mortality. So a recent study was done in German level 3 NICU in 2021, where safety incidents were checked. So in that study, we could see that medication errors contributed to higher incidence rates in causing the safety incidents, which was 44%. Rest had lower leverage like equipment failures and or problems which contributed to 27%, communication errors being 6%, and documentation errors being 5%. So we need to understand that any avoidable harms that is occurring in NICU should be avoided. And this year we commemorated the Patient Safety Day on 17th September that we foresee and we look upon every year. And the theme for the same was safe care for every newborn and every child. So we need to understand that every newborn is at a higher risk for developing any harm in the NICU course. So why they are at higher risk is that because of their rapid development, because of their evolving health patterns and very differential diagnosis patterns. So moving ahead, so what is a safety incident? That I like to mention that safety incident is any unplanned event that occurs to a patient, causes patient harm, causes any untoward event to the hospital supply, or causes prolongation of hospital stay in the hospital course of a patient. That is known as a safety incident. Moving ahead. So this is the WHO definition of medication error. What is a medication error? Any preventable error that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient or consumer is known as a medication error. So we need to understand that reducing medication error is a linked interventional change that enhances the neonatal outcomes. So what are the types of medication errors? So as per the weightage of different errors, I'll be enhancing upon it. Types. First one is during the administration phase, it accounts to 54.4% of drug errors. Second is ordering and prescription errors. It accounts to 21.3%. Third one is the transcribing errors. That is 1.4%. During dispensing, it accounts to 15.9%. During monitoring phase, it accounts to 7%. And at last, documentation error is there, and there was no data for the percentage. So we need to understand the reasons for increases in the incidence of medication errors. Why medication errors occur in NICU or any hospital stay? It is due to the weak medication systems that is in the place. Human factors need to be taken into consideration, such as fatigue, poor working conditions where staffs are heavily burdened. So we have seen that various studies which were conducted, they showed that more than 20% of medication errors are being just happening due to the heavily burdened staff and staff shortages, inadequate training and skill enhancement scenarios, poor supervision and poor communication, local working culture, inadequate medicine supply, memory lapses due to inadequate exposure to in-service educations, knowledge and rule-based mistakes, action slips. And we have seen that a recent study was done in which it stated that 74% of errors and 79% of potential ADE, that is adverse drug events, occurred in the ordering phase itself. So 29%, this is the quantification of the patients who have undergone unintended medication and discrepancies and medication errors at the time of admission or discharge from any given hospital. So we need to understand, since drug calculation is very minute calculation, so there is a difference between adolescent and neonatal drug calculations. So what is the difference? That is potentially 100-fold difference from both the populations. So we need to understand, since drug calculation is different and causing 100% fold difference from the neonatal to the adolescent, though the chances of increasing the medication error is also potentially 100-fold times. So we have seen that more than 1 in 10 nurses have undergone traumatic events or mentally due to mental or psychosocial events which have been evolved in their life during the COVID pandemic, and they have contributed to severe adverse events. So they are usually referred to as second victims when involved in such events, and they may suffer from further serious emotional harms as a result. So care should be taken and relax. So more than 90% of such patient incidents can be reduced and are considered as preventable. So how? Proper team briefing and role allocation should be given, whether it be doctors or nurses. Effective communication should be in place between different working personals. Storage checks should be done. Prompt reporting of errors and documentation should be taken into consideration. So moving ahead, how to reduce the drug errors. First one is the standardizing and incorporating the medication administration rights. So there are 10 rights of medication administration. That is the right patient, identifying the right patient by the hospital denominators. Second one is right medication. Before giving any medication, we have to check whether we are administering the right medication which is ordered. So goes with the right dose, right route, and right frequency and time. This has to be cross-checked with the doctor's prescribed orders. Next comes the right documentation. Whatever medication has been administered should be written along with its specific name, the time, date, dosage, and along with the initials. This has to be documented, and if any untoward event has occurred due to the drug administration, the same needs to be charted as well. Seventh one is right to refuse. So in this case, neonates cannot speak. So parents are the surrogate caretakers, and they are the decision makers for the neonates. So parents should be given the full entitlement to right to refute or right to carry on forward with the medication which the doctors feel that the patient should undergo, and they should clearly mention that to the parents. Right response is that whatever medication we are giving to the patient, is it reaching the desired effect? Right education means whatever medication we are giving, we should encourage the parents and tell them like what all medications we are giving, what is undergo such medication administration to the patient. And right reason, last is the right reason amongst the medication rights. So right reason is that clinical judgment is very crucial for both the doctors and the nurses. Like whatever medicine we need to administer, before administering, we need to judge within our minds, like, is it necessary that this drug should be given or not? Because I'll just give you an example. An example would be like a prompt cessation of empirical antibiotic therapy in the NICU. If there is no need, if the cultures have if the cultures have come sterile for any given baby on the third day after the reporting, we can empirically stop. We can ask as nurses, we can ask the doctor, is it necessary to continue with the antibiotic therapy, which will in further decrease the antimicrobial resistance. So medication safety, how to check for the medication safety? There are triple checks. First check is conducted when the medication is taken out of the storage and the label is being read. Second check is conducted when the medication is being prepared and the label is being read. Third check is conducted when the medication is being administered and the label is being read near the bedside. So this administers medication safely to the patient. So next we'll talk about what is the NICU practicality. Among the nurses, care should be taken while transcribing drugs into the drug administration chart or the drug chart, correlate each and every day, specifically the night shift staffs, to check the admission face sheet for UHID of the patient with prompt name, not to copy the entered drug details from the previously filled chart, triple check the drug order in each shift, that is the morning shift, evening shift, and the night shift, prompting enhanced accuracy. Not to overwrite on the mistaken part, always single strike by putting initials. Initialize the name for newly added order or any change in order or updation. Not to take verbal orders under any circumstances except critically emergent situations. Such order always needs to be followed with readback order policy. Telephonic order strictly needs to be intercepted. New nurse role with designation in NICU can be incorporated. Nurse whose sole responsibility will be to look and advise for all the drug errors, preparation and its storage, frequent upgradation with the recent norms to be made for the NICU drug nurse, use of barcode point of care as per hospital norms. So further responsibility of nurses in eliminating the drug errors would be that the look-alike and sound-alike drugs to be kept separately and labeled with different color coding. Look-alike means, I'll give you an example of injection adrenal atropine, they look alike. Sound-alike would be potassium chloride, oral Potchlor and oral pedicloryl. So these drugs should always be labeled separately and kept separately so that mistakes should not occur in the administration phase. And we need to watch the units. Both the doctor and the nurses should always watch the unit. Whatever it is prescribed, is the same is being administered as well. Examples would be mg per kg per minute versus mg per hour versus micrograms per kg per hour, mg versus micrograms, milliequivalent versus microgram versus grams. Care should be taken not to overlook in unit conversions. Always seek help or ask help. When in doubt, always ask the seniors. Misplaced decimals causes compounded errors, like tenfold times it causes the errors. When in doubt, incorporate the subservience. Never to feel intimidated by asking the seniors. Optimizing nursing flow to minimize interruptions. So a chart I have attached with this. This is the nursing chart where we have entered the drug prescribed to a patient. So we can see that it is clearly written, capitalized, clearly and legibly we can read that. And also if there was any error, a single strike was done and it was initialized as well. So the same should be incorporated in all the units. So next comes, what are the doctor's responsibility? Prescriptions to be duly notified with clear, precise capital words. Any change or upgradation to be written again and duly notified to the assigned nurse. Frequent usage of computerized prescriber order entry, that is CPOA, should be done wherever it is possible. To emphasize entry of emergency drugs within the 30 minutes of administration, not to go beyond that. Clearly mention all the standard and international units of drug. Not to prescribe the trading name of the drug, but rather stick to the chemical name of the drug. Discourage the use of abbreviation except the standard ones. This we need to ensure that if doctors are not following, we are authorized enough to speak politely to the doctors and let them remind that we need not use any abbreviations. We have to use a chemical name for the drug, not to prescribe the trading name, because trading name can be different, and due to the prescription of the trading name, drug errors, chances of occurring drug errors are more. Next, I'll give you just example. This is the one on towards my left hand side is the computerized form of drug entry, and towards the right hand side is the written aspect of the drug entry. We can see that both of them are clearly legibly mentioned. If there is any error, it is being initialized. If there is any addition of new drug, the same has been initialized with date. Same should be followed. So next comes the care of high alert medications. High alert medications should be used under auxiliary labels. They should be separately labeled, separately stored. And secondly, automated alert systems within the electronic health records should be used for its ease of access. Independent double checks and documentation of both care providers' name on the drug chart should be mentioned. The person who is administering the drug and the person who has cross-checked, both of their names should be initialized while the same high alert medications are given. Next comes the narcotic policy. First one is the procurement and storage of the narcotic policy. So the narcotics should be sourced from licensed supplier, and separate double locking systems should be maintained for all the narcotics in any given unit. Second is the documentation and inventory management for the narcotics. Narcotics stock book can be maintained, and if it is not there, we can advise and ask, and like new policy can be incorporated where stock books are kept. Inventory allocation to the nurses should be given at each shifts to count the narcotics. Third is the prescription and dispensing of the narcotics. Prescriptions written in clear, legible words, capitalized, dated, and signed. And discourage verbal orders as mentioned previously. Personal training and disposal. Only authorized trained personnel should be handling the narcotics. Strict controls on drug diversion should be maintained. And also if during disposal, if there is an incidence of ampule breakage, so a prompt measure of incident reporting should be taken in place and put into consideration without blaming the person, because it can happen accidentally. This is the narcotic register that we maintain in our unit. So I have just put one picture. And in it, we also mention what we are doing if the balance is kept. Are we discarding or are we keeping it back? So this is the fentanyl. I have just mentioned one. We are keeping for all the narcotics fentanyl register, and we once we are replacing it from store, we are also mentioning the same. Next comes the standardization of the drugs. So what do you mean by standardization? So standardization should be universally followed, and it uses concentrations and volumes which are standardized. If possible, use commercially available premix solutions, and dose error reduction software using syringe pumps and infusion pumps should be utilized. So the standardization done in a unit. This is the standardization for the IV fluid preparation and also the guidelines for the antibiotic administration in NICU. So both of the charts I have kept. So we follow this once doctor's orders are written, we follow this chart and prepare the drugs. Next comes the safe injection practices. So in safe injection practices, we during the practice phase, we need to understand that one needle, one syringe and only at a one time should be used, and asepsis to be maintained at the point of preparation till the point of delivery. Asepsis should be strictly followed, and contamination should be eliminated. Vial usage should be taken into account, that single dose vial policy to be prompted, and high cost antibiotics which can be used again to be stored for another 24 hours with proper labeling of date of opening and date of expiry. Same goes for all the continued use of oral supplements and oral drops. Multi-prick vials to be minimized to single patient alone. So now comes the medical error disclosure. So what do you mean by medical error disclosure? So whatever error has happened, it should be then and there disclosed without creating any judgmental environment. So we need to take care that creating an environment that focuses on healthcare teams' respect and compassion for patients as well. The first crucial step involves promoting the reporting of medical errors, ensuring the adverse events, drug events and close calls are routinely notified as soon as they occur. We do not have to wait. Remember that to notify is not to blame. Continuous involvement of monitoring of strategies to incorporate the mishappenings in the form of quality improvement projects on medication errors should be taken. Healthcare providers' limited understanding of what constitutes a medical error often results in underreporting. So this comes in both amongst the nurses as well as doctors. So they should be undergoing frequent training purposes and skill enhancement for the medication drug error reporting. So this is the medication error checklist that we undergo. So one of the quality improvement project we are undergoing in our unit. So this is the medication error prescription and transcription checklist. So this is the filled form that I am showing you. So initially we had more than 50% of prescription error and nearly 30% of transcription error. Now due to the implication of the reporting system and due to the implication of the quality improvement project, we have come down to 5% for both the prescription and transcription errors. So the last slide will be the open vial policy. So once we are using the vaccine vial, how to monitor it? It allows healthcare providers to use multiple dose vaccine vials beyond a single sessions, that is for a limited time of up to 28 days. Applies to multi-use vials of DPT, hepatitis B, pentavalent and IPV. It must be kept in correct cold chain storage between +2 to +8 degrees Celsius. And on my right hand side is the vaccine vial monitor, which must be in a usable state. So we can see that the inner square should always be on the lighter aspects than the outer square. If both of them are on outer circle, if both of them are having the same color, it needs to be discarded. Proper needling and septum handling should be crucial. Only manufacturer provided diluent should be used, which is pre-cooled. So what are the core insights from all this medication error aspects that we've talked about? That is, no harm means to report the medication error as soon as it is identified. Prompt encouragement and enhancement of corrective strategies to mitigate and contain the further harm should be taken. We need to understand that no single method is there to eradicate all the medication errors, and bridging the safety gap by open and direct communication should be taken into consideration. To incorporate the international patient safety goals, IPSG, if not in place in many hospitals, care should be taken to standardize the IPSG goals in their respective hospitals. Thank you.
Thank you for the.
Thank you, ma'am. Now I request Dr. Grace to hand over memento to Dr. Mrs. James. Next lecture is on care of surgical newborn in NICU, pre-op and post-op stabilization by Dr. Deepa Hariharan. Dr. Gorul Satyanarayana sir is going to chair the session. Dr. Deepa ma'am, please hand over memento to our chairperson, Dr. Grace. Ma'am, please, yes. Here, down. Cushion, sir. Cushion, sir. Introduction slide is there, sir. You can move cushion, sir. Yes, sir. Yes, sir.
Okay. Start, yeah. Good afternoon, everybody. I would like to thank the organizers for giving me this opportunity. I'm a neonatologist from Chennai, and this topic, initially I thought, okay, what can you talk about surgical care of the newborn to make it interesting? Yes, okay. And anyway, I think we'll just start. See, what I really want to convey is this, okay? A part of it will be interactive. Hopefully, the audience will take part. And the main thing is, see, if you look at the underlying illness for which you're operating, like CDH, how hypoplastic the lungs are, how preterm the baby is who's subjected to surgery, the technique of the surgeon, these are all not under our control. Okay, the pre and the post-operative care is under the control of the neonatologist, a modifiable factor which can make a huge difference to the outcome. Just only one slide on physiology, don't worry. See, if you look at, we know that there are differences between preterm and term babies and later pediatric age group. Especially preterms they have less functional residual capacity, greater risk of apnea, greater risk of airway collapse. Their cardiac output is rate dependent. Okay, they cannot increase the stroke volume. So changes in heart rate during anesthesia can really tip them off the edge. They have less ability for thermoregulation, glucose homeostasis, impaired cerebral autoregulation. But the last line is what I want to mention. Everything is immature, but their perception of pain and stress is reasonably mature. So much so that pain and stress can affect the baby both short term and long term. So that pathway is, if it was also underdeveloped, it may not affect the baby. But pain, stress, and metabolic pathways related to stress are well developed. So I'll just present a few case scenarios and let us see what the audience has to say. Okay, this baby was born at 33 weeks gestation with a birth weight of 2.1 kilo and discharged on direct breastfeeds in 2 days. So seems like a very low risk situation. At 8 weeks, The baby has an inguinal hernia and seems to have grown well, 3 kilos. So after surgical repair, because it's so low risk, the baby was shifted to the mother's side in 2 hours. But at 7 hours post-operative, the mother found the baby unresponsive in her single room. She shouts for help. Aggressively, immediately CPR is done. The baby is shifted to the NICU, and the CBG during this episode was 90. Okay, so a very low risk baby was shifted to the mother's side, suddenly found unresponsive. I'm sure all of us have gone through this sometimes. Okay, now what could have happened? Could the mother have fed the baby wrong? The milk have been aspirated? Did the baby develop surgery from the sepsis from the surgery? Some seizure from the anesthetic drug? What could have happened? Anybody wants to volunteer? Or other causes? Hypothermia. Okay, let me just add the temperature was 36.3. But that's a good thought. Yeah. Anything else? But you see such scenarios? Sometimes you see, right? Sometimes not necessarily post-op, rarely in single room babies, and sometimes post-op. Okay. Aspiration is a possibility, you feel. Okay. Now the only thing in that case, my question is, this baby did not aspirate for 8 weeks of age till the surgery was done. Was doing well, thriving well. Seizure due to what? If it's due to what? Huh? Yeah, the sugar I put 90, that's dyselectrolytemia. But how do you think a dyselectrolytemia will happen in a hernia surgery in a well baby? Okay, but do you think it's likely to happen? Quite unlikely, right? Okay. Now, this is something we all need to remember, okay? The post-operative apnea, a very important but a neglected, forgotten, underestimated entity. Post-operative apnea affects 10% of infants under 60 weeks of post-conceptional age during the first 12 to 48 hours post-op. Post-conceptional age, it's an independent risk factor. So the more premature the baby, the more likely it can happen. But it can happen up to 60 weeks post-conceptional age, means a 33-weeker at 8 weeks of age is not totally out of risk. And it happen even in minor surgeries like hernia or raphe. Because I've seen once in a hospital where I was working once, a baby who underwent just an ovarian cystectomy, a very low risk surgery in the newborn, was found dead early in the morning during rounds. So it's not really related to the degree of the surgery. And mainly this apnea post-operative is due to CNS immaturity. It may be due to all the reasons you said, hypoglycemia, hypothermia, drugs, airway injury, etc. But mostly it is due to CNS immaturity. So, and this graph is very important. There's no laser pointer, right? Okay. This graph is very important. You can see there that at 35 to 40 weeks post-conceptional age, about 8 to 10% risk of apnea post-operatively. And at 50 weeks, it is still 3 to 4%. And only at 60 weeks post-conceptional age, the risk of apnea becomes very, very low in the post-operative period. And in addition to low gestational age, if there are other factors like BPD, NEC, lot of neonatal apnea, anemia, seizures, etc., there may be a greater risk of post-operative apnea. So, what has happened? There may be a greater risk of post-operative apnea. So, nowadays, critical care guidelines are suggesting that all babies less than 60 weeks post-conceptional age who have undergone surgery, who have had anesthesia, you can see here, must be monitored post-operatively with at least a pulse oximeter, preferably also with an ECG monitor. Minimum should be for 6 hours. And if they are less than 4 to 6 weeks post-conceptional age, at least 12 hours you should monitor them before shifting them to the mother's side. Okay, so there is an entity called post-operative apnea, and a little bit, I'll just tell you in the next few slides about your other diagnosis, aspiration and other such things. But this just says that less than 60 weeks, monitor them. And if they're less than 46 weeks, monitor for 12 hours. And this monitoring should be done for at least 12 hours from the last episode of apnea. So if you see an apnea, 12 more hours of monitoring before you give. You shouldn't give them in 2 hours. The treatment is similar to what you would do otherwise, caffeine, HFNC and all that. And whenever possible, defer surgery till 47 weeks post-conceptional age because the risk of apnea is high. And monitor with a pulse oximeter, pneumocardiograph, look at the respiratory pattern, etc. And here for post-operative apnea, there's no brilliant treatment needed. Okay, treatment is simple, but the main thing is you should be aware of it, anticipate it, and monitor it. That's the most important thing. And this also applies for bronchiolitis. Though this is out of the scope of this lecture, apnea is an important presenting feature of bronchiolitis. And see, this is what I would like to say for this question. The answer is it was apnea. And even if there was aspiration, even if there was seizure, most likely it was secondary to the undetected apnea. So the basic principle is a baby who did not aspirate before surgery should not aspirate after surgery if your risk factor assessment was good. You all agree with me on that, right? Like if a baby aspirates in the hospital, we are responsible. Our risk factor assessment was not good in starting feeds, shifting to the mother side, stopping the monitoring, whatever. And apnea, when there is a near arrest situation, secondary to the hypoxia, aspiration happens, seizure happens, etc. So here the diagnosis was inadequate monitoring and likely apnea. Now the next case, a baby who was born at term was found to have malrotation. Lab's procedure was done on day 4 at 7 a.m. And at 9 p.m., which is about 14 hours post-operative, during the consultant rounds in the night, the baby is still drowsy from the anesthesia, has some minimal movements in response to pain and all that. Heart rate is 196 14 hours after surgery. CBG is 280. Blood pressure is high, 78/56. There is good urine output. And at 8 p.m., 1 dose of morphine was given. But even before that, the baby was very tachycardic with high BP. So do you think something went wrong with the surgery? The diagnosis here, you have tachycardia, hyperglycemia, hypertension, etc. Do you think something went wrong with the surgery? Do you think the baby got cardiogenic or septic shock? Or do you just think this is acceptable post-op status? At 14 hours after LAD's procedure, this is how the baby will behave or something else? Who wants to take it? Nobody wants to answer this. Do anybody? Yeah. Now we are not able to hear you. Okay. There is hyperglycemia. Yeah. The baby is under stress, you're telling. Okay. The baby is under some kind of stress. Okay. Okay. You feel so they are not accepting these vitals. That's what you're telling, right? Yeah. Basically, you're not accepting as normal adaptation after surgery. You feel it's a stress. Okay. Any other answer? Let's move. Yeah. Because I have only 20 minutes. Okay. So post-operative analgesia is again an under-recognized, underutilized entity, just like post-operative apnea. See, pain is not only emotionally harmful, it's physiologically harmful. Pain causes stress hormone response. It increases the systemic blood pressure, thoracic pressure, intracranial pressure, causes dysynchronous breathing, apnea, vagal response induced apnea, vagal response induced bradycardia, and also permanent CNS damage. And control of pain, on the other hand, prevents all these physiologic derangements. So pain is not just about emotion, it's about science and physiology. Pain harms all the systems in the body. And when you're dealing with post-operative analgesia, I read this in one chapter, which I think is very excellent. Please remember just 2 principles. Okay, one is in the PICU, adult ICU, they always use objective pain assessment tools. We don't use it in neonatology. Okay, we don't use pain assessment routinely in neonatology. But while critically ill and sedated infants may not express pain as discomfort, and we should get used to objectively assessing pain And pain will not be just all these facial changes, heart rate, saturation changes, etc. And some of these you can readily implement, like premature infant pain profile, neonatal infant pain scoring, etc. So if we use a scoring system, we'll be more aware of the pain and we'll know how to treat it. Low scores, you just do non-pharmacologic, etc. And the second point is also very important. When it comes to pain, prevention is more important for post-operative pain. Start some analgesia on entry into the NICU and titrate the dose up or down based on the pain scores. So these are two things that are not often done. We don't give an analgesic until the baby expresses pain, and we don't assess pain unless there is severe derangement in the vital signs. So, and for post-operative analgesia, what drug? This again I found extremely interesting. We always talk about high drugs, morphine, fentanyl, dexmedetomidine, etc. But if you look at a meta-analysis, the strongest evidence, the highest level of evidence is in support of paracetamol. Okay, multiple analysis, and the strength of the evidence is very high for paracetamol, but you should start it soon after surgery, before the baby expresses the pain, has the pain every 6 hours. That alone will not suffice, but it will substantially reduce the need for opioids. The dose of opioids you need, like morphine, fentanyl. And the discussion about these two will be beyond the scope of my talk, but morphine, very effective, but long half-life. Fentanyl, chest wall rigidity, but short half-life. I'm personally in favor of dexmedetomidine, non-opioid, but as effective as these. And don't just sedate with midazolam, give analgesia. And don't underestimate the effect of non-pharmacologic measures just because it's a post-op patient, 24 hours post-op, swaddling, KMC, sucrose gels, calming environment. These will also reduce the usage of opioids. So start routinely, start with paracetamol, use an objective assessment scale, and use the lowest dose of opioids that are needed. So in this case, as it was rightly mentioned, the baby is in lot of stress, and most likely that stress is pain, because it's difficult to call it a surgical complication. Cardiogenic shock, unlikely to happen at 14 hours. Septic shock also, it's too late for cardiogenic shock and too early for septic shock from the surgery. This kind of stress is certainly not acceptable, and we should have better dealt with the analgesia. The resident was scared to give the morphine because the baby was not yet awake and fighting. Okay, so just because they are not crying and fighting doesn't mean they don't need analgesia. So post-operative apnea, post-operative analgesia. Now the third case, this is a simple case. During pre-operative assessment for anti-VEGF injection for retinopathy, a 6-week-old weaker who's on room air, so no major BPD, room air is found to have 9 grams hemoglobin, prothrombin time 16 seconds, and APTT 56 seconds. The ophthalmologist, as usual, wants the neonatal, they want us to take all the responsibility, wants the neonatologist clearance for the procedure to be done in OT under anesthesia. Will you give clearance? How many of you will give clearance for this baby? And how many will not? Anybody who will give clearance? Yes? Giving clearance? Raise your hands. No. Not giving clearance? And if you're not giving clearance, why? What is the reason? You are giving clearance. Superb. Yeah, actually, yeah. Then anybody who doesn't want to give clearance? If you're not giving clearance, what is the obstacle here for you? You're worried about the APTT. Okay, you're not worried about the hemoglobin. Hemoglobin also is a little worrisome, and the APTT. Okay, let's see. Now, this is very important for us to know the normal hematologic parameters. And what I did a survey once, it was just a like bedside kind of survey, and I find that neonatologists have the least knowledge about hematology. I don't know for what reason. That is one thing they don't seem to, I mean, that somehow they have the least amount of knowledge about that. Now, hemoglobin more than 12 grams is needed only for major surgeries, or if there is some underlying problem like BPD, maybe a VSD, something like that, VSD with failure, something like that. Otherwise, Like for an anti-VEGF injection, even for a herniorrhaphy, 8 to 9 grams hemoglobin is enough if the baby is stable. Platelet should be at least more than 1 lakh for major surgeries. But this fourth one, please remember that the APTT matches the adult value of 35 seconds only at 4 months of age. Okay, so if we know these normal parameters, we would first avoid unnecessary investigations like sending factor 8 levels, unnecessarily giving FFP before surgery, and unnecessarily postponing surgery out of fear. Because anti-VEGF you don't want to postpone, like unlike the herniorrhaphy. Okay, so knowledge of normal hematologic parameters, and hematology you should be individualized and restrictive in your transfusion criteria. Very sick baby, higher hemoglobin. Stable baby, lower hemoglobin. And understand that PT also reaches the adult level of 12 seconds at about 1 to 2 months of age, and APTT only at 4 to 6 months of age. So this baby can be safely subjected to surgery. Then just 3 or 4 other issues. One is antibiotic prophylaxis. Okay, in general, see if the baby is already having stage 3 NEC or perforation, something like that, they would already be on antibiotics. But for clean surgeries like say an ovarian cyst or you're doing an inguinal hernia, the first dose should be given not earlier than 60 minutes of incision. Okay, you cannot give it in the NICU and shift the baby much later because you need high tissue levels of antibiotic during the surgery to prevent sepsis during surgery. Okay, so ideally this should be done after shifting the baby into the theater, just before the incision maybe, or just as the anesthetist is getting ready, it can be given. Most commonly, surgeons still use cefazolin. And even for CDH, hernia repair, even elective colostomy, cefazolin is enough. Piptas with metronidazole, etc. for gut perforation, TEF, etc. But in all cases, stop antibiotics within 24 hours for clean cases. If no sepsis have developed during and after surgery, don't give the antibiotic for more than 24 hours. Fluid electrolyte and nutrition. Breastfed babies should be kept NPO for 4 hours, formula fed for 6 hours before surgery. Correct dehydration and dyselectrolytemia pre-op. So that, we don't get this answer. It could have been an electrolyte problem if something happens after surgery. And this dehydration, especially it's important for some surgeries like pyloric stenosis or meconium ileus, where you did the gastrographin study. In general, when you suspect dehydration, third spacing, err on the side of giving slightly more fluids than slightly less fluids. Okay, they don't tolerate dehydration well during surgery. And post-op, don't delay feeds a lot. In fact, in some of my surgeons, even for a resection anastomosis, they start feeds with 24 to 36 hours. Ostomies, they start in 12 hours, etc. And if feeds are delayed, start TPN to avoid a catabolic state. Monitor electrolytes and understand the nature of ileostomy fluid, CSF fluid, etc. for appropriate replacement. And then the other issue is, as it was mentioned, it could have been hypothermia. Thermoregulation is very important. Every hospital, every theater, every anesthetist may have their own thermoregulation prevention bundles, warming devices, etc. But what I tell my postgraduates and nurses is, at the end of the surgery, just before shifting the baby back into the NICU, in the theater itself, check the temperature once. You will be amazed how many babies are having 34 to 35. Because most of the times, the first temperature we document is after they have been warmed up. They come into the NICU, they spend 10 to 15 minutes under the warmer. But if you take it there, you'll be amazed that there's so much of hypothermia. That documentation will also remind the surgeon and the anesthetist next time they should be more careful about the temperature. I think that's the only way we can constantly remind them is before accepting, check a temperature in the theater. Hypothermia aggravates cardiorespiratory instability. It's an important cause of cardiogenic shock post-operative. Then this last slide, who does what? Okay, in your hospital, suppose a baby needs to be intubated for the surgery and was not on the ventilator before. Who intubates the baby? Your team or the anesthetist in the theater? NICU team. Okay. Anywhere where the anesthetist does it? No, I can't believe that nobody is volunteering for that.
We don't allow actually.
You don't allow them. Okay, I also don't allow them. Good. Yeah, because see, we are more familiar with all these things. We are doing it all the time. They do newborns occasionally compared to the number of pediatric children. So look at the difference in the airway: large acciput, narrow nares, large tongue, narrow subglottis, floppy epiglottis. So many differences. We are dealing with it each and every day. They probably deal with it once a week. Okay, so it is safer for us to do it. And vascular access also, I prefer my nurses put in the IV, but I also send my nurse and they are there in the OT throughout the procedure, because in case something happens in between also, the NICU nurses are better at getting IV lines than the theater nurses. And in general, we don't send them with a PIC line, well, because you can't give boluses, etc. But if you send them with the PIC line, again, the nurse should be there throughout, making sure it's not getting blocked by non-usage. And of course, things like handing over consent should be done as a team. So intubation and vascular access, for the sake of your patient, for you to have a peaceful post-operative period, let the NICU team do it. So in summary, there's something called ERAS, Enhanced Recovery After Surgery Bundles, ERAS bundles. Only recently it has also been extrapolated with guidelines for newborns. So far it was there only for adults. So there you look at the preoperative, intraoperative, postoperative. Preoperative, anticipate the need for monitoring. Okay, use sensible, responsible, restrictive blood transfusion practices. Decide about the antibiotic, secure an IV, secure an airway, and shift the baby. Intraoperative surgical technique, regional versus general anesthesia are not under our control, but we can play a role in the fluid management and the temperature management, though it is intraoperative. Post-operatively, monitor for apnea. Don't forget analgesia. For analgesia, prevention is more important than active once pain is assessed. Don't forget the importance of early nutrition, stopping antibiotics, and involving the parents. So it's always a blessing when you have a surgical team and an anesthetist with whom you can get along perfectly as a neonatologist. That team, I think it's a blessing. Sometimes it's very difficult. I have been very blessed. I've had very cooperative surgeons and cooperative cardiothoracic surgeons, anesthetists. For example, in 2005, we established a cardiovascular NICU. That means post-operative care for a baby who just weighed 638 grams. The cardiothoracic surgeon, Dr. K.M. Cherian, he allowed us to do it in the NICU rather than keep it in the CT ICU, which was a very new concept that time, that babies survived and doing well. And recently we had a 900-gram baby for whom we inserted a pacemaker. And PDA ligations, we try to do it in the NICU rather than shifting the baby to the theater. So all this means a good knowledge of physiology, being blessed with a good team. I hope I had some useful points. Thank you.
Now I would like to request Dr. Gorli Satyanarayana sir to give a memento to Dr. Deepa Hariharan. Thank you, sir. Thank you, ma'am. So next we have panel discussion, skill building in neonatal nursing. What does India need? We have panelists, Dr. C. Nirmala, Dr. J. Venkateshwar Rao, Dr. Shruti Panjankar, Dr. Shilpa, Dr. Nagendra Chaudhary, and Mrs. Manisha Praraj. To moderate the session, we have Dr. B.D. Bhatia. Over to sir.
So that the panelists will be audible, no?
కింద దింపమన్నారు కింద దింపాము
Acha. I fell down.
Put it down. Put it down. కింద పెట్టాను
Yeah, because I will fall down.
Because you get involved in this.
मुझे नीचे जाना
దింపమన్నా దింపాను కింద పెట్టమన్నారు
थोड़ा आगे कर दे हम नीचे चले जाते नहीं पॉसिबल है नीचे
इसलिए ओपन करना पड़ेगा पीपीटी हाँ इसमें देख लेंगे ना हाँ सो इसमें वो पीपीटी ओपन
Sir, you might be needing the laptop.
Yeah.
So,
No. We will not be needing because he will be driving the show.
yes, sir. But he might be needing.
You can keep it down, na?
Not possible.
No. You see, ఒకసారి మళ్ళీ చెప్తున్నా నేను
Sir,
స్లైడ్స్ మేము ఎవరో రన్ చేయండి.
Yes, sir. Sir, కింద పెడతాము. Sir కింద కూర్చుంటారు.
That's it. ఎందుకంటే మళ్ళీ స్టెప్ అటు ఇటు అయితే సార్
Can I make it a full one?
Sir,
వీళ్ళే ఎక్కువ ఉన్నారు మనం You want us to make it anyway, we will do it. Mic.
इधर माइक होना दो
है
Should we start then? Yes. So we have a very important topic for panel discussion, that is skill building in neonatal nursing. What does India need? Now I have got 6 panelists with me, and courtesy Indigo, all are here. So Dr. J. Venkateshwar Rao, Dr. Nirmala, Dr. Nagin Chaudhary, Dr. Shruti Kar, Dr. Shilpa Kalane, and Dr. Manisha. So this is me, no need to introduce myself. Dr. Nirmala, she is Professor and Head Pediatrics at Government Medical College, Yadadri, Bongir, Telangana. Dr. J. Venkateshwar Rao is Professor of Pediatrics and Medical Superintendent at Mala Reddy Institute of Medical Science, Hyderabad. Then Dr. Shilpa Umesh Kalane, she is Head Department of Neonatology at Dinanath Mangeshkar Hospital, Pune. Dr. Nagin Chaudhary, he is Professor and Head Pediatrics at Universal College of Medical Sciences. He has traveled all the way from Nepal. Then next is Dr. Shruti Prajnakar. She is Assistant Professor, Department of Neonatology at IMS and SUM Medical College, Bhubaneswar. And then we have a nursing personnel with us, Miss Manisha Praharaj. She is Associate Professor of Department of Child Health Nursing from the Nursing College, Bhubaneswar. So we have got very learned panel with me, and before start, just few introductory lines. The neonatal mortality
rates. They have reduced from 40 per thousand live births in year 2000 to 20 per thousand live births today. But the sad thing is that it is stationary for the last couple of years. No further decline is occurring. Yet every year, 5 lakhs newborns, they do not survive the first 28 days of life. And this is one area where we can make some impact if we improve the quality of neonatal nursing. So this looks like should be the single biggest modifiable factor deciding the survival and long-term outcomes. Now the objectives for today's panel are identify the real skill gaps at the bedside, not just on the paper. Then prioritize the hard skills, the soft skills, the training methods, and the system fixes. Third, hear directly from a frontline nurse what actually works and what doesn't. And the four, arrive at 2 to 3 concrete and actionable recommendations. So to start with, Dr. J.V. Rao, what do we believe is the single biggest skill gap in neonatal nursing in India today? Is it the lack of knowledge, a lack of practical skill, or it is a system failure?
Thank you, sir. At the outset, let me thank each one of you for coming to listen to our discussion on such a very important topic to improve the neonatal outcomes, especially post-lunch time. Thank you very much once again on behalf of the faculty and the moderator. Sir, the most important point here is there are three things here. Is it a application of knowledge in terms of practical skills, that is what is lacking, or both are lacking, either knowledge as well as practical skills, or is it a systems failure? I would like to tell you very clearly that enough knowledge, at least a reasonable amount of knowledge, theoretical knowledge is being imparted to the nurses, but there is a lot of gap in terms of application of those knowledge into the bedside. That means that the guidelines which have been taught to them are inconsistently applied on the bedside. Next slide, sir. And once we know that there is a gap between the knowledge and application, the next important point is recognizing this gap is one of the most important steps for skill building initiatives. Because we need to prioritize, at least address this issue, the most important thing, then find out why reason is, or for what reasons there is a gap between knowledge and practice, and what you can do to correct that. Next slide, sir. So why actually there is a block in terms of application of knowledge into the practical skill? Many times workload is more, nurses are being overburdened with work, there is nobody to supervise, no structured kind of monitoring happening. And what is the solution for that? So the only solution, or the best, rather say evidence-based solution, would be to go for a simulation-based real-time kind of training, which is proven to reduce the gap between the theory and practice. Because studies have shown that there is significant improvement in terms of practical application once there is a simulation-based training. Now let us come to the another stark reality and a pathetic situation where what is the recommended ratio of nurses with regards to babies whom they take care? 1:1 at least for normal, very critically babies, and normal NICU 1:2, at least basic care 1:3. And look at what actually is there. Next slide, sir. Now look at this pathetic situation where there is a ratio of extreme incidents where there is a 1 nurse for 25 babies, especially in poorly staffed government setups. There is a lot of disparity or discongruence between what is required and what is exactly happening. And there is an article in JAMA Pediatrics in 2025, where they have clearly mentioned that once a nurse is taking care of more than 3 infants, automatically there will be a critical care task missing and the outcomes are likely to be proved. So that means there is enough evidence to say that overburdened nurses will lead to bad outcomes in NICU. So now, what are the key challenges to implement this kind of initiative in terms of bridging the gap between the skill and the practice? There is a high attrition rate among staff nurses. Once a staff nurse gets into adequate rhythm, knows the basic skills, she moves on for a greener pasture, a better pay pocket. So NICUs, they made a study and found out that 20 to 30% attrition rate happens annually in many NICUs. And our training quality is many times it is qualitatively inferior and not very uniform and not very consistent, and protocols are not very standard protocol based. And another most important thing is our training modules or training schedules are mostly one-off approach. They come for a workshop, they go back. And we know that when there is a gap between what is knowledge and what is implementation, there will be a steep downward trend in terms of memory, and that leads to a lot of gap between, and there is no consistent way or consistent protocol to assess these modalities.
Thank you, Dr. Rao, for highlighting the deficits. Now, moving to the specifics. Dr. Nirmala, where are the most critical clinical hard skill deficits? Are we still struggling with the basics like resuscitation, or are the gaps in high-tech care like ventilation?
Yeah, good afternoon, everybody. The key concept here is competence is not permanent, that it requires maintenance. For example, the neonatal resuscitation program, which has been happening for more than 2 decades, and now it has come it has become mandatory that both in the public and private sectors that all will get trained in the basic NRP. So coming to the resuscitation skill, over a period of time, we have found that if there is no follow-up or the booster dose of the training, there is a decline in the training skills of resuscitation. So even after the certified course, over a period of 7 to 10 months, there is a decline. So the booster doses, like you train them again, and then it lasts for the next 4 months. So how do we manage this gap? So these are the gaps that need to be filled by low intensity, frequent and low short-term sessions to be followed up, so that they may continue to have those skills and not forget those skills. So with respect to wherein the studies have shown that even among the residents, that there is a decline in the skills. So the reinforcement has to be done. And in a Nepal study has been done wherein it has been found that if you do a weekly review as well as a preparation before birth, if the checklists that are formed, so which is well maintained or done in the advanced neonatal resuscitation program, where we have the performance checklist. So it helps in a stepwise maintenance and then not forget any step. So this has significantly had better retention, as well as the stepwise will be maintained, and it has a better performance. And similarly, monitoring and safety with respect to the ventilation. So when you do the ventilation, like the non-invasive ventilation, the monitoring is very important. And then whether hyperoxia or hypoxia should be prevented, because the consequences can happen with respect to we do the RP screening, but at the same time the nurses need to be trained in that and monitoring. So there should not be a gap, because it will have an adverse outcome. So even in resource limited settings, there may not be appreciation of the long-term outcomes. So we need to train them and reinforce them during the rounds, and every weekly reviews has to be done regarding the outcomes. That will go a long way in reducing the gap. And one more thing important is maintenance of asepsis with regards to hand hygiene, and even the KMC, which has reduced the mortality as well as the infection risk.
So moving to from hard skills to soft skills like communication and critical thinking. Now, Dr. Shruti, beyond procedure, the NNF CPG emphasizes on communication. How vital are the soft skills like the parenting counseling, the grief support, and interprofessional teamwork, and how do we formally teach these?
Good afternoon. Well, we focus a lot on neonatal resuscitation protocol, intubation, securing central lines, but we often forget soft skills. So what we have to remember is, though technical skills save lives, soft skills sustain the quality of life, and this has to be actively integrated into nursing care and nursing curriculum. And with the NNF CPG alignment, we are moving from patient-centric care. So when a nurse effectively counsels a family, she not only reduces the cortisol of the parent, but also reduces the cortisol of the infant, improving lactation, improving neurodevelopmental outcomes in the neonate we are nurturing in the NICU. Now, are these skills supposed to be taught or they have to be picked up by the juniors from their seniors? Well, we have to move beyond this. They have to be actively taught, and we have to rely on counseling pedagogies. Something as simple as the ask, tell, ask model, wherein the nurse asks or assesses the baseline knowledge and the understanding of the parents, and then tells or gives them small chunks of information without using complicated medical jargon, and then asks back or checks her or the parents' understanding. So this model can be effectively circulated, and there have to be structured methodologies to teach these models. So some simulations wherein she talks about how to break out an intraventricular hemorrhage should be as important as teaching NRP. Now, aviation industry is in use for the wrong reasons, but the CRM or the crew resource management is something they champion about. So we have to take lessons from them. Communication has to be standardized. Situation, background, assessment, and recommendation should be the format so that there is no role of hierarchy. So we have to actively teach it to our residents and nurses, and we have to give a lot of emphasis to closed loop communication, wherein the sender initiates, the receiver interprets and validates, and then the sender confirms and closes the loop. And finally, we have to focus on psychological safety. So a nurse, when she puts up a medication error, she should not be reprimanded because she is lower down the hierarchy. So she should have equal hierarchy, and she should be a part of the team. So soft skills are important.
Well said. Technology leads to survival, and then the soft skills lead to the better outcomes, neurodevelopmental outcomes. Now, Dr. Nagin Chaudhary, given the high risk, low frequency nature of neonatal emergencies, what is the role of simulation based training in building competence and confidence? How do we make it more than a one-day workshop?
Good afternoon, everyone. First and foremost, simulation-based training is a highly effective method for enhancing the competency of the nurses, those who are providing, or those who are involved in the nursing care. It provides the opportunity for a safe learning environment, and it also helps to enable the practice without real risk to the baby. And it also helps to build the muscle memory and improves the psychomotor skills. And finally, simulation-based training reinforces the procedural fluency, like it helps in helping the sisters to assess the ventilation, and then it also helps in their confidence building. Next slide, please. And then why simulation-based training is important for the nurses who are practicing in the NICUs. First and foremost is it helps in the early error recognition and its correction. Because if you are practicing simulation-based training, it exposes the gaps in the knowledge and the system processes, and it helps us, or it allows us time for early correction. And second, it also allows us for the training of rare events, like whenever difficult intubation is occurring, simulation-based training, if they are trained well, and that will be beneficial to the baby. And then finally, it also helps us to allow as a team if we are practicing simulation-based training. Next slide, please. Now, the types of simulation-based training which can be assessed in the NICUs are high fidelity simulation and low fidelity simulation. High fidelity simulations are a complex resuscitation simulation. They are realistic, expensive, and then like whenever we are practicing full neonatal resuscitations. But low fidelity simulation tests can be carried out in our NICUs, like to acquire specific skills, like we can teach the sisters for umbilical vein catheterization and etc. Now, what is the evidence? The recent meta-analysis done in 10 randomized controlled trials shows that simulation-based training, especially high-fidelity simulation-based training, has a large benefit in skill performance and then knowledge of the sisters. Now, once we have practiced the simulation-based training, just a single training is okay? No, it's not okay. We should make it stick to our NICU. For that, we should have a regular in situ simulation-based training in day-to-day practices. Like we can advocate for mock courts in the actual NICU with the real team, And it not just only allows to test our skills.
Survive and thrive in those first few months of posting.
Thank you, sir. First, I will thank the organizing committee for inviting me here. So, before, so previous slide, sir. Next slide.
Next slide.
Yes, sir. The first question was that is the INC, is our curriculum is effective for the nurses, for the student to be in the NICU to learn many things. Yes, it is effective, but I feel key for student nurse when they are going to the NICU, so there should be extensive nursing period so that they, at least minimum there should be 2 to 4 weeks of exposure because they are going only for the 1 week in our curriculum. So in 1 week only they are exposing for the thing like only they are observing because there are many new equipments which they are only observing from the outside and they don't have that much of exposure. If it will be extensive period of for 4 weeks at least they will from the observation so they can go to the specific care and then to the individual care they can go for, and hands-on training on the modern equipments like high flow nasal cannula and CPAP and many more equipments are there. So which is they don't feel like it because they are only observing. So hands-on training is required. And one more thing is key simulation based training, as sir already said, key it is very much effective. So for the simulation based training, and I feel key it's a competency skill checklist should be there when the students are doing, so we can see how they are doing. So skill checklist should be there so that we can do. And one more point I will add here in the curriculum. So research and evidence-based practice should be there where new cases should be discussed, and any quality improvement like family-centered care and DSI, that should be there in the research. We can also go for this. And next, I will emphasize on the structure preceptorship because this one is very much important because when a new joinee will enter into the NICU, so many seniors are there. Many seniors have many different mentorship are there. But if they will assign to one person only, so that will be like the new joinee can trust to that person for a particular period of time. That person can supervise, that person can teach, and that person can be trusted so that new joinee can express all the thoughts and can learn from one mentor. So it will avoid the confusion. So it will increase the coordination, and it will improve the confidence of the new joinee, so they can also learn from the one mentor, so to avoid the confusion. Next steps. No, before sir, last one.
Thank
A psychological
That was the
safety.
last.
No sir, before first slide. Yes, sir. And one more point I will say, that is a psychologically safety environment. Because when a new joinee will enter, because already we have studied, now we enter to the NICU, we can't say, ki, yes, I don't know something. Because if sometimes what happens, if you will say, I don't know, maybe they will say, "Arey, you have studied already and now you're saying you don't know." So this will cause one emotional stress. So if senior nurse can allow ki yes, I don't know, is it safe for the person, and so that we cannot show ki ha, we know everything. So that is not possible for everyone ki we know everything. When we allow I don't know, so it will be reduce the emotional stress, and it will improve the resilience of the NICU, and it also improve the coordination between the staff and
Nursing
nurses.
staff should be encouraged rather than discouraged.
Yeah.
Thank you.
Thank you.
Dr. Shilpa has been waiting for long.
Yes.
So looking ahead, does India need a formally recognized cadre of neonatal nurse practitioners? What would their scope of practice be, and how would this address the existing skill gap?
Okay. So thank you, sir, for the question. So internationally, first we should know who is a nurse, neonatal nurse practitioner. So internationally, she or he is a master's or DNP trained advanced practice neonatal nurse. And beside bedside care, they have role in various other capacity, that is diagnosis and clinical decision making. Also independent or collaborative work with the neonatal team, the clinicians, and procedures like umbilical catheterization or intubation, as well as communication with the family members. Also, the evidence, including Cochrane, has shown that having an NNP in unit reduces the workload, improves the quality newborn care, also improves the communication with the family. So what is the Indian context? We have the similar frame like internationally known NNP, which is what we have is nurse practitioner pediatric nursing. This is the course designed by ICN. Now this is not specifically for neonatal nurse practitioner. However, it is a competency-based program. It's a very good academic program. So this can definitely pave a path for developing a course for neonatal nurse practitioners, sir. Next slide, sir. So why the NNPs are needed? So as we all are talking about having an NNP and having need for upholding the skills of all the nurses. However, we also need to realize there is a gap towards need for doctors as well. The doctors, there's only major times one doctor in level 3 NICU struggling with a lot of sick babies, and then level 1, level 2 babies predominantly is handled by nurse. So we need someone the mid clinician level who can take care of the level 1 and level 2 NICU babies, and the neonatologist or the doctor can take care of the sick level 3 babies. So that is how we need an NP. And yes, so impact on care, I already said that it has, the evidence is good enough that NNP has shown an improvement in quality care, and also it has shown the impact at the system level as well. So yes, we should think about starting or having an NNP program in India, and we should have a nurse with that cadre.
Thank you, Dr. Shilpa, for adding new dimension. Coming to the Dr. Nirmala again, even with the trained nurses, adherence to protocols is a major issue. How do we build a culture of quality and standardization? Is the answer checklists, audits, or something else?
Yeah, here basically in NICU we look at prevention of harm and prevention of infections and better outcomes. So here to maintain this, we have the bundle, which is a small set of evidence-based practices, which when done together has been found to, particularly when you start central lines, CLABSI has been reduced. And these are the things that follow in rather than individually doing it, when you do as a set, it has found a significant reduction in the central line infections. And why they work is because it acts as a checklist, and together as a team you do it, it reduces, and then reliance on memory, because sometimes a case is going down hill, then you are in the stress, and as a teamwork when you do, the outcomes will be better. Next slide. So how about auditing? Auditing is where we have a systematic data collection on the compliance with respect to the documentation or bundle elements and the outcomes. So by taking the feedback, by auditing, you know what are the gaps which need to be reduced. And then in the clinical settings, particularly, you have seen the antimicrobial stewardship in NICU, wherein an audit and feedback has reduced the usage of antibiotics in most of the NICUs. And what are the key principles here is do a timely multidisciplinary involvement with transparent reporting, so that everybody has a safety environment and also safety culture where, like Manisha was saying, that even the whole team, including the nurse, should not think twice before, say, pointing out the errors on how to improvise. So this is the safety culture and safety climate.
Next, Dr. Shruti. Now we can train nurses, but how do we retain them? That is a major issue. How do the high stress work environment, the burnout, and high staff turnover fundamentally undermine all our skill building efforts, and what is the solution?
Well, moving to the crisis of retention, I call it the leaky bucket analogy. So we spend a lot of skills, we spend a lot of time and resources in training these nurses, the nursing capacity, and what we realize is they eventually get burnt out and they leave the unit. So there is a turnover which is as high as 25 to 30% in some units. And when the staff leaves, there is an increasing load on the remaining staff, and then the remaining staff gets burned out, and then there is more turnover. So as a result, there's a perpetual novice workforce who is not properly trained, and this leads to a loss of institutional memory, which is very, very essential in ICU. So what we have to understand is this is not just an HR issue, it is a safety issue. And data has shown that the impact of emotional exhaustion and depersonalization has led to increased medication errors, less adherence to protocols like hand hygiene and central line bundles, which are essential for preventing sepsis, and there is reduced vigilance in monitoring. So when a nurse is affected, her cognitive skills are also challenged. So burned out clinicians have less power of taking decisions. So how do we go about this? How do we plug in these leaky bucket channels? We need to understand this is not a salary issue. This is about professional dignity. So there have to be formal titles. So the NNF is working for it, and something like specialty nursing in neonatology or a critical care nurse staffing can be done. And career ladders, most often we see that once a nurse wants to climb up the ladder, it is often in the administrative side. She does not stick to bedside. So there have to be defined career ladders where she can become a nurse specialist, a nurse educator, and continue to teach bedside. We have to understand that safe staffing should not be limited to guidelines. It has to be a policy that has to be implemented. 1:1 for ventilated babies, 1:2 for stable babies. Moreover, we need support systems. So there is something called the code lavender. So there has to be a mandatory debriefing after critical events like deaths, wherein the nurses are counseled so that burnout is addressed, and then shared governance has to be emphasized upon. The nurses have to be empowered. They should have a voting in the unit decision. They should be a part of not only caring, they should be a part of the treatment plan. So we have to care for the carer.
Mostly the staff nurses, they retire as the staff nurses only.
Absolutely, sir.
So they don't get promotions. So coming back to Dr. Shilpa now, simulation is a high impact but can be resource intensive, especially in a large country like India. To train hundreds of thousands of nurses, how can we leverage low cost technology and digital platforms like e-learning, video training and mobile apps to scale up training and provide continuous at the bedside support?
Thank you, sir. Very important question. So, as we all know that India has around 800 SNCUs and thousands of private NICUs, and the traditional teaching method like workshops cannot keep pace with the need of upgrading skill of so many nurses. So we have to have something which is low cost, high volume, continuously reinforcing, and also standardized across the nation. So, sir, can we go to the next slide? A typical workshop generally caters to around 30 to 40 nurses, and if we stretch maximum 60 nurses, and the need is like even thousands. So the certain techniques, like like this slide has shown, that e-learning modules, video-based training, and mobile apps can to some extent may fill this gap. So how does this help? So e-learning modules, as we know, that it provides a uniform knowledge baseline. So the person sitting in the remote area can have access to the standard modules and can have up-to-date knowledge about the standard protocols. Also the video-based learning, which is just-in-time videos, like for example, umbilical catheterization or intubation, hand hygiene, IV cannula, or simple process like BSL, how to check the sugars. So these short videos can really keep the procedure standardized, and also keep the can help in keeping the nurses up to date in terms of protocols. So mobile apps also can keep the nurses updated about the evidence-based protocols, which keep on changing, as we all know that every time. So that also is a good modality which can reach to thousands of nurses. So together, these can meet the requirement of high volume teaching, as well as maintaining the standards of continue with the standardized protocol, also continuous reinforcement. And we've seen so many slides right now that a single teaching is not really happening now. Single teaching leads to decays. There's a lot of psychomotor motor delay with that. Psychomotor, which decay? Yes. So it doesn't lead to retention of the knowledge. So we need to have something which is continuously reinforcing. Yes, sir. Next slide. So yes, the blended learning model where we have online theory and then hands-on practice also leads to retention of the knowledge and upgrading skill. The eco model, which is extension of community health outcome model, which is a very good innovative model where it's not based on the mentorship, but where the expert can guide the person who is sitting in the remote area about the skill, knowledge, may debrief the person, and this is how can keep the person updated about the critical cases and also the recent protocols. Similarly, something called digital skill passport, we can keep a track of the accuracy and learning. Also, it is like a logbook, online logbook, so it can keep a track of skill retention and the progression also. So the next slide. So yes. So one line I would like to know: simulation is definitely costly, but in right hand and right way, it is definitely productive. And it's not one method; it is combination of various methods which will help us in designing such programs.
Dr. Rao, now coming to finally towards the end of this panel, what is the one policy change or the national initiative the NNF should champion to fundamentally elevate neonatal nursing skills in the next 5 years?
So we have come to the last part of our objectives, and in order to prevent myself from getting roasted alive by Dr. Bhatia, if I don't give time, he's not going to spare me. I'll be very, very quick. So let us say step one. Step one is a single mandatory competency-based protocol of training, private as well as public, which is endorsed by NNF as well as Indian Nursing Council, also approved by the Government of India and the respective state governments. This is step one and the most important. Next slide, sir. And a formal certification process that to work in a level 2 NICU, one nurse should have some kind of a certification, not just attending a workshop. A skill-based training modality which she has undergone and she has got a certificate, that should be a must for her to make. And then linking ratios to accreditation. We have lots of accreditation agencies coming up under the Quality Center of India, QCI, and NABH, NNF accreditation. For all these things, you need to make that the NNF nurse who is working there should have these ratios are maintained, and the NNF nurses are have adequate skill training. Next slide.
Thank you, Dr. Rao. Now we had Dr. Nagendra from Nepal, so we thought it would be in the fitness of the things that what is the status of the nursing education in the Nepal. He can just deliver it upon.
Thank you, sir. So the main challenges and the barriers which the nurses of Nepal are facing is similar to many of the nurses of the low and middle income countries. So the main issue in our country is like we have a high infant neonatal mortality rate, which is a major concern for our nation. And another, there is a discrepancy between the rural and urban healthcare facilities and the facilities which the nurses are being providing, and a persistent knowing-doing gap that is also a major problem of the nation. And finally, we have a geographical barrier and low resource constraint in the nation is one of the challenges which we are facing. And then now, just I would like to tell you that what are the skill development pathways for Nepal. So the major educational pathways are similar to other countries, like we have proficiency certificate level in nursing, and then bachelor programs like BSc nursing and bachelor in nursing science are provided, and master programs are also provided. And then these programs are accredited or licensed by the Nepal Nursing Council. And then there are various universities in the nations like National Academy of Medical Sciences, Institute of Medicine, and other affiliated colleges. They are responsible for providing the bachelor and master programs. And then during these programs, the various trainings are also collaborated by the government of Nepal and various INGOs and NGOs. Next slide, please. So what are the formal programs of the nation? So we can just classify it into two categories that the nurses are receiving. One is the pre-service training of the nurses, and another is in-service training. So pre-service training is during the nurses are being trained in the nursing schools. So they are we mainly focus on child health nursing, and the nurses are also taught midwifery nursing for taking care of the mother and the babies. And simulation-based training are also provided to the nursing during their curriculum. And in service training, the nation provides skill birth training or SBA training, and that is provided by the Ministry of Health and Population and National Health Research training councils. And one of the important training the country has initiated is helping babies breath, or SBB training that emphasizes on the neonatal resuscitation program. This is widely used all over the nation, and it has drastically reduced our neonatal mortality rate. It was introduced in 2012, and this training has been integrated both in the pre-service curriculum as well as the in-service curriculum of the nurses. And they are also provided by our nations, and it is also funded by the American Academy of Pediatrics. Next slide, please. And then the Nursing Council of Nepal has also mandated CPD programs in their curriculum. Now they have made compulsory CPD points for their renewal. So that is also one of the important steps that the Nursing Council has taken to enhance the nursing skills of the nurses. Next slide, please. So, in spite of all these programs, we still have challenges. There are gaps, and then there are areas of improvement. So, as Sir has already told that we don't have any widely established neonatal nurse practitioner in Nepal. Also, that is the major challenges for us, and the resource limitations and infrastructure gaps in low and middle income countries is a major challenge. Geographical disparities, like in Nepal, we have mountains, Madhya, and rural areas, and various private hospitals, they don't have a uniform protocols, and then they have their own protocol treatment. That is also a major concern for us, so that the nurses are not being able to provide appropriate care. And finally, skill retention. That's not a one-day procedure. That requires a regular ongoing training, QI cycles, and refresher trainings to prevent knowledge decay. So I think if these areas of improvement are addressed for the nurses,
Thank
we
you,
can
Dr.
have a
Nagin.
better nursing.
So coming to conclude the plenary discussion, what does India need? There are 4 recommendations. First is a unified standard. We need a standardized national curriculum, a single mandatory competence-based framework for all NICU nurses, which is endorsed by NNF and Indian Nursing Council. Then the formal recognition. We must move towards mandatory credentialing and certification for the nurses working level 2 and level 3 nurses and NICUs, ensuring skills go beyond basic orientation. Then policy enforceability, link ratios to accreditation. NNF nurse patient ratio of 1:1 for ventilated, 1:2 for stable babies must become a mandatory requirement for NABH and NNF accreditation. And the way forward is standardize the care bundles and checklists, sustain continuous simulation and mentorship, and scale low cost, high impact technology. The journey is of 1,000 miles, but begins with one step, and that one step has been taken by the NNF today. So I would like to just thank all the panelists for doing a wonderful job, sticking to the time, and we have just crossed 8 or 9 seconds more than the allotted time. Thank you.
Thank you, sir.
Thank you, sir.
Now I would like to request Dr. B.D. Bhatia sir to present mementos to the panelists. Thank you. The next session is Changing Clinical Scenarios of Pertussis in Recent Time by Dr. Sunil Agarwal. To chair the session, we have Dr. Chandrakala. May I request Dr. Chandrakala ma'am to introduce Dr. Sunil Agarwal. Thank you.
Madam there.
Introduction slide and
Hi sir, hi sir. Hi sir. Now I would like to request Dr. Venkateswara sir to give memento to Dr. Bhatia sir. Oh. छोड़ दो one line.
Can I have the introduction?
I have to charge 10 minutes. That's why.
Yeah. The slide?
No, slide is there. Just tell Sunil Agarwal. That's all.
Okay. Okay. So I'm pleased to introduce Dr. Sunil Kumar Agarwal, sir. He's a professor of pediatrics, CBMCH Cuttack. Over to you, sir. And sir is speaking on changing clinical scenarios in pertussis. Over to you, sir.
Next. Very good afternoon, all. First of all, thanks to my chairperson and dear all IAPNs and NNF members gathered over here. And as you know, this is a mixed bag. So my part is only 10 minutes. So I'll be talking on a subject which is related to more or less more of prevention. So as because it is a neonatal conference, so my part to prevent certain diseases which are known as vaccine preventable disease. And this program is being sponsored and supported by GSK vaccine. With this disclaimer, so I am going further. So before going to that, I must say today is a great day, 12th December. So 12th December, in our initial decades back, we used to celebrate this day as National Youth Day because of it is birth anniversary of the then, you can say Vivekananda, Swami Vivekananda. And number two, today also birthday of Tamil megastar Rajinikanth. So second character. Third character, today is also birthday of great legendary cricketer Yuvraj Singh. So that means I mean to say these three characters are there. So I'll be talking on 3C vaccine. So what is three character? You will be coming to know one by one. First part, each pertussis still is a concerned disease. Number one, pertactin. What is that? Number three, is it going to have some clinical relevance or not? Lastly, is there any guideline that we have to follow and we can immunize our premise 1 kilo, 1.5 1,500 gram premise, can we go for vaccination? First part, is pertussis still an unresolved public health concern? Answer is yes. Now if you see from 1980, the DPT vaccination when came before 1985 and now in 2023, in the era post-COVID also, with 90% of coverage in Indian scenario, still number of cases of pertussis are to the tune of 3 lakh. So 2.23 lakh cases of pertussis still do occur in our country, and out of them, many, maybe 10-20% do occur in the neonatal period. And neonatal pertussis mimic like neonatal sepsis. It is very difficult to differentiate between the two, and we are missing out a lot of cases of neonatal pertussis or sepsis going to die. With that note, a study has been done in Western India that a lot of mother and infant pairs has been studied, and they have come out 87% of mother and infant pair are are unimmunized. I means the antibody titer has gone down. So that's why the need is that either you give acellular pertussis vaccine to the mother so that you can develop the antibody. It will develop via, it will cross via transplacental barrier and it will enter into the baby and protecting pertussis in the initial part of first or 2 months of life. And second, at 6 weeks, you are planning to go for DPT containing combo vaccine. So definitely it is a matter of concern. Going to the second part, what is Pertactin? I have already told, think this is a Bordetella pertussis. Now Bordetella pertussis crude wholesale antigen is having 1,000, 2,000, 3,000 number of antigens. But if you segregate them, come out with only 1, 2, 3, 4, 5, then these are known as 5C component. Number 1 is your pertussis toxin. You see pertussis toxin. Then number 2, filamentous heme agglutinin. Then comes your Pertactin. Then Fimbria 2 and Fimbria 3 antigen. So that means if you are giving one acellular pertussis vaccine, one that has to be pertussis toxin. If 2, then it has to be filamentous heme agglutinin. If 3, then Pertactin has to be there. So there are 2 component acellular component vaccine available in the globe, in India as well. So one is 3 component from GSK, another is 2 component from Sanofi. So 3 component means it contains Pertactin. 2 component means it doesn't contain Pertactin. So what is that Pertactin? This is the antigen which is present on the surface of the Bordetella pertussis, which is responsible for adherence to the mucosa of the nasopharynx. Number 1, and it decides the virulence factor. So that's why if Pertactin is there in the antigen or in the vaccine, the antibody will be formed and that antibody will not allow the organism to attach and not allow the organism to enter and evade the immune system. So that's why it is good to have 3C component rather than 2 component. So going further, increasing relevance. It has been seen for last couple of years post-COVID in the France. There are many outbreaks are there, and the outbreaks Bordetella pertussis, they are morely Pertactin positive. So that's why you should have a vaccine which contains Pertactin. Second point, in Slovenia, there is an outbreak that is also Pertactin positive. So that means we should have a vaccine that should be more component than 2C, 3 component, and it should have a Pertactin as one of the components so that it can prevent the virulence and it can prevent the attachment of the bacteria into the nasopharynx. So anti-Pertactin antibody, they develop and they help for the phagocytosis of the organism. So that's why it is necessary that in the vaccine, its presence makes a lot difference. So that's why GSK, multinational company, vaccine company, acellular Pertactin containing pertussis vaccine have developed high efficacy. Number 1, acellular tri-component pertussis vaccine with this is having a definite placement in the global market. Although there is no accepted correlate, but still it is a better than the 2 component, and Pertactin has an importance role because it goes via Th17 response along with other response. That means it has been seen that there is a faster lung clearance if the Pertactin component is there. So in order to summarize what I have told, number 1, the 2 component versus 3 component. 3 component is there where Pertactin part is there. Number 2, Pertactin is necessary as of now because it bypasses the virulence and adherence. That means this antibody which is going to be formed in the body, it doesn't allow the Bordetella pertussis to stay for a longer period in the nasopharynx, and it will not allow to cross over the immunity and going and causing the complicated or fulminant pertussis. So that's why its importance is there. So going further, immunological insight, immunological outcome from India, what is there? Long-term immune persistence is there or not? What is the real world data and special population preterm? It has been seen that if this vaccine is given as 6, 10, 14 or 2-month schedule, if you go to America, they give 2-month schedule. That means 2 months, 4 months and 6 months. In India, we give all the vaccine early because the India population is high and we have to give all immunity to our children earlier part of time. So that's why it has been seen all the component which are there in the hexavalent acellular component vaccine from GSK, they are having a more near about 100 to 99% antibody titer development after 3 doses of 6, 10, 14. So that's a good vaccine. So going further again, documented that immune persistence can occur more than 7 years. So that means 7 years, 10 years. Hepatitis B has been studied. The immune persistence can occur or can stay beyond 17, 18 years as well. So that means whatever hexavalent is there, in PI it has been seen, it has been written. This GSK hexavalent 3-component vaccine can be used up to 3 years. That is starting from 6 weeks, it can be given up to 6 years. Now question come in 3+1 schedule. In the 1.5 year booster, you don't need hepatitis B. But still then, 1 dose of hepatitis B as a hexavalent doesn't cause no harm. Or that means no local reactogenicity. It is very safe. Government, WHO has already been told that 1 component of extra dose of hepatitis B will not cause any harm. Rather, it will impact and boost the memory cells regarding hepatitis B. So with that note, finally, is it important or is this vaccine Infanix Hexa can be given to the preterm, can be given to the less than 1,500 gram, can be given to the less than 28 weeker? Let's see that there are 10 clinical trials are there, more than 1,600 preterm infants included, and 10 clinical trials they say that this vaccine is safe beyond more than 24 weeker. That means a teeny baby of 900, 100, 1000 gram, if the baby is hemodynamically stable, that means hemodynamically stable baby, you can go ahead with this vaccine. But otherwise not on the chronological age, on the 6 weeks. This cannot be given at birth. Birth, oral polio, birth, hepatitis B, birth you are giving BCG. But when the 6 weeks chronological age comes to a LBW baby, you can go ahead with this vaccine. Similar level of seropositivity, seroconversion, everything you can point and get it granted that whatever the term baby is going to develop, the same type of immunogenicity is going to develop in preterm and LBW babies as well. Well tolerated. There is no side effect much more in preterm babies. You know, preterm babies are immuno-immature. So that means the immunity is not good, but still then they mount good antibody response to those antigen. So that's why it is to be given. And everybody of us know the preterm babies are more vulnerable, more high risk for these vaccine preventable disease. They can die of pertussis, they can die of diphtheria, they can die of any disease you can say. So that's why these vaccines are very safe in them that we can go ahead. Infanix Hexa is well tolerated with co-administration of you are giving what vaccine along with hexavalent. One is PCV, that is pneumococcal. It is very safe. The pneumococcal take-up will not be interfered with this hexavalent component. And you are giving rota vaccine orally. So nothing wrong if you are giving co-administration with this vaccine in premix. Then immunogenicity in preterm, all the components are having very good to the antibody titer, maybe to the tune of 99 to 100% as good as term babies. So always remember, preterm baby, don't wait for 2 kilo, 3 kilo weight to come or 2 month, 3 month the age to come. It is not like that. If the baby is hemodynamically stable, you can give, but only caveat is that if the baby is nearing to 28 weeks or the weight is less than 1000 gram, by that time some babies they develop apnea. So that is the reason this vaccine to be given in a setup where ICU setup or in a hospital setup. So don't give this vaccine in then and there in the clinic if the baby is too much preterm and lesser than 1000 gram. So that's all about. Infanix Hexa has a similar tolerability profile in preterm and full-term infants. That means local symptoms. You know, this DPT vaccine, which is combo, now hexavalent. I am talking of acellular, 3 component versus 2 component. Whatever I told till now, it is 3 component, which contain pertactin, and this causes some amount of local reactogenicity because it is because of the pertussis component. So there will be swelling, there will be erythema, everything, nothing wrong. You can apply ice with a piece of cloth for 2 to 3 days. You can give paracetamol. Prophylactic paracetamol never to be given. That has to be kept in mind because that will inhibit your mounting of antibody response to the antigen. So prophylactic paracetamol has no role. Now coming back to pain, redness, swelling, everything is same as whatever you are getting in the term baby. So message from this is that preterm babies, there are a lot of data is available from GSK that this vaccine is very well tolerated, very safe and immunogenic in cases of preterm babies. So finally, there are a lot of academy, American Academy of Pediatrics, then Advisory Committee of Immunization Practices, ACIP, IAP, everybody has told that this vaccine is safe and it is to be given to the preterm or LBW as per chronological age. If the chronological age is 6 weeks, you can go ahead with this vaccine. So after that, the last line, safety. Always the vaccine should be safety because we are giving acellular in office practice. But the government gives W. W means wholesale. And government gives pentavalent, not the IPV as a component. But here added component is IPV. I mean inactivated polio vaccine. So that's why the safety and healthy people, because we are giving this vaccine to a healthy kid, and that must be very safe. It should not cause any anaphylaxis. We have never seen anaphylaxis in a preterm, in a small baby, because of immunological immaturity. But still then, in bigger children, if at all anaphylaxis develops to first or second component, the subsequent component are never to be given. So anaphylaxis to the first component is a absolute contraindication for the subsequent uses of this vaccine. So finally, dear delegates or dear doctors, I must say, if you compare on one side acellular, another side wholesale, risk of generalized reaction, local reactogenicity, fever, whatever you say, they are 3 times more with the W, I mean wholesale. Injection site swelling, everything 4 times more, and risk of fever and sometimes febrile convulsion. You might have seen wholesale pertussis given at 6 weeks may have a fever induced seizure within 1 or 2 days and nothing wrong thereafter. You admit the child, do a lumbar puncture, sepsis strain, everything is negative. So that means it is early presentation of fever triggered seizure in a susceptible child who is having SCN1 gene, and that is causing seizure in an early child, I mean 6 weeker or 10 weeker. So you have to manage with that. So with that note, how relevant is it in my practice? Suppose I am giving 3 components with a Pertactin and 2 components from Sanofi without Pertactin. Is it going to have, number one, in Indian scenario, this is cost effective. That means there is a difference of 500 to 800 rupees difference, and you are giving 1 component extra, just like you are going to a shop, buy 2, get 1. It is just like that. That you are giving 2 with a 1 bonus. So that means Pertactin, and that is need. It is scientifically driven. So that means that if you see 10 cases of fever, 7 cases of redness, 6 cases of pain, and 4 cases of grade 3 systemic response are lesser in comparison with 2 component, that is Sanofi. That means these are the benefit. Some amount of reactogenicity lesser with this 3 component in comparison with 2 component of Sanofi. So now is there any head-to-head trial with the wholesale component? Now you must be seeing there are 4 vaccines available in India which are containing 6 antigen. What are they? One is GSK Infanix Hexa, another is Hexaxim from Sanofi, another is from Serum, that is W, that is Hexacil. You must be using that Hexacil, that is 6 component, and another is from Bharat, another is from Panacea Biotech, that is EG6. And these 2, that means last 2 are wholesale. Now if you see pain, the least pain is there with the first one, least redness, least swelling, least fever. So it means that not only it is reactogenic wise or systemic reaction wise, it is better in comparison with the other competitor like 2 component, but also it is much lesser in comparison with the other existing 2 wholesale pertussis vaccine in Indian market, one from Serum and another from Panacea Biotech. So it has been concludingly, we can safely depend on this cost effective vaccine, that is known as what? Infanix Hexa. We are giving Pertactin, and this is can be given even to the preemies, to the small kids having lesser than 1,500 gram as well, provided it must be, the baby must be vitally stable. If the baby is vitally hemodynamically stable, then only we can go ahead. So with that note, global experience, only hexavalent vaccine, more than 20 years of experience. Infanix Hexa has been used more than 100 clinical trials, registered in 94 countries, more than 6 crore kids as of now vaccinated. And this is the brand picture you see, Infanix Hexa. Many of us have used in our day-to-day life. And pertussis containing Pertactin is the need of the answer. A 3 component already we have showed that the persistence of immunity beyond 7 to 17 years. Meta-analysis says it can be very safe to be given in preemies, and reactogenicity outcome superior than any other hexavalent vaccine available in Indian market. So with that note, I must be saying, what is the 3 component? Competency, credibility and capability. This vaccine is giving all the 3 points in a 3 component way. So I feel if you have choice to go for double role on one side Sanofi and triple role on one side Mahan from the same character, that is Bordetella pertussis, I don't know, Amitabh Bachchan is the Bachchan of India, and one side triple component, another side double role in Adalat, we will choose what? It is your choice that the science given is 3C is better than 2C, or 3 component having Pertactin is much better in comparison with that. But your brain has to understand that if you are giving at a lower affordable cost, then definitely we can go for that. And finally, being a IAPN and NNF member from East Zone of India, I welcome you all to Calcutta Pedicon in the next next year, I can say, or next month. So welcome to that. Thank you very much for this vaccine talk and supported talk from GSK. Over to Madam. And Madam, please leave me in 1 minute because I have to catch plane. Only 15 minutes is there.
Thank you very much, sir, for your excellent presentation, which is very useful. Can we allow any questions from the audience? Or
one question.
One question.
Yes, yes. Right. Yes, I'll come to you, sir. Very good question. That is wholesale versus acellular. Wholesale is a crude antigen. It contains whole body pertussis as a whole. So that means 2,000 or 3,000 antigens are there. It has been seen the transmission from a person to a person or a baby to a baby because of Th1 response, the wholesale is having some edge over acellular pertussis. So community transmission is altered by that, but not by acellular pertussis. So that is a gain of that because it is Th17 mediated and that is Th1 mediated. So that's the reason that is there, and that's the reason in our government of India never going to change in a populous country like this from wholesale to acellular. But having said that, go to the country like US, go to the all developed country as of now, even if there is upsurge, they have not changed acellular to wholesale. Why? Because acellular, even these three components, that is good enough in prevention of pertussis in the individual, may not be preventing the transmission because it is not wholesale. Thank you very much. So I take leave from everybody and thank you very much. Hopefully I will catch my train. Thank you very much.
Sir,
sir, 1 second, sir. Thank you. Sir, 1 second. Sir, you need to take a moment.
Thank you, sir. Next topic is kangaroo mother care. Kangaroo care in babies on respiratory support by Dr. Chandrakala, ma'am. To chair the session, we have Dr. Kishan, sir, from Apollo Hospital. So I would like to request Dr. Kishan, sir, to introduce Dr. Chandrakala, ma'am. Thank you.
Good evening, all the delegates and speakers. So I would like to introduce our next speaker, Dr. Chandrakala, madam. She did her MD, DNB, and DNB neonatology and holding a fellowship of IAP. And currently she is working as professor in Department of Neonatology in St. John's Medical College Hospital, Bangalore. I welcome you, madam.
Thank you very much for the warm introduction. Start. Good afternoon, everyone. Let me start my presentation. So, an important topic today we are discussing is kangaroo mother care on babies with respiratory support. So, I don't know how many of you are following this. How many of you are really giving KMC for those babies on respiratory support? Can I have your raised hands? Excellent. Excellent. Okay, so I'm going to discuss about that now. So these are the outline I'm talking on KMC, and we all of us know that with global evidence that KMC reduces mortality 32%, reduces hypothermia, and of course infection reduction. So what are the components of KMC? All of us are aware that, continuous skin-to-skin contact with the mother or the caregiver, and it is to be started as early as possible, and promotion of exclusive breastfeeding as soon as possible, and discharge the baby and continue that at home with the involvement of the family. These are the core components. All of us are aware of that. So this is what I was talking about, the evidence. What is the evidence for kangaroo mother care? All of us are aware of that. Reduces mortality, hypothermia, and infection reduction. This is from a global study. So these are the components of KMC. All of us are aware of that. And we also know the physiological benefits of KMC: thermal stability, respiratory stability, and metabolic support. It reduces hypoglycemia, the variability of hypoglycemia, and support nutrition. This is very important. Another study which says, it is updated in 2025, says that in early introduction of skin-to-skin contact for mother and baby and across term and preterm babies, it has proved that it improves breastfeeding, thermoregulation, glucose stability, and maternal satisfaction. And we have a strong recommendation that skin-to-skin contact is a standard of care. All of us agree with that. So now, this is regarding the kangaroo mother care. So we are discussing about the kangaroo mother care in those babies on the respiratory support. All of us know that in preterm babies, the most important reason for morbidity is respiratory distress syndrome, and it is an important cause of mortality as well. We know in WHO says in 15 million preterm babies who are born, RDS is a leading cause. And that too, requirement of the respiratory support is more in extreme preterm babies. And also, we are aware that non-invasive ventilation is preferred to reduce ventilation-induced injury. All of us are aware of that. And this is regarding the non-invasive respiratory support. And I'm not talking much about this. This is a different non-invasive respiratory support which is available, is presented in this slide. So now coming to the landmark study. So it is in 2021, it was published in Lancet that it causes 25% reduction in the neonatal mortality and also secondary benefits as well. It reduces sepsis and hypothermia prevention and early initiation of breastfeeding. Now, so need for KMC in babies on respiratory support. The question, so we all know that preterm babies need respiratory support. And because of the respiratory support which is given in ICU, we need to separate the babies from the mother. And we also know that KMC provides thermal, respiratory, hemodynamic and neurodevelopmental benefits to the baby, to preterm babies. The question is now, can we safely combine KMC with respiratory support, reduce respiratory support duration? Does it happen? So that is a question which arises. So many systematic review, it says that yes, KMC can be started as early as possible and it is feasible. Coming to the next slide. In this slide, so what is the physiological basis for recommending KMC in those babies on respiratory support? So this causes a chest wall synchrony and regularizes breathing pattern in those babies, in preterm babies. And it reduces apnea and bradycardia episodes. And also it causes stabilization of saturation and heart rate variability. And this is a study where it says that, the first one, so the time, the heart rate being in the normal range of 120 to 160 beats per minute is in KMC, during KMC than before and after KMC. And also the time the heart rate is more than 160 in a baby is definitely, so it is more in those babies before KMC than during and after KMC. It says that KMC is beneficial, of course, in those babies requiring ventilatory support. So this, all of us know the advantages of KMC. What does this physiological role of giving KMC to the baby? It produces normothermia and it is comparable and superior to incubator care, that all of us are aware of that. And skin-to-skin contact reduces the cortisol and increases melatonin in preterm babies. And it is very important to note that there is a dose-response relationship between the hours of KMC or skin-to-skin contacts we give and the cardiorespiratory stability in a preterm babies. Now, this is NIV and respiratory support, all of us know which is better. This is a Cochrane data available. What is the implication for practice? Many preterm babies can remain in non-invasive ventilation for prolonged period in NICU. So can we use this? This is an ideal window to deliver kangaroo mother care. So can we start KMC there itself? Do we have to wait for the baby to hemodynamically become stable to start KMC? This is a question which arises. So KMC in non-invasive ventilative support in ELBW babies, the cohort, which says that, you know, in a KMC group and in as compared to non-KMC group, in KMC, non-KMC group, so KMC independently reduces the duration of the NIPPV, CPAP and oxygen therapy and apnea frequency in those ELBW babies. So we have evidence, 2024-25 research says, so it is helpful in those babies on the respiratory support one, and it reduces 7-fold stress reduction, stress biomarker in those babies, and it produces autonomic stability, and KMC uptake reached up to 82%, and in facilities where structured training program is available. That is an important point to note down. Another Indian study where KMC is given for those babies on non-invasive respiratory support, that is CPAP. So here in those babies less than 2 kgs and 26 to 28, a point to be noted here, the mean duration of the total hours of respiratory support is less in those babies given KMC as compared to no KMC on respiratory support. So this is our own feasibility study, which is done maybe 5 to 6 years back in our own study, in our own institution, in low birth weight babies, 20 babies on CPAP and invasive ventilation as well. What is shown here is that the heart rate and FiO2 is slightly higher but clinically insignificant. Saturation, respiratory rate, temperature, and are stable in those babies on KMC. And mothers say that, you know, KMC is acceptable and comforting to them. So, is there a doubt now? So we have to make KMC the default. That is important. So what is needed for that? So what extra things is needed for that? So we need a space and we need system change for that to accept it. So what do we need for that? So yes, we need to have a dedicated space for KMC and the things needed for a continuation of KMC and which is suitable for the mothers and the baby. This is what we do using the KMC kit we give to all low birth weight babies. That include the binders, the cap, socks and wraps which is needed for continued KMC care for those babies. Now I'm discussing about what I discussed was in non-invasive ventilation. Are there any studies if the babies are on invasive ventilation? So yes, even in those babies also it is feasible, and in those babies it is feasible and it is safe in those babies as well. There are many studies says that even in those babies on ventilated, it is safe and feasible and it is effective. Now, KMC, this is what I was talking about. Now, what is the next concept? How do we make it feasible? So mother, this is our own NICU or MNICU. This is what we started 2 years ago. Mothers in NICU or MNICU. What is this? This is nothing but the facility, a place, a safe environment for the mother and the babies to be together. The both are cared together in the same place by the neonatologist and by the obstetricians. And that place should have a facility for, the oxygen, central oxygen supply, the suction machines, radiant warmers and CPAP machines and etc., which is very much needed for the preterm babies. And this is our own NICU, MNICU unit. So the mother NICU, MNICU model is what we need to implement. So what do we need for that? This is very important. So we need to have a dedicated space. We need not have to mix that with the high dependency or KMC ward. We need to have a dedicated space for that, and we need to have along with the mother's baby bed, we need to have mother beds as well, and the reclining chairs for the mother, and the mother should be comfortable to give 24/7 KMC to their babies. And also, because the care is given both together for both mother and the baby, we need to have definitely a protocol in place for infection control policies, because the obstetricians will come there and the parents will come, caretakers will come. So we need to have a conducive environment to take care of that. And we need to have a structured monitoring protocols for airway safety of the baby, which is very, very important. And the continuity of medical care should be given to both of them. It should not get compromised. So also there are many evidences to say that skin to skin during transport and early stabilization also is useful. And now, so this is our own NICU. What is important? So why it is, we are really scared to do that in those babies on ventilation or on respiratory support is the monitoring, which is very, very important. The monitoring of the baby on the respiratory support is very, very essential. Continuous monitoring of the heart rate, respiration, saturation, and we need to be very careful about the alarm limits. And if the baby is on ventilator, we need to watch on the PIP, PEEP, is there any leak, is there any asynchrony, we need to see that. Okay, and we need to continuously monitor the temperature in these babies, very essential. And this is a very useful, mnemonic, I can say, TABCDEFG. This is a framework which we need to use for monitoring of these babies on KMC. Okay, now another study we have done. So, what are the barriers? Are there any barriers to give? I said that, there is dose dependent relation between the number of the hours the KMC is given and the response in a baby. Yes. And are there any barriers to do that? Yes, certainly. There are barriers. It is our own study, and, barriers for the prolonged duration of KMC. That is, so what they felt was the CPAP and central lines were found to be the major barriers for providing prolonged KMC. This was done, many years back. So, of course, now it is not no more a barrier for us. So we have a protocol set in place for giving, the KMC for those babies on respiratory support. We have a protocol. We have a definite inclusion criteria, and also we have definite criteria for not to include the babies on, KMC or prolonged KMC or early initiation of KMC, or when should we delay giving KMC. We have a certain criteria. So it is very important when to interrupt a KMC session in those babies on ventilator support. Also, we have it in place. So definite protocol is very important. And when you are initiating KMC in those babies on non-invasive ventilation or invasive ventilation. So practical technique is very important. So what is the answer? So we need to be very careful. So doctors, we believe that it is very important. Is that enough? No, it is not enough. Our residents and our nurses should be convinced, and the parents should be convinced to accept this. So, staff training is an answer, and everyone's role and responsibility should be clearly defined to do that. Everyone should be in line in doing the same thing, and we need to have a standard operating procedure for doing this. This is very, very essential. And monitoring, as I said, is very, very essential. And what is the answer for this? A simulation-based training of the nurses. Okay, so just telling that it is important, it is not essential. Simulation-based training is very, very essential. So continuous, learning, teaching is very essential from the doctors to the nurses and to the junior nurses. So that is how it goes. We have done a last 2 to 3 slides. We have done a QI project in the last 2 years back. So where we wanted to initiate IKMC. Okay, so immediate KMC in in postnatal ward in those babies who are preterm and as well in the NICU. So we wanted to improve in NICU. We never used to give those babies in NICU IKMC. We never used to give. We used to give KMC, not IKMC. So we wanted to improve that from 0% to 50% over a period of 3 months. So it happened. So through series of PDSS cycles, through series of training and involving the parents, the nurses, and the junior doctors, and to we identify the barriers, and this is what we could initiate. And in IKMC was initiated as compared to those not initiated. The time of initiation was very early. It is 1.5 as against 10 hours. Okay, and duration of KMC was 5 hours against 2 hours, and the duration of KMC per day is also very important, so which is statistically significant. And we have shown that IKMC even in NICU it reached, we were able to reach our target. So then, are there any controversies and research gaps? Yes, still there are research gaps. What are they? Optimal timing and how long, how minimum is a dose, daily dose I need to give, and how do I do that for extreme low birth weight babies and those babies less than 28 is still we do not know. And also how if the baby is on high frequency ventilation, how do we do that? We still do not know. And is there any can we integrate that with available monitoring and automated apnea detection and tele-KMC follow-up? All this still there is a research gap that we need to do that. Key messages. The key messages is that KMC is now a care evidence-based therapy. It is not an optional add-on is what is the first point I want to say. Combining KMC in respiratory support is feasible and appears to reduce the duration of ventilation and support and apnea even in ELBW babies and VLBW babies with appropriate protocols, monitoring and training. Every stable baby on NIV and respiratory support, we should be able to offer KMC. And this is my last slide. And thank you very much for the patient hearing. Thank you very much.
Any questions? Thank you, madam. Thank you very much for sharing the insight in the next level of the KMC. Thank you, madam.
Thank you.
Thank you, ma'am. Now I would like to request Kishan sir to give a moment of appreciation to Dr. Chandrakala ma'am. Thank you. Thank you, sir. Thank you, ma'am. Next, we are having panel discussion, Art of Postnatal Newborn Care, a guide for the pediatrician. Today, we have panelists Dr. Mahendra Kumar Gupta, Dr. Vinit Saxena, sir, Dr. Sriram Banu, Dr. Manas Mishra. To moderate this session, we have Dr. Ashutosh Kumar, sir. Yes, sir. Yes. Sir, we already told, sir. Sir, thanks, sir. Small announcement. There is an inauguration today in the evening around 6:30. So it is at V Convention Hall A, Level B. So it is followed by dinner. Thank you so much. So something not in our hands.
कुछ कोई फोटो लेगा अपनी है? अच्छा, थैंक यू। ग्रुप में डाल देना। फोटो नहीं मिलती है यार, जब बोलती है तब आप भूल जाते हो। वाइफ को दिखाना होता है ना।
see the red reflex, binocular red reflex should also be done. So as I said, absence of red reflex, these are the conditions like cataract, all these things will be seen. Next, coming to the ROP screening. So it has many legal implications. So we should be very careful regarding ROP documentation and counseling the parents. So RBSK guidelines, NNF guidelines is one thing, and second thing is AAP guidelines. So we'll follow the NNF and RBSK guidelines. If the gestation age is 34 weeks or less than 2 kgs, definitely we need to do ROP. Or if the gestation age is between 34 to 36 weeks, with associated risk factors like cardiorespiratory support, prolonged ventilation, BPD or sepsis, or if the babies receiving prolonged oxygen therapy, these babies are risk for ROP. So these babies should be screened. And coming to the next thing is AAP guidelines. AAP guideline shows the gestation age of less than 30 weeks or less than 1.5 kg. Or if the baby is from 30, above 30 weeks or 1.5 to 2 kg with associated risk factors, definitely ROP should
So
be
generally,
done.
most of the units we follow the RBSK guidelines.
Correct.
Thank you.
So
I would like to ask Dr. Mahendra Kumar Gupta about the hearing screening program that we have for our well babies
Yeah,
and the sick.
already I told we do all the screening for the babies for hearing, and there are two types of hearing screening. One is the healthy baby who is not in an ICU, and the baby who is in an ICU. So there's the high risk is in an ICU one. So auto acoustic emission test or OAE test to be done for all the babies who are not in an ICU, and that's the universal hearing screen. So we will do what we will do in OAE. This is just to screen the microphone of the sound. Means we are giving some sound from the probe and receive that sound. So it is just test the cochlea and the conduction. Just test. So it is not a complete test for the brain and wiring, but the automated auditory brainstem response or AABR screening, it is a screening test for the high risk baby where we check all the wiring from the start, from the hearing to the ear to the brain where the sound is perceived. So it is check the wiring, and it is important for high risk babies. So we do the two-step testing. First, we go for first step. We do OAE for all babies. If they are pass, then nothing is the worry. If they are fail, then repeat it. When they repeat, then we fail or pass. If it is pass, then it's okay. But all the pass should be monitored. Those who have high risk factors, then we will check for their linguistic and auditory issue in the close monitoring, and those who have no risk, then we are regularly to check routinely. And like autoacoustic emission, AABR, AABR is automated. Automated is screening test, means it gives result to analysis result to do that it is pass or not. So we don't go for any audiologist that it is okay or not. But ABR alone is, or BERA is the diagnostic test. So this is the difference between BERA and the AABR. So we will do two times. First, we will do the high risk baby AABR, pass, fail. If it is fail, then we will again we do, and if it is fail, then refer to the audiologist for the next.
So the take home is that for every high risk baby, we need to do a screening ABR rather than
screening
only
ABR. ABR.
Very correct. So moving on to the next this thing, I would like to give a clinical scenario to Dr. Shriram. So we had a term baby who was born, was discharged on day 2 with a serum bilirubin or TCB of 13. He's again admitted back to you on day 4 and 5 with serum TCB of 18.6. So what is this screening strategy that we follow in our, because this is also a huge medical legal concern that we have these days, and what should be the discharge planning, the management strategies for all these baby with neonate, because the jaundice is such a common entity that we encounter every day.
for hyperbilirubinemia. So we'll do the universal screening for all the babies, irrespective of risk factors. We need to screen all the babies according to the recommendation AEP and NICE guidelines. So either we can do transcutaneous bilirubin or TCB at 24 to 48 hours or before the discharge or at the discharge. And we need to assess the risk factors. What are the risk factors for neurotoxicity? So if the baby's gestation age is less than 38 weeks or albumin is less than 3 grams, having sepsis, so or ABO incompatibility, alloimmunization, all these risk factors you need to consider. So first we'll focus on the screening follow-up. So when to do the bilirubin, when to ask the babies to come for the follow-up. First thing is we need to measure bilirubin, either TCB or TSP within 24 to 48 hours of life or before the discharge. The second thing is if the bilirubin TCB is coming into the phototherapy range, we need to check with the bilirubin TSP, and we need to, if it is comes under phototherapy range, we need to start the phototherapy. Or if the bilirubin TCB with the machine, if the value is more than 15 or within the 3 milligrams within the threshold value, then you need to confirm with the bilirubin test, and if it comes under the threshold value, then definitely you need to start the phototherapy. And certain risk factors will be there, like when to call for them for the jaundice checkup. The first thing is pre-discharge bilirubin, depending on the pre-discharge bilirubin and other risk factors also. For example, if the baby is having cephalometoma or premature baby, low birth weight baby, or having polycythemia, IDM babies, these babies are having risk. So these babies definitely we need to call for the follow-up. And pre-discharge bilirubin, if the bilirubin is less than 2 milligrams, obviously 2 milligrams below the phototherapy threshold, you should not discharge the baby. You need to check the TSP within 4 hours and you need to start the phototherapy, or you can counsel them. The second thing is if it comes between 2 to 3.5 milligrams, you can check between 8 to 24 hours. Tell them to follow up at 8 hours. 3.5 to 5.5, you can check within 1 or 2 days, and later will be around 3 to 4 days.
Okay. So you rightly said that every newborn, before he is being discharged home, we should have a universal TCB screening if the facility is available. TSB screening or testing should be done if the values are beyond 15 or within 3 milligram per deciliter. You nicely brought out various cutoffs when we should be follow up. So this is the graph that we are generally, most of the units are following for the intervention or using it to phototherapy. Dr. Gupta, I would like to ask you, we had a newborn. He was discharged home on day 3, got readmitted in the state of shock. Echocardiography was done at the new unit, and they found that the child is suffering from, is having coarctation of aorta. Now, there is always that this was missed when the child was being discharged home. So, what is the unit practice that you all have to detect all these congenital heart diseases? Can we detect them by a non-invasive testing?
Yes, there is a pulse oximetry test we have to do as a screening test, and the pulse oximetry screening test is used for detect the critical congenital heart disease, the heart disease which are drug dependent and require surgery within 1 year of the life. So that is the critical congenital heart disease. It not pick up all the heart diseases like PSD, ASD or PDA, it cannot. And what we do pulse oximetry test in the baby. There are 4 requirements are there. One, baby should be sleep, it should not be active, and the baby should be more than 24-hour old, and it should not be on oxygen. If you are doing pulse oxy on oxygen, then it's no value. Then the pulse oximeter should be other set technology one. It should not be a normal pulse oximeter. And then we do the pre and post ductal saturation by this, and this saturation we plot on the graph and get there are 3 types of saturation we get: more than 95% and less than 3% difference. 2 things should be at least, and they are pass or means the negative screen, so they are left to the baby should left. Then another babies who are less than 90% of saturation, they are in the red box and they should directly go for echocardiography. And another is a group is yellow, where 90 to 94% saturation, or there is the more than 3% difference. And this is the graph where we put all that. It is green means pass, baby should go for. But yellow one, there should be screen again. In the red, you should go for the echocardiography. If yellow one again shows in the either red or either in green, so put according to that.
Thank you, Dr. Mahendra. Coming to the next entity, hypothyroidism is one of the common etiology for mental retardation, and we all understand it's a treatable entity. So, what should be the screening strategy for it, sir?
Sir, like ROP, auditory screening, TSH thyroid testing is very much important, and if somebody misses it, he can land into serious medical legal problem. And advocacy from every forum is there. Last week only, every IAP member received a mass email how to test for IAP. So testing protocol is very important for programmatic and implementation purpose. At birth, one can send cord blood. It is very easy to send, and every hospital or maternity home should make a practice. But the ideal is postnatal, after delivery, 48 to 72 hours, because at that time surge comes to the normal. Dried blood spot or venous sample, technically venous sample is better, but dried blood spot is a ready option. And in spacious condition like baby is premature, low birth weight, sepsis, or any way sick, one can send earlier also. But this sample should be repeated ideally after 10 days of first sample or after 2 weeks in sick baby. Cutoff level, TSH 20 or less, it is okay, normal screen. If it is more than 20, serum positive, it is by, if it is by direct spot, then repeat confirmatory test for venous sample, TSH as well as T4 or total T4 both. And after second report, you can go for treatment. I think in next slide, a beautiful table is there. If TSH is more than 40, then you have to repeat a sample for confirmatory diagnosis, and you have to start a treatment immediately. For sick baby, if you have taken sample 24 to hours or between 24 to 48 hours, a lower level, I think more than 35 is enough to start treatment or re-screening. And this is how you proceed with a different TSH level. If TSH less than 20, baby is okay. If more than 20, then you repeat TSH. If it is more than 40, then go for confirmatory test. If it is between 20 to 40, so I think everybody
Absolutely. So the message is that we should be screening every child for the state of hypothyroidism. I would like to ask Dr. Manas, what is your take for other metabolic disorder screening in our setup?
So in the Indian setup, we do not have any national mandate which says that we should have all the IEM screened. But we have some state level and some national level programs. Like we have the RBSK, the Rashtriya Bal Suraksha Karyakram, Swasthya Karyakram, in which it says that the 4 Ds, the defects, the deficiencies, the diseases, and the developmental delays needs to be screened. But it's more of a clinical screening and metabolic screening only in some available states. Like we know the Goa state and the Kerala state, where Manohar Parrikar had started, that universal newborn screening was being taken up for all the babies. ICMR recommendations are mostly for the congenital hypothyroidism and for the congenital adrenal hyperplasia. If we see the Indian Society of Pediatric and Adolescent Endocrinology, or the IAP, they also say that mandatorily, as are told, we should be doing for the congenital hypothyroidism and for the CH. And for other tests, like we have something like the G6PD deficiency, or we have galactosemia, phenylketonuria, or biotinidase deficiency. These are the primarily 6 disorders that we do the testing for. So we should wait for the first 48 to 72 hours so that the baby has had some feed, so that the metabolites that we want to get on the TMS or on the GCMS for any amino acid metabolism defect or any fatty acid oxidation defect are present in sufficient quantities that they can be detected by the dried blood spot.
Yeah.
So these are the major tests that are done on the DBS. So in the UK, what we used to follow, UK has a national mandate that all babies need to be screened. So there are 2 things. They call it as a Guthrie test, which initially started with the PKU, the phenylketonuria, which is much more prevalent over there. The day 0 Guthrie is mandatory over there, where you have to take red blood spot on day 0. And day 5 is also mandatory. So the first results that they want to see within day 0 to day 5 is for the most common IEMs or hypothyroidism which need immediate treatment. And the day 5 is something which takes about 1 to 2 weeks, which is kind of a confirmatory for them, where they start treatment and they start referring to the metabolic and the genetic people to go ahead with it. So at Indian level, because of our population and other things, we cannot have full screening for everyone like that. But the ones which we are following, like for the hypothyroidism, and maybe in some setups where the states can afford, like Goa, for having these at least the 6 common IEMs, we should be following that.
Okay. So currently
from industry, from Lal Path, a long list is there. So in private practice and individualized practice, one can tailor and figure out this 6 condition on priority.
So we have a lot of myths and practices which is being followed across the length and width of India. The few common ones we have all discussed and put on the slide, where what should be the bathing practices. At few places, the bathing is done immediately after birth. The cord practices are very widely practiced in various communities. There are concerns about the sleeping position for a newborn. I would like to request all the panelists to address one of them individually, that what you should be asking our pediatrician to recommend to the patients or the children in their practice.
Sir, for bathing, not for pediatrician, for nursing home, maternity home, support staff also. Because with a showroom condition, baby, neat and clean and with a diaper, ayas and dais get a good tip. So this practice, immediate bathing should be strongly discouraged, and bath should be delayed at least 24 hours. WHO group suggested certain specific recommendation to maintain a good temperature. First thing is ambient temperature should be monitored precisely. Immediately dry and remove the wet linen. Appropriately cover baby with 1 or 2 pieces of cloth. And best thing is keep baby and mother together to maintain warmth.
So basically, the bathing should be delayed for a while. In fact, we at times recommend that till the time cord falls, you can wait for bathing. What about the use of emollient, Dr. Shriram?
So regarding the use of emollients, so latest guidelines, studies have shown that it's not recommended. If the baby is term baby, full term baby, healthy, so routine application of emollients, oils or any creams, it's not recommended. So some studies have shown that VLBW babies less than 1.5 kg, topical application of sunflower oil will improve the skin barrier function and prevents the invasive infections. So as of for the healthy term baby, these emollients were not recommended. And some studies are still going on with the families of atopy, dermatitis, eczema. Still studies are going on whether to apply or not. As of now, it's not recommended.
So what about the routine use of chlorhexidine over the cord, Dr. Mahendra?
Yeah, the cord should be left dry and keep it clean. And nothing required if the baby is normal. And if the requirement of chlorhexidine is only in the condition where the practice of putting some abnormal things like dirt, the cow dung, or some other traditional condition going on, they are putting in the society of that. So in that case, we can apply chlorhexidine 4% for first 7 days on the cord. That is enough to avoid the sepsis or infection.
So Dr. Manas, what about the sleeping position that you would be recommending and the body massage?
Sir, so sleeping in neonates is, at least it's another subspecialty. I'll say that neonatal sleep, a lot of work has been going on all over the world. So the sleep positions, it started in the 1990s, where the Western countries, mostly the UK and US, have done a lot of studies. They have the differences, like they don't keep the baby and mother in the same bed. They don't prefer bed sharing. The baby is in a different cot, and the position of the baby. So the head should be in the midline, and what should be the position, whether the baby should be prone or supine. So the pooled data that they have taken from multiple RCTs and some cross-section studies where they have studied about the SIDS and the SUDI, which is a sudden unexpected infant death, and they have found out that the odds ratio in the meta-analysis was 2.93 for SIDS in babies who were prone. And babies who are at high risk, like there had been some conditions, like some mothers who had been judged that they are little high risk in the infant care, the odds ratio was as high as 9. So it is definitely, the campaign was started in the US that is called Back to Sleep in 1994, and that has been endorsed by the WHO and multiple bodies in the UK, US, and in India, that the baby should always be on the sleeping on the back if you are not directly observing the baby, or if you are sleeping. In the daytime, when the baby is directly under your observation, for some time you can give tummy time to the baby, which is good for the baby, but that should be under direct observation, and you should not be sleeping the baby on any other position other than the back or the supine position. The whole body massage, so this is not the traditional thigh massage that we expect when the parents ask us. So what we mean by this whole body massage is it's a gentle tactile stimulation that the mother is expected to do by
discharged, how do we follow them for their growth and development for the initial 6 weeks of age? So I would request Dr. Vinay to handle this issue.
For government facilities, NHM beautifully designed it. It is clubbed with healthcare visits to home-based newborn care as well as home-based young child care visits. So purpose of this visit and examination to ensure optimal growth. So first within 48 to 72 hours, then after 2 weeks, then club it with your vaccination schedules. That is 6, 10, 14 of DPT, then 6 months, then 9 months to 12 months. And for high risk, it depends on situation and what facilities you have. So with this visit, first important thing is to check for weight gain. So everybody knows that every newborn loses some weight and regain to birth weight at 10 to 14 days. Weight should be properly plotted. Single reading is not important. And deviation, at least 2 centile deviation from growth curve is important and needs evaluation. So if despite good latch, baby is not gaining weight, then it is a point of concern when we should go for evaluation, optimize that milk transfer is okay or not, and do some measures to enhance supply. And in that, and if everything is done and still not gaining weight, then targeted supplementation.
Thank you, sir. KMC, we have heard a lot about KMC in the previous session that we had. I would like to ask Dr. Mahendra. He is very fond of KMC and has been a very aggressive follower in his unit. So what is your take on a KMC which should be started at hospital setting, and how the mother should be motivated to continue at home?
As previous lecture about KMC, kangaroo care, the WHO definition is also there: early continuous sustained skin to skin contact and exclusive breastfeeding, then the early discharge and follow up. So the kangaroo care should be continue even at home. So there are 2 barriers are there to start at home. Is one is the myth and another is the fear. The parents are in the fear that baby can aspirate or something else. So there, and second one is the myth. That is what is the benefit of that. So we will tell about the benefits of the kangaroo care and we start kangaroo care within our NICU with the parents, not only mother, with the other parents also. So they will confident enough that they will continue there at home. So that we will start, and after that we make the follow-up at home also. So what we will give, we call them timely with video calls and contact number of self-help group. We made self-help group so that they help group, they are the family who had done kangaroo care at their home, and they meet with them and they will sort out their problems whenever they required, and they provide the guidance for the new parents. So by the self-help group, and we will provide a performer so that they can put all the time that how many times they have given kangaroo care, when they will show to the local, and whenever that they need something to, and then we will call them for follow-up as the time passes.
Thank you. So what is your take for the breastfeeding continuity? We have an institutional delivery which has increased, but still we are lagging behind in the initiation and the follow-up till 6 weeks. So what is your take for this?
So exactly the in breastfeed WPW World Breastfeeding Week 2024, the theme was bridging the gap. The institutional deliveries are increasing, but the breastfeeding rate is quite less than 50. It is matter of concern, and that's why so we have to increase our rate of breastfeeding by three things: the time, team, and policy. The policy should be made and strictly follow or strictly adhere to the policy by the hospital, and there is a team, and not only the alone doctor, the nursing staff, as well as all the other staff. Everyone should know the policy and why, how they have improved the. So we
So
start
basically it should be a team
breastfeeding.
effort where everyone should be pitching in, starting from the hospital setup to the family.
Yes.
So the last thing is a single slide where I would like to ask Dr. Shriram. The parent counseling is one thing which we often do it in a very rushed manner. What should be the points following it, and what is your take on this? This is the last slide that
Yes,
we
sir.
have.
So regarding the counseling and communication, so these are the points we need to focus for a counseling for a healthy baby, healthy term baby. So first thing is we need to congratulate them. Happy you are blessed with a baby boy or girl, first in a pleasant manner. The second thing you need to explain about the normal newborn behaviors. So hunger cues, feeding issues, any feeding is a proper positioning. We need to tell how to change the diaper and the sleep wake cycle, all these things we need to explain thoroughly. Next, feeding guidance we need to give. At least the baby will feed 8 to 12 times per day. Proper burping should be done, and we need to explain a focus on the danger signs. What are the danger signs? If the baby is too hot to touch or too cold to touch, or if the baby is looking very pale, yellow, all the danger signs we need to explain thoroughly, and focusing on immunization and screening. So immunization, all the birth vaccines like BCG, OPV, hepatitis B should be covered or not. We need to give the vaccination card, and the screening, all the eye screening, hearing screening, and metabolic screening should be done and should be properly documented. And discharge counseling, we need to tell when to come for the follow-up. If there is risk factors like hyperbil or hypoglycemia, so we need to call them, and especially SMS alarms will be much beneficial in that case.
So thank you. That this brings us to the end of our panel discussion, and I would like to thank all the panelists and all the audience for listening to the panel patiently. Thank you, everyone.
Now I would like to request Dr. Ashutosh sir to give memento to the panelists, please. Now I would like to request Vineet Saxena sir to give memento to Astor sir. Next session, it is by Dr. Amnit Kaur ma'am. If it is not written, it didn't happen. Rethinking NSU documentation. To chair the session, we have Dr. Jalil Ahmad sir from Coimbatore. I would like to request Dr. Jalil Ahmad sir to introduce Dr. Amnit Kaur. Thank you. Hello, ma'am. Hi, ma'am. How are you, ma'am? Hello, ma'am.
I'm good. How are you?
Good, ma'am.
You're organizer?
Yes, ma'am. Kind of.
Child test தான் DNB பண்ணலாம். ఇప్పుడు ఎక్కడ ఉన్నారు?
I request all the three speakers to confine to 20 minutes each. Without any much ado, we'll proceed to the first topic. Over to you, madam. CV. Professor Dr. Avneet Kaur is a senior consultant and head of the Department of Neonatology, Apollo Cradle, Motinagar, New Delhi. Was awarded gold medalist in Defense Neonatology for the year 2007 and 10. Indian JNA Award for Neonatology. Part of various PG and fellowship training programs. Was a joint secretary of NNF Delhi. He has got credit 55 publications in various journals. Over to you, madam.
So good evening, everyone. First of all, I thank the organizer to give me this opportunity to be here on this platform. I think we all are tired of all the sessions since morning, but I think what I'm going to present is all the crux what you have done all throughout your NICU stay, taking care of the babies. But if you haven't done this, you haven't done anything. So I think that that one line holds all the learning what you have done in this conference. But if you haven't implemented in form of documentation, you haven't done any good to the baby. So the word said is that if it's not written, it did not happen. Emphasizing that how crucial the documentation of the patient care is important. So I'll take you through a few slides, which will be like 20 minutes, that first of all, why documentation is important, both legally and ethically. Secondly, what are the types of documentation errors which we all see day in and out. And I'll take you through few real-time litigations which have been put on internet and given by the court of law, and what were the implications of those legalities, and how we can improvise our practices and some specific strategies so that our documentations can be better and henceforth the outcome of the babies. So what is the objective of our documentation? So documentation is important not only for the patient's safety, it is also for our safety, for our legal protection, for our professional integrity, and for a better working of our clinical scenarios as well. So we all know that we use different type of medical records. Some of our units use like handwritten records, some use electronic healthcare system, and some use a combination of both electronic and the handwritten records. So we must know what all should be documented. So it's not just writing general conditions stable, my child looks sick, my child look alert, these are the vitals, and okay, continue same treatment and your signature. That is not what is documentation. Documentation involves what, whom, what was the procedure done, what time, what dosage, what indication, what response, how are you going to monitor the side effects, how many attempts were made, and who did it, and did we take the consent or not, and who made this decision? Was it discussed with the parents or not? What all screenings are planned for the baby? Were the screenings done or not? And were the parents informed of about the screening or not? And after informing them, what was a discussion made with the parents? And then eventually also talking to them while giving them the discharge summary and the planning post discharge. So it's not simple. It involves lot of intricacies. We see day in and out some of these documentation errors happening. We commonly feel that it is just the incomplete entries, or it is just the incomplete communications, or it is the indirect consents taken. But what I'm going to talk to you today is what we are not supposed to do, but we need to also understand what legalities we can face with all these things. So first of all, whenever you are called to a court, so the judge will ask you first an important thing. What is the standard of care? So your question is that did you comply by what has been advised as per the guidelines? So your answer will be, yes, I followed the NNF guideline. I followed the AAP guideline. So first of all, you need to prove that whatever you did was as per the guideline. The second thing is that you need to prove that whatever guidelines said, did you do it or not do it? So that is, even if you did it, but you did not document it, it is equivalent to negligence. So you did it, but you didn't document it is equivalent to negligence. And what implication this negligence carries to is that you can have the financial problems because of this negligence, the legalities which is financial. You can have legalities which is pertaining to your hospital authorities questioning you, your National Neonatology Forum or your boards questioning you, and your ethical questioning you, your ethics questioning you. So your documentation is a legal defense and is also an evidence against you. So it can protect you, but it can kill you also. So it should not be ignored. When we learn about ethics in our clinical practice, we learn about few terms. We talk about beneficence, we talk about non-malfeasance, and we talk of autonomy. So the same holds true for our documentation. If we write clear documentation, we convey that we have given this care to the baby. If we write documentation, we can prove we did no harm to our baby. If we write documentation, we give the clear autonomy to the parents that we did right for your baby. So whatever we learn and the ethics of our medical science, we do this only by documentation. So I'm taking to a real case. It was presented in one of the journals, and it was a study which just got published in 2025 from a Brazilian NICU, where 120 babies data got published. And it showed that there were 50% of the patient who experienced one or other adverse event, and 49% of these 49 per 1,000 patient days were identified, and 40% had some or other adverse drug reactions. But only 8% of these adverse reactions were in the standard reporting format. So, do you think that we all don't face that whatever we are working in an ICUs will definitely cause some or other adverse effect? We can face NECs, we can face ROPs, we can face IVH, we can face the drug reaction. But the question here is not that. How we were ready to face or plan for these drug reaction is what we want to protect ourselves by doing the right documentation. So we all know that drug reactions are very common, and this study showed the same. But adverse reaction is not a negligence. Failing to predict, failing to monitor or document is the negligence. So we commonly see cardiac drugs like furosemide, which can lead to electrolyte imbalance, dopamine can lead to arrhythmias, antibiotics can lead to nephrotoxicity or renal side effects. So those are the ones which need to be reflected on documentation. Just taking you through a case, it's a real case. 29-weeker, had PDA, was decided to be started on like furosemide for protection of BPD. So furosemide was started for this baby, and it was documented that furosemide is being given for this baby for the PDA as per the protocol. But the documentation never wrote that why it is being given and how are we going to monitor the side effects. On day 28th, the baby started having seizures. And when the child started having seizures, and the parents were clueless why this child is having seizures, the child was investigated, and child was detected to have hypocalcemia. And that's when the parents took the doctor to the court and asked the doctor that when this drug is having this side effect, why my child was not monitored for these side effects in a preemptive manner. So how we could have protected ourselves by documenting it, that we could have just completely written that these are my baseline labs, this is my monitoring plan. I could have informed the family that this is the drug I'm giving, can have this side effects, but I'll keep monitoring this child for these side effects, which could have protected the family, and we could have made up the family preemptively and protected the doctor. So it creates a defensiveness for the doctors. Now, we also talk about the documentation in a timely manner. So documentation is typically completing your notes, but after when you're about to finish your shift. So half of the things you'll remember, half of the things would have just fallen out of your brain because you're handling 30, 40 patients. So the most important thing is documenting accurate, complete, and in a real-time manner. Also, sometimes you use electronic records or you use manual records. We copy paste things. We write continue same treatment. So I'll take you through another scenario. This baby was planned for a ROP screening on day 21 of life, preterm 27-weeker. Baby underwent ROP screening on 21 day of life, and the retina specialist said that this baby warrants another ROP screening after 1 week. After 1 week, when the baby was so-called considered like that has to be done, but that copy-pasted was done, ROP screening done, advice for after another 1 week, because nobody noticed that it was done after 1 week and the doctor has recommended after another week. So that copy-pasting was going on after 1 week and after 1 week. And then another after 1 week, when actually ROP screening was done, it was aggressive AP-ROP. So the copy pasting of documentations is something which we need to seriously look into. We need to have some timestamps, and we should not be having the copy pasting options going on. So I'll be taking through some 5 real-time litigations which have happened and which are available on internet pertaining to our neonatology cases in best of the hospitals. So this is one of the very famous hospital in Delhi. So in this case, basically the baby was advised to undergo ROP screening, and but they forgot to. Baby was discharged on day 21 of life, and the baby was planned to have a ROP screening on day 28. But however, that ROP screening was not written in the discharge summary. It was not informed to the parents to undergo the ROP screening, and the baby lands up at 4 months of age with retinal detachment. So how important it is to write about the date, whom to be seen for the ROP screening. So it's very important. Please follow guidelines, but at the same time, if you have followed guidelines, if you have not documented, nobody can help us. Another case, one of our very good colleagues, he has been debarred from a national neonatology working per se because of this case. So the parents found the baby to be having cerebral palsy, and the baby had undergone hypoxic ischemic encephalopathy at the time of birth. And the baby was given a discharge summary where it was written that resuscitation done, baby successfully resuscitated, baby is discharged, neurologically stable. But later date, the baby was having cerebral palsy. So when the court asked for all the resuscitation documents, There were some documents which are missing. There was some forging of documents. And because of all these legalities, our doctor is nowhere allowed to perform neonatology practice. So we had another case because of which the baby lost the life, and there was no resuscitation data records. So because of lack of those resuscitation data records, again the case went to the court. So there was this case where the baby was detected to have sepsis, and the order to escalate the antibiotics were given. However, that was not actually performed. So because of just the oral verbal orders to escalate the antibiotics and no documentation of that, the baby lost the life, and the doctor could not protect themselves even by doing good, that the escalation of antibiotics were done. So I think these legalities are like, can happen at any level, and the only way to protect ourselves is to do documentation. And I think the last but not the least of these documentation is the consent forms. From entry to any procedure to anything you do, if you don't have the consent of the parents, you can always be sued. So the power of documentation should be such that even if you are not available in the court of law, your paper should speak for you. So the lawyer will ask you, the opposing counsel will ask you for your documents. The family will seek the answers from your document. The audits will also seek from your documents, and your practices will also speak for your documents. So commonly what challenges we face in our documentation is that NICU working is so evolving, the patient dynamics are changing so fast that sometimes we are not able to document. Our work pressures, our number of patients are so much, and we are always short of time. So these are the common things which we are told. So I think the best ways for improving our practices is that first, we should always get that to the workflow of your NICUs. So you should plan it in such a way that every place your comparison from the previous baseline, how the baby is doing, what are the indication, what is your monitoring plan, what are the red flag signs, your over systems, and the communication plan. Everything should be jotted down in the workflow only. So for the medication also, it is very important. What is the indication? What is the dosing? What is the baseline labs? What is the monitoring plan? What are the side effects? How you're going to monitor the side effects? How the family has been counseled? So all this should be there. Your over system in your NICUs has to be streamlined, because if your over system is streamlined, that is where the lapses happen. So in our NICU, we have a printed over system. The first shift completes the duty, they hand over a written documented thing to the next shift, and that's how, and it is compared to the previous and the nursing records also, that this done, this done, this done. So there are check boxes in the over system also. So also to get the things into our system, it is important to conduct audits. So until unless we conduct our audits, we'll never be able to improve our handing over, our monitoring of our adverse effects. So all these needs audits. So audit, develop standards, train your staff, monitor, and then celebrate the success. And last but not the least, now we are moving towards the era of electronic health records. So in my unit, from 2019 onwards, we have been using an electronic health record system called ENICU. So in our ENICU, we have all my monitor, my warmer, my infusion pump, my ventilator is all connected to an IoT device, and that IoT device is connected to an iPad where everyone can see the data of my baby. There is a camera on my baby where, like, sometimes if I'm not in my NICU, if I'm in like OP area or anywhere else, I can grossly see what is happening to my baby. Not only that, when we put the dosage of the antibiotics, it puts no, this is going for erroneous reading. So it auto calculates my dosaging. and it puts the remark, no, this dosing is not right as per this. We have also put our Aspergen guidelines into the system, where every day nutritional values are calculated and it compares it to the Aspergen guidelines. So we can keep checks on whatever we are doing, whether it is our antibiotic dosage, and it gives us a reminder, no, this baby needs to be monitored for hearing before discharge because we gave antibiotics for more than 5 days. So that
Another
protects
3
us.
minutes, madam.
So that protects, I'm already on the last 2 slides. So it protects us legally also, ethically also, and improves our clinical care as well. So the thing which I explained you, like my monitor is giving minute to minute data. I have clear legible drug records. We do auto calculation of the drugs. We have reminder for the due medications for the nursing staff. We have reminders for the ROP, hearing screening and ultrasound screening. We have timestamps. If the nursing staff has to give antibiotic, they get a timestamp on the screen itself that this antibiotic is due. They check mark it, and that's it's done. So copy pasting things are, you can protect yourself. So I think takeaway from my talk is documentation is the documentation of your care. Vague documentation, writing vague things can never protect you from court of law. Writing your clinical reasoning of what you did, not just what you did, but also what you wanted to do is important. So it's important to document real time and not from your memory, and adopt the electronic health record system with detailed documentation and timestamp to protect yourself from all these implications which are ethical and legal. Thank you so much.
Thank you, madam, for the excellent messages. So he is emphasized on the documentation so that we can avoid legal proceedings. Very important in the NICU part of it. Thank you, madam. Now we'll move on to the next topic by Dr. Sai Sunil Kishore. He skipped.
So next topic is by Dr. Chandrakumar sir. NICU nostalgias, therapies that need a graceful exit. This chair also will be this topic is also will be chaired by Dr. Jalil Ahmad sir. Thank you, sir.
Dr. N. Chandrakumar is a very eminent neonatologist in Tamil Nadu. He is a close friend of mine. He is a senior consultant in health pediatrics and neonatology, MGM Healthcare Chennai, Apollo First Med Hospital Chennai, KKC 88 Chennai. He is affiliated to these 3 institutions, and he has got 50 publications in national as well as in international journal. Professor KM Gold Medal in surgery, and Dr. Balakrishnan Gold Medal in MD Pediatric JIPMER, and NNF Gold Medal for Best Research Paper National Neonatology Forum. He is an Young Investigator Award, Pediatric Academic Society, Washington, D.C. Over to Dr. Chandrakumar for his important topic.
Sir, before the talk, I would like to request you to give the memento to Dr. Amrit Kaur ma'am. Thank you, sir.
Madam, may I ask a question? Thank you. That was a nice talk, and it is very relevant. My name is Pushan Gudet, neonatal consultant in Ankura, Hyderabad. I just wanted to know your experience of electronic health records, sir, in NICU. ENICU is, of course, it's built for a purpose and for a reason. Were there any occasions where you had difficulties in terms of mistakes in the system itself? Of course, it's built for not to do any mistakes, but no system is proof from errors. What was your audit trail that you do regularly to make sure that what the system you set up actually doing its work? Of course, it is most of the times correct, but what is your audit process that to make sure that it is working?
Yeah, so
Thank
see, actually the electronic health records, sometimes we have internet issues, that's very common. But when we make entries, when we write things, sometimes there's a lot of flow of things which are going on. But when we make electronic entries, sometimes those flow things are missing because electronic has a limitation that it can take data.
So that's the commonest thing which we face when we are making electronic entries, that sometimes that flow, okay, I gave like dobutamine and like, within 20 minutes I had to shift to dopamine. That at times, those the flow of things in the electronic medical records, that is missed. Secondly, the pop-ups usually come to the system. They say, okay, done, and actually it is not done. Okay, so that is a good thing also to give pop-ups, but sometimes it is like they tick it and they miss it, giving it. So these are few lacunae which we see in electronic health
And
records.
who oversees that? It's because it's a checklist.
Yeah.
We assume that it is done,
It is
but it's
done.
not done.
Yeah.
But who oversees that?
So when we started in 2019, we started having a hard copy also. We were doing like handwritten things also, and we're doing the electronic things also. So we wanted to keep a check that where, the false things can happen. So there we used to have the hard copies, and then we realized that sisters are doing like this. So we ensure that somebody or the TL on the shift will ensure that this thing is done. So they will keep a check on that they have done it, and then that will be properly documented. So we did some audits to rectify whatever electronically they were doing it and which could be missed.
Thank you.
Thank you, madam. Thank you. Over to Dr. Chandra Kumar for the
Thank you,
NICU
sir.
nostalgia.
Good evening, everyone. So here I'm going to talk about NICU nostalgia. Basically, therapies that need a graceful exit from NICU practice. That is, those which are considered now obsolete, and slowly we should stop using those interventions. So, what does nostalgia means? A feeling of pleasure mixed with sadness when you think of happy times in the past, right? So definitely there are some therapies which definitely would have helped save babies, but slowly as new evidence emerge, these therapies become obsolete and irrelevant, and they may be considered redundant. Okay. So here we are going to discuss about some of these strategies which apply in NICU. It can be antepartum, intrapartum, or postpartum, which happens in the core NICU practices. So here I have given the list of interventions probably which we have to relook into, which needs reconsideration before administering or using in the current era of evidence-based medicine. So I might have missed some of the interventions, I missed aminophilin for apnea of prematurity. I did not include immunoglobulin for sepsis. So these are all some of the therapies which have become, in fact, obsolete. So among the list of from these list of interventions, I would kind of discuss some of the relevant ones in detail. So when it comes to antepartum interventions, we should discuss something about antenatal steroids. I mean, all of you should not be, taken aback by why antenatal steroid should be considered obsolete. It is not the antenatal steroid as such should be considered obsolete. We know that it has got a lot of benefits, but what we need to consider is the choice of antenatal steroids, whether it should be betamethasone or we have to move on to dexamethasone. So we know that there are many good reasons to recommend dexamethasone. Government of India has come up with a policy to use dexamethasone because the betamethasone which is available in India does not have the long-acting form of salt, that is betamethasone acetate. It contains only the phosphate component, so that it may not be equally it may not have the efficacy which is seen in the studies from the Western world. When dexamethasone, which was compared to betamethasone in network meta-analysis, there was no difference in the incidence of neonatal death, neurodevelopmental disability, or intraventricular hemorrhage. So these morbidities or these outcomes are not different from betamethasone. So I think dexamethasone is a safer option, and we need to move on to using dexamethasone routinely than betamethasone. So when it comes to choice of antenatal steroids, I think dexamethasone scores over betamethasone in terms of the availability of the recommended salts, and hence I think betamethasone we should consider as a obsolete agent for antenatal steroid coverage in our country. Then I would like to discuss about the antibiotic use of antibiotics for preterm labor. So especially preterm labor without rupture of membranes, which is what was studied in Oracle 2 trial, where they discussed the role of antibiotics like erythromycin as a co-amoxiclav, combination of both or none for preterm labor, especially with intact membranes in Oracle 2. And they found out that when there was no rupture of membranes and there was spontaneous onset of preterm labor, even though the antibiotic usage might have, antibiotic usage did not even reduce the incidence of prematurity, but in the long term, they found out that using antibiotic increase the risk of adverse outcomes in these infants, including neurodevelopmental impairment, cerebral palsy, etc. So that is the reason why routine antibiotics for preterm labor without PPROM or rupture of membranes is slowly going out of practice. Then the other intervention, which all of us would be surprised to see, is any woman with a complicated pregnancy, especially an IVF pregnancy, is asked to stay in the bed for a long time, and she is not even advised ambulation outside her room. So actually, there is no evidence for this, and this bed rest is going to increase the risk of venous thrombosis and may lead to maternal depression, and actually it leads to higher cost of care because mother is advised to stay in the hospital or in an accommodation nearby the hospital, which is going to turn out to be expensive for this couple. So current recommendation is not to avoid routine bed rest for these high-risk pregnancies. In fact, we should encourage some amount of physical activity for these women. Then we will move on to some of the intrapartum interventions. The first one which I would like to discuss is about the meconium aspiration syndrome. So a lot of things have evolved, changed in the management of meconium aspiration syndrome from antenatal delivery room management to post-delivery management in NICU, which we will discuss them together. Among the antenatal management, amnio infusion used to be one of the interventions which was considered widely. So when I was doing my MD, my obstetric counterpart, one girl was doing a thesis on amnio infusion. So it used to be quite popular, using amnio infusion to reduce the incidence of MAS or severity of MAS in the infants born through thick MSL. What evidence has to say about it? So 10 years back, 10, 15 years back, the Cochrane summarized that the evidence for amnio infusion is good, that it reduces the incidence of MAS, but this evidence largely comes from developing countries. But if you look at evidence from developed countries, it is not reducing the incidence of MAS. So that's the reason why it was not recommended. But subsequently, if you see, a lot of more recent studies have come, and this is a recent meta-analysis wherein it shows that up to 70% reduction in the infusion is used, and this systematic review recommends that amnio infusion could be potentially a therapy which can be adapted in future, but for now, or at least a decade back, it has become obsolete, and amnio infusion is not practiced nowadays. When it comes to delivery room management of babies born through meconium stained amniotic fluid, so previously, as soon as the head was out, oropharyngeal suctioning was done. Okay, so now this has become obsolete. following a large study which was published in 2004 by Nestor Wayne. So, and this practice has been stopped. That is routine oropharyngeal suctioning after the head is delivered. So once these babies were born, subsequently they were assessed and then they were classified as vigorous or non-vigorous. So they were considered vigorous if heart rate was more than 100, good breathing and good tone. For them, only initial steps of resuscitation was provided. So non-vigorous infants were subjected to tracheal suction. So from 2015 onwards, this routine ET suctioning for even for non-vigorous infants has been stopped. So why this recommendation was made? Because it was due to evidence again from developing region. The major contribution has come from India, from LHMC and JIPMER Pondicherry. So these trials showed that clearly there was no increased incidence of MAS if these non-vigorous infants also were not provided tracheal suctioning. That's why ILCOR and NRP came out with the recommendation that even non-vigorous infants, the priority should be positive pressure ventilation, not tracheal suctioning. Then the another important intervention in the delivery room, which we need to remember, is delayed cord clamping, or otherwise called as deferred cord clamping. We know that it has a lot of benefits both for preterm as well as term babies. Sorry for the small font. And not only short-term outcomes, but including long-term benefits. So for preterm babies, it stabilizes their circulation. There is reports that there is decreased incidence of IVH and NEC. For term babies, it increases the hemoglobin level, it increases iron store levels, and long-term also it has shown some benefits. So that's why NRP in the recent revision has come up with the recommendation that delayed cord clamping for up to 60 seconds should be practiced, and it has been revised from earlier 30 to 60 seconds. So no immediate cord clamping should be followed, but it can be done in certain conditions for maternal and fetal indications. Maternal includes when she is having hemorrhage, hemodynamic instability, or if there is abnormal placentation, and fetal indications if there is an immediate need for resuscitation. So when it comes to cord clamping, yes, the delayed cord clamping should be adapted, and immediate cord clamping has phased out gradually. Then the next important area is oxygen during resuscitation. So here there are two different direction it goes. We are convinced that we should not use oxygen for resuscitation of term infants. That is, initial oxygen usage for resuscitation of term infants has stopped. But on the other hand, the use of the right amount of oxygen for preterm infant to start resuscitation is still evolving. So why usage of oxygen for term infant was stopped? Because the studies goes back to almost 2 decades. Here also significant contributions have come from India by Ramji sir from MAMC. So where they found out that use of room air for resuscitation significantly reduced mortality in these infants. So this is a systematic review and meta-analysis of the trials on room air resuscitation, and it shows that there is at least 27% reduction in mortality when room air was used for resuscitation of these term infants who did not breathe at birth. However, the initial FiO2 which is required for preterm infants, it from 100% it came down to room air. Now again it is changing. So in a recent meta-analysis, this group, which includes professors from PGI as well, they have found out that when compared to okay. So when compared to high oxygen, when high oxygen was compared to intermediate oxygen, the high oxygen group had a lesser mortality. Similarly, high versus low oxygen group, they found out that high oxygen group had a lesser mortality. So the recently published torpedo trial also did not find that increased incidence of adverse outcomes in the babies who received 60% oxygen when resuscitation was started with. So in the right or appropriate FiO2 to start resuscitation in preterm infants still is evolving. So recent NRP recommends that from the they have revised from the previous existing recommendation, which was 21% for more than 35 weeks and 21 to 30% for less than 35 weeks. They have included one more subgroup. So for 35 it stays 21%, 32 to 34 21 to 30%, and less than 32 weeks they are saying that we have to start with 30% or more. So probably we need to adapt these changes while resuscitating our preterm babies. So initial oxygen for resuscitation of term infants exited, but initial room air resuscitation for preterm infants, at least as of now I can say, is not an option. We need to start with higher FiO2s. Similarly, the two-thumb technique and two-finger technique for chest compression. So two-finger technique has slowly become obsolete, and NRP recommends that two-thumb technique is what is recommended. Why? Because this has been found to cause better mean chest compression, and then percentage of chest compression with adequate depth. All these were better with two-thumb technique, and self-perceived CPR quality also was better with two-thumb technique. Hence, this has, the two-finger technique previously traditionally recommended. If it was one resuscitator, you can do two-thumb technique. Two-finger technique has become obsolete. Then the dose of epinephrine, 1 in 1,000 for endotracheal, 1 in 10,000 for IV. It has become 1 in 10,000 for both. So this is also a practice which we need to adapt. Then comes the intervention in NICU. So there are certain interventions which have become obsolete is oxygen administration by hood, because there is unmonitored oxygen delivery to the babies. There is risk of CO2 retention at low flow, and none of us use oxygen by hood, and we have transitioned to either low flow or high flow nasal cannula. The next important intervention, which has significantly changed the practice of treatment for babies born through MSL in babies with meconium aspiration syndrome, is use of CPAP. So traditionally, it was thought that CPAP is a contraindication, and MAS is a contraindication for CPAP because of increased risk for pneumothorax in this disease. But this study from Hyderabad, Dr. Murki's unit, showed that this significantly reduces the incidence of need for mechanical ventilation if CPAP was started early in babies with meconium aspiration syndrome. The selective head cooling for HIE. So we have transitioned to whole body cooling, and selective head cooling is not a preferred mode of cooling, because the whole body has to be cooled uniformly for appropriate results. Then comes the surfactant therapy. In surfactant therapy, we can discuss about timing of surfactant therapy as well as the technique of surfactant therapy. Timing, when it comes to timing of surfactant therapy, we need to talk about whether prophylactic surfactant is beneficial or not. So, because we always say that prevention is better than cure, so if you give surfactant early, probably it should work better for preterm babies. And hence this practice of delivery room surfactant evolved. But the problem with delivery room surfactant or prophylactic surfactant is that you have to intubate the baby and give surfactant. So there is increased risk of BPD. So there can be unnecessary use of surfactant, and obviously there is a need for intubation, mechanical ventilation. So this practice completely changed following these landmark trials wherein they showed that early use of CPAP reduced surfactant usage by almost 50%. So, and hence, delivery room surfactant, the practice of delivery room surfactant totally stopped, and now slowly we have moved on to early rescue surfactant replacement therapy. What about timing? You are saying that selective early rescue surfactant, but how early? How early is early? Do we have an answer? But the things are, the findings are variable. Various studies are used at different time limits, time frames. So, but preferably it should be used less than 2 hours after birth. So once the timing is decided, we need to know what is the best technique of administration, whether we need to do the good old insure technique or we need to move on to other techniques. There are multiple, ways of administering surfactant. But what we need to remember is doing less is more for newborns. So we need to be less invasive in administering surfactant as well. Then slow or delayed enteral feeding. So we have good evidence that early enteral feeding and rapid advancement of feeding does not increase the incidence of NEC, and in fact, it reduces the duration of hospital stay and improves the weight gain. So we should not be conservative anymore in feeding our very low birth weight infants. Then the routines in the NICU. Routine fumigation is not required because it is not going to clear the biofilms which are there on the equipment or surface. It needs a good terminal cleaning. Okay. The routine fumigation has become obsolete. Gowning in NICU because it gives a false sense of security, and people may not be doing good hand washing. They may think that they are, preventing infection by wearing gowns, but actually it is recommended only for special situations like when a child is in contact isolation. Restricted parental visit to NICU was traditionally thought that it may increase risk, but in fact, it is going to improve the outcome of these babies, and hence, we need to adopt these family-centered care in each and every NICU. There are other interventions which are worth mentioning, but whatever may be the intervention, so we need to look at this Gartner hype cycle, where any new change will be followed by a peak of inflated expectations, and there will be a trough of disillusionment. Then there will be a slope of enlightenment, and then finally there will be a plateau of productivity. So similar, these examples will fit in with that. We started with low FiO2 for preterm. Now we are moving towards high FiO2. Again, probably the amnio infusion may come back with recent evidence being available. So after a graceful or not so graceful exit, people do come back. But whether it is helpful or it is going to haunt us, we need to wait and watch. Thank you.
Really true, Dr. Chandra Kumar. Unfortunately, this topic has been preponed to some other, in all these deliberations, very important. And he is gracefully asking us to exit from the old protocols, which is the need of the hour. In fact, it stuck my mind like a nice used stewardship. We follow that. And thank you very much for the wonderful talk. Thank you.
Thank you, sir. I request Dr. Jalil sir to give memento for the Dr. Chandra Kumar sir. I also request Dr. Chandra Kumar sir to give memento to Dr. Jalil sir. The next presentation is going to be Common Mistakes in Delivery Room, a case-based review by Dr. Sai Sunil Kishore sir. And I request Dr. Kishan sir to be the chairperson for the presentation. Good evening, all. I'm happy to introduce our next speaker, Dr. Sai Sunil Kishore sir, who is also my teacher and my mentor. Sir did his MD and DM in neonatology in PGI. Currently, sir working as clinical director and head of the Department of Neonatology in Medicover Hospital for Women and Children, Visakhapatnam. And sir also working as associate professor in MIMS. Sir published almost 35 international national papers and participated as faculty in national neocons and almost 100 workshops and CMEs. Sir got best research award in DM neonatology. Sir is also fellowship coordinator. With this, I welcome sir.
Yeah, thank you, Dr. Kishan, for that kind introduction. Very good evening to you all, and it's a pleasure to interact with you all today here. So, the topic which I'm going to discuss is common mistakes in delivery room. I'm not here to teach any rocket science or discuss the studies. So, just stick to your basics. Don't do any errors in the delivery room. So, that is the main objective. And I think this will give some of the important take-home messages too. So why delivery room errors matter? We know that the golden minute, it determines outcomes for short term as well as long term outcomes, and we know that actually 10% they need assistance and less than 1% they need extensive resuscitation, and the errors actually it can contribute to hypoxia, hypothermia, and a delayed PPV. So that next 15-20 minutes I'm going to discuss these aspects. So during resuscitation, what are the things which can go wrong? Like poor anticipation and poor teamwork, ineffective ventilation, and recently we have this update of 2025. So we should know what are the recent updates this year. And immediate postnatal care within the delivery room, like your unhealthy and age-old practices. So each aspect I'm going to discuss what are the mistakes which can happen and where we can go wrong and what is the correct way of doing it. So you might have seen in many of the nursing homes and delivery rooms, even in its tertiary care center also, like this is the usual storyline and common mistakes which are done. So initially I'll discuss like the immediate care which is being done in a delivery room. So one is immediate cord clamping. In spite of having, though it is standard of care, if you ask 100 nursing homes, so what is the practice rate? So it will be like less than 50% only. So immediate cord clamping is still being practiced, and now actually like delayed cord clamping is the standard of care in each and every unit it has to follow, and WHO, ACOG, and everybody has given strong recommendation. And in the recent update in 2025, actually there is more emphasis. Earlier it used to be like 30 to 60 seconds, but now it is definite 60 seconds. And there is even a little more emphasis on cord milking also. Actually the cord milking was not emphasized earlier, but now actually you can practice more of cord milking also. So in less than 28 weeker, actually it is contraindicated, but 28 to 34 weeks and beyond 34 weeks it can be done. So there is more emphasis on cord milking. And this has got a lot of benefits. Placental transfusion, and not only it will give the volume of the blood, so it will give stem cells as well as immune cells. And in preterms, actually, it will reduce the risk of IVH. It will reduce the risk of hypotension. So preterms have got more benefit as compared to term babies. And most of the units, actually, they do like once the baby is born, they put the baby on radiant warmer. So in spite of repeatedly saying actually like the baby has to be delivered onto the mother's abdomen if it is a baby is vigorous. So this will promote early skin to skin contact and also the breast crawl. So and this early initiation of breastfeeding also it will promote. So receive the baby under radiant warmer only in sick and small babies, in preterm babies. And what about routine suctioning of mouth and nose, even in the setting of no meconium as well as meconium and amniotic fluid? Now, actually, like you should not do routine suctioning. Like you see, like if you are standing there, you will try to do something. So put your mucus sucker in the or suction catheter in the mouth, followed by nose. Okay, so if it's a baby who is vigorous and if the baby is crying, then what is the need for routine suctioning? So suctioning is required only if there is any visible secretions and if there is any obstruction in the airway, only that is the situation where you need. And now, like in vigorous meconium and amniotic fluid also, that routine suctioning is not recommended. And if you do routine suctioning of the mouth and nose, so what can happen is there can be fall of oxygen saturation, and it also can cause vagal stimulation. So because of that, actually, the baby can become bradycardiac, and many times actually your residents will tell baby went into secondary apnea after doing your oral and nasal suctioning. So that is due to the vagal stimulation following your suctioning in a normal baby. So it is simple wiping of the mouth as well as nose is enough rather than doing the suctioning. So most of the nursing homes, they do still they practice this removing vernix. So cosmetic touch is needed, removing vernix and applying oil something. So this should not be practiced. Don't remove, and it's good and it's productive. And patency check by putting a feeding tube in the mouth, nose as well as anal opening. So this is also like not required. No need of routine check unless there is any risk like IUG or any other risk factor, then only it's needed. And routine stomach wash, most of the units still practice, but that is also not needed in the delivery room. No routine stomach wash. And also people think that let's keep hood oxygen for 10 minutes 15 minutes just like that, we'll see later on. So this also should not be practiced, because in preterms it is increased with risk of ROP. So basically what I'm trying to say, like you might have seen 10 practices, actually like we know that it's not needed and these are the common mistakes and errors, still most of the units they practice. So these are to be avoided. So in the delivery room. So these are one set of things which we should know. And now I'm going to discuss the more of resuscitation things. So this is a case scenario where actually there is a high risk mother, IVF pregnancy. There are risk factors of severe PIH, and there is meconium and amniotic fluid also. And your first year DNB resident was present, and baby delivered flat, and baby required resuscitation intubation, which the resident could not do, and baby landed up in asphyxia. So what are the errors here? So no pre-delivery team briefing and no anticipation. So one thing actually which is being emphasized in all the NRP updates is like risk assessment. Risk assessment and your delivery room team briefing, risk anticipation. These are the things which are important, and equipment readiness checklist should be there. So all these things are very important. So correct approach will be something like TAP strategy, like your team, your assessment for the risk factors and preparation. So these are the important things which are required. And checklist driven readiness, like your checklist should be pasted there in the delivery room, and adequate staffing for the anticipated risk factors. So at least one who is completely trained and who knows the NRP well. And many times like you also see this kind of scenario, a preterm baby comes, like baby becomes hypothermic. So like we, from labor room to our OT to NSU itself, actually baby comes hypothermic with 32 33 degrees centigrade temperature. There is no polyethylene wrap, and warmer is not preheated, our transport incubator is not working properly. So what are the mistakes or what are the errors which can happen? So one is like you should have a proper servo controlled warmer, so which may not be there, and the ambient delivery room temperature, it should be adjusted much prior to the delivery, and your polyethylene wrap should be there. So many times actually you see in preterm care, so these are the things which are required, like when compared to your term baby, so these are the extra things which are required in the delivery room. So your polyethylene wraps which should be there, you should be able to receive the baby as soon as the baby is born. It will reduce the insensible water losses, and also it will reduce the hypothermia risk. And delivery room CPAP, so many times what people do is like once the baby is born, so baby like you start giving positive pressure ventilation in preterm babies. So what is required for these babies who is breathing but having retractions is CPAP. So your delivery room CPAP has got many advantages. It will reduce the risk for ventilation. It will reduce the need for surfactant. So definitely like delivery room CPAP should be there. And blender. So in according to the recent update in October 2025, like in babies who are less than 32 weeks, you have to start with more than 30% oxygen. So and like more than 32 weeks, 32 to 36 weeks, you can start 21 to 30%, and term babies you can start with room air. So that is the standard of care. So for that you should have a blender. So then only you will be able to do that. So having blender is very important, and safe transport protocols and working transport incubator again very important. So to prevent brain injury, all these things are to be done in the delivery room. So delayed cord clamping, especially for this is for preterm babies mainly. Delayed cord clamping, gentle suctioning, avoid head down position, and avoid high pressures while giving PPV. Avoid rapid boluses as well as avoid bicarb. So these are all the things which are important to save the preterm brain. And this particular sentence still holds true, because you are standing there, you will keep doing something for the baby. Okay, so this was published in 2005 by Alan Job, who says that there is perhaps nothing more dangerous for preterm lung than anxious physician with an endotracheal tube and bag. So because just you are standing there, you will trying to do something and intubate the baby. Okay, just watch, you optimize your respiratory care, so whether the baby requires a delivery room CPAP or what is it. So many times this happens, ineffective ventilation. So there will be mask leak, airway is not positioned, and increasing the oxygen instead of giving positive pressure ventilation. The baby is not breathing, but people keep on increasing oxygen rather than giving optimal positive pressure ventilation. So what are the errors which can happen? So you should, like MR SOPA, like your mask seal, all those things were not checked properly, and inadequate assessment of chest size. So which is most important thing. So correct approach will be, so check your MR SOPA and ensure proper mask seal and proper head positioning. So these two are very important things while doing positive pressure ventilation. So and pertaining to chest compressions again, so if you are doing with incorrect technique or inadequate depth, so what is the like in the previous session also we had, so now these days actually the two finger technique is obsolete now, so you should not do, you should only use the two thumb technique. And while using two thumb technique also, your positioning of the thumb is very important, and depth is also very important. So many times actually you will do like this, where actually the pressure is not on the precardium, it is laterally placed. Okay, so because of that actually the babies won't improve. So it should be optimal position and optimal depth. So then only the babies will improve. And proper ratio of ventilation to chest compression, and also interruptions in during compressions, like while you do for 10 minutes 10 seconds 15 seconds, again you interrupt, so that should not happen. So it should be complete cycle. So correct compression technique, and the correct ratio. So those things are very important. Another thing is poor team coordination. So sometimes actually twins or triplets are born, and unless you anticipate the problems, unless you do proper team briefing, so it will go very chaos. So if there's no team briefing and no closed loop communication, the problems can occur. So in especially in multiple gestation, there should be clear assignment of roles. There should be proper team briefing. So within just 5 to 10 minutes prior only, like you should tell who is the leader, who is going to manage the airway, who is going to initiate the chest compression, or who is taking care of medications, and who is going to connect the pulse oximeter, like that. Otherwise, if you tell one thing, so all the people will run for that only. So proper team briefing and closed loop communication is very important. So most delivery room errors, they are system failures. Communication is strongest. It's not the technical skill. And you should know ventilation is more important than giving oxygen. Anticipation is more important as compared to the reaction at that particular time. And team is more important than individual. So build a safe delivery system by proper simulation training, mock drills, and having intermittent audit as well as feedback, and QA projects also. So for example, now you know cord clamping, you want to improve the cord clamping rate. So you have a QA project. You can put some posters and you can educate. So there are different components of QA projects, and you have to take it along, and that practice has to be continued. And this is important. Actually, these are some of the changes in 2025, which was published just a couple of months back. So in the initial steps of registration in the delivery room, what are the changes? So there is integration of card management which came up now, which was not there earlier. And there is no need of routine section, they clearly mention. In delayed card clamping, there is more emphasis on the practice and at least for 60 seconds. As I was mentioning, it used to be 30 to 60 seconds earlier, now it is 60 seconds. And milking is like now option for non-vigorous term units with intact cards. So like in depressed baby also, in a term baby, you can milk the card and you can shift the baby onto the radiant warmer. And ventilation rate, earlier it used to be 40 to 60 per minute. Now actually there is a little change, 30 to 60 per minute also you can do. And target saturation table, like which we see conventionally, it starts with 1 minute, 2 minutes, like 5 minutes, like that. So now it starts with 2 minutes, because even if you use the best pulse oximeter probe with signal extraction technology, still actually like it's very difficult to get reliable values within first 1 minute. So it starts with 2 minutes. And initiate oxygen concentration. In very preterm baby, you have to start with relatively higher oxygen. In less than 32 weeks, you start with more than 30%. Earlier, it used to be like all preterms 21 to 30%, and you can escalate based on the saturation value. But it is no longer true in less than 32 weeks, because these babies will have bad lungs. So you have to start more than 30%. And more emphasis is given for laryngeal mask airway also, while giving positive pressure ventilation. And there is definite place for ET tube size too. Like earlier in the standard protocol, actually like less than 1 kg baby, 2.5, that used to be given. But we all know that actually like if you are intubating a 600 or 700 grams babies, 2.5 won't work, and it will cause a lot of glottic edema and subglottic injury subsequently. So we used to practice that only. Like if I'm intubating a 600 gram baby, I'll do with 2 size endotracheal tube. So now it came up. So less than 800 grams, you can consider 2 size endotracheal tube. And more emphasis on communication, better teamwork, and family communications. So these are the top 10 delivery room mistakes which people do: poor anticipation and ineffective ventilation, delayed initiation of PPV, wrong oxygen use, wrong percentage of FiO2, inadequate chest compression, the temperature errors, management errors, deep suction errors, which can lead to vagal stimulation and problems, poor team coordination, and not having checklists. So these are the 10 important mistakes which we should not do. So thank you very much for your patient hearing.
Thank you, sir. Thank you for the wonderful presentation. Questions?
Yeah.
Even that unstable and limp baby, we want to take the baby and resuscitate. If they keep on doing milking, we will be in a hurry to take over the baby, no?
So milking in less than 28 weeks actually definitely contraindicated even now also, because it can increase the risk of intraventricular hemorrhage. So that is there. And earlier actually like people used to worry too much about milking. Now actually what they told is like between 28 to 34 weeks. So you clamp the cord at 30 centimeters and you rapidly milk it, and you just shift the baby onto the radiant warmer. Okay, so for few seconds milking. Yeah, for like babies who are not below 28 weeks. So above that you can do.
Thank you. Now I request Dr. Rahman sir to give a moment of appreciation for this session. Thank you, sir. Now I also request Dr. Sai Kishore sir to give a moment of appreciation for Dr. Kishan sir. Thank you, sir. Thank you all delegates for the patience till attend the end of the session.
There is an inauguration ceremony happening in Hall A. Kindly attend the inauguration ceremony followed by dinner.